Good morning, everybody. Oh, a little anemic. Let's try for something a little bit stronger. Good morning. Good to see all of you. Um, we have, just so you know, we have about 30 people online as well. And I'd say we have something close to that number here in the room with us. Um, it's a beautiful day here in central Pennsylvania. Very glad to be here with all of you. I'm Ken Thompson. I'm the medical director of the uh, Pennsylvania Psychiatric Leadership Council. And we are gathered here today to participate in a conference on reimagining the mental health system, steering the behavioral health system in times of change and turmoil. When we started talking about this planned conference, I believe it was around the time of the elections, might have even been anticipation of the election that we first broached this. But as you all know, the elections turned out as they did, and we are in a particular moment. I want to comment on the fact that 5 years ago, we had a PPLC meeting about a week before the COVID lockdown started. And at that meeting, we were talking about the fact that something was going on. We weren't quite sure what was going to happen. We had the governor come to the conference, and we were all elbow bumping and in all big room together. Within a week and a half, all of that was blown apart. Now, I am not anticipating that things are going to be blown apart in a week and a half, but I do want to say that the things that we are witnessing in Washington, in the country, are of, personally, my own feeling here, of equal magnitude. We are in not normal times. We are in very, very unusual times, and we are in times that I am afraid are going to be much more difficult before they get better. So it's in that context that this meeting today is occurring. We wanted to talk as best we could about what we imagined the challenges would be that we would be facing when we gathered here in April. And I think we have at least been somewhat close to what kinds of challenges we are facing in the mental health world. Not all of it we could anticipate. And through the course of this day, we're going to have, I'm assuming you're Tim. Tim Clement is going to come and speak. And I don't know if, am I going to introduce Tim? Dr. Serta is going to introduce Tim. That's better. But wait, Ken, wait, hold on. You're just standing. Okay. We're going to have a keynote address by Tim, who will be introduced by Dr. Serta in a second. We are going to have several panels following. One, a state update on where are we at this moment and what's happening with the Pennsylvania Behavioral Health Council. We're going to hear a little bit about what's happening at this moment in community behavioral health across the state. We're going to have lunch. Then we're going to get together and talk about some of the challenges that are faced by left behind communities in Pennsylvania. And finally, we're going to end with a panel on building community and the behavioral health workforce with a ending moment of just kind of recapping what we've been through and any observations or thoughts about what we might do next. So that's the layout for the day. Usually somebody will say, in terms of housekeeping, somewhere out there is a bathroom. You can get up and go whenever you need to. It's around the corner. Of course, if you went the other direction, you'd find a bathroom that way too. So I'm not going to waste any more time on that. We will try to run this meeting with as much time for interaction as we possibly can. We will be figuring out how to bring the people who are on online into the conversations, and we'll be using Lucy, who has been our stalwart in making all this stuff happen. She's the one behind the Starship Command over there. And we're going to have, I think, an extraordinarily meaningful and useful day. Most important, what I hope is that we come out of here with some sense of connection with each other, reinforced by the day's activities, and a sense about how we may find some way and some path forward in this moment. So with that, I'm going to introduce Ken Serta, who is professor of psychiatry at Jefferson. How did Einstein get that? Jefferson, and very involved with the American Psychiatric Association and the Pennsylvania Psychiatric Society. Ken, you want to come on up?
Yeah, thanks. Like Ken was saying, I've been involved with organized medicine really since my first experiences with emergency psychiatry in Philadelphia, where we had police officers showing up at emergency rooms with patients they had picked up on 302s who were dead in the back of the police van. And it was a bit of a scandal at the time, and thought the Psychiatric Society should do something about it. So Bill Dubin had asked me to head a committee to take a look at it, and I was hooked on the action we were able to take to get much better training for the police officers. So I've been involved. I'm currently going to be, I'm on the board of the American Psychiatric Association here, but part of the great pleasure I've had in doing this has been the opportunity to work with some very talented individuals who you'll hear from soon. And Tim Clement did his undergraduate and graduate training at Drexel in Philadelphia, and then has worked really in the mental health space since. He was the state legislative policy wonk for the American Psychiatric Association when I was on the board the first time, and was on the Government Relations Committee here in Pennsylvania. Was a fantastic resource for us. We lost him to Mental Health America a couple of years ago, which caused many of us so much consternation. We actually sent a protest letter to the APA board, but he went anyway. I guess we should have sent it to him. He's encyclopedic in his knowledge about mental health policy, as you will hear, and he's been a great advocate for us. Please welcome Tim Clement.
Well, good morning, everyone, and thank you, Dr. Serta. That was a very gracious introduction. So I'm Tim Clement. I'm the Vice President of Federal Government Affairs for Mental Health America. We're the nation's oldest mental health advocacy organization. Been around since 1909. Got affiliates all over the country, including a big one here in Pennsylvania and southeastern Pennsylvania, the Mental Health Partnerships. And so, yes, as Dr. Serta mentioned before, I was at Mental Health America. I was the American Psychiatric Association for 6 years. And before that, I was something called the Kennedy Forum, which was run by former Congressman Patrick Kennedy, who was the lead sponsor of something called the Mental Health Parity and Addiction Equity Act way back in 2008. So what I'm going to do is I'm going to go through, we're going to give you an update on what's happening down in Washington, D.C. That's where I am every day, down the grind on Capitol Hill, and working with the administration as well. As Dr. Thompson mentioned, yes, it's a tumultuous time being down there. Personally, I've known a number of people who lost their jobs because of some of the recent reductions in force through the federal agencies. So what I'm going to do is I'm going to walk through some of that chaos and turmoil that we've seen. I'm also going to walk through what we expect to see in Congress, or the process we expect to see. The outcome we don't know. And as I go, if you have questions at any time, please feel free to just shout them out. And also leave time at the end for questions as well. But if there's anything you think, well, what does that mean, or are you sure about that? Please chime in. So with that, bring up the slides. Okay, there you go. Vice President of Federal Government Affairs. That's my job title. All right, so where to start? Where to start? There's a lot. So Obviously, I think as most of you know, there's been a major reorganization within HHS. We'll talk about that. Probably start with that. Staffing cuts at HHS, particularly SAMHSA. That's probably not probably is certainly going to have a significant impact. Proposed cuts to programs focused on mental health and substance use disorder. There's a leaked document that came out a few weeks ago that had some very, very draconian cuts listed in it. So we'll walk through that. And then Congress. And of course, the big thing in Congress is what's happening right now. It's going to start kicking off this week is the budget reconciliation that Republicans are doing to extend the tax cuts from 2017. And of course, I think as many of you have heard that they're going to try to pay for it by slashing all types of other funding. And I will say this, just I'll give away the game here. The most important thing here that could potentially happen is what happens in Congress. So they're talking about cutting Medicaid potentially up to $880 billion over 10 years. Whether they do that or not remains to be seen, and we'll talk about that. But nothing would have more of a negative impact on behavioral health than extreme Medicaid cuts. And you're hearing a lot of Republicans in Congress, and the media has been a little bit lazy about this, saying we are not going to cut Medicaid. Absolutely not. And I'm going to talk a little bit about that more because you look at some of the statements they're made, they're very carefully worded so that they can say, well, that's not what I meant by not cutting Medicaid. So, but we'll get to that in just a little bit. Okay, so let's start with reorganization within HHS. So in March, Secretary Kennedy, RFK Jr., he announced a major reorganization within HHS. And you look here, all of these things you see on the slide, I'm not going to go through all of them. Of course, SAMHSA, Substance Abuse and Mental Health Services Administration, that's a pretty important one. All these things were technically eliminated. So whether it's SAMHSA, HRSA, AHRQ, Medical Reserve Corps, Prevention and Public Health Fund, all of those things were cut. In other words, the press release said all these things are eliminated. And so you look at that, that's a lot of stuff. Head Start program, NIMHD, like there's a lot of things on here. When you look at how could a government cut the work of all of these things and expect things not to fall apart immediately? Well, so we ask ourselves, does that mean the work of all these entities? Well, no. So despite what you've seen about all these things being cut, the actual work that they do, that's not necessarily being cut because why? Much of the work, one, is folded into different entities within HHS. We'll talk about SAMHSA and how that fits in a second. But there may be, so we'll get this in a second, but the work that most of those entities you saw on the previous slide, all of that work is still going on right now. We'll talk about how, to the extent that work's going on in a minute. But just because all of those agencies and sub-agencies were technically, quote, eliminated, they're not really eliminating the work that they're doing, although there probably will be more specific programmatic cuts that we'll talk about in a few minutes. Okay, so they created a new thing, the Administration for Healthy America. This is part of RFK Jr.'s Make America Healthy Again push. The acronym is AHA. And so SAMHSA, HRSA, and a few CDC programs were folded into this new agency. And within it, it has these official divisions: primary care, maternal and child health, mental health, which of course includes substance use disorder, environmental health, HIV/AIDS, and workforce. So those are the divisions that exist within this new administration. And so SAMHSA was essentially folded into the mental health division. There's a few SAMHSA programs that were put into some of those other divisions, but for the most part, the mental health division within the Administration for a Healthy America, that's where SAMHSA now resides. Okay, so how much does this matter, the reorganization? It's really hard to say. We haven't seen such a huge shift in reorganization. Really, the last time we saw a major shift like this related to mental health and substance use disorder within the federal government was back in 1992 when they created SAMHSA. There used to be a mental health agency that was focused on both mental health services and also mental health research. In 1992, they separated them, creating SAMHSA and also creating NIMH and some of the other NIDA and NIAA. And so that was the last time we saw a major reorganization. And of course, that was through an act of Congress. That was through an act of Congress that had vigorous debate. And I just read through the transcript of one of the hearings, Ted Kennedy, Orrin Hatch. Very cordial civil debate. Lasted for, it was introduced in early 1991. They didn't actually vote on it until the summer of 1992. And it had, passed very easily through the vote. This, however, was just done through a press release on one day. So it's very different what we're seeing than the last time we saw a major reorganization. But like I said, we really can't tell what the effects are going to be because, even though you saw those divisions and sub-agencies eliminated, the work that they do is still is still there within this new agency and within some of the other divisions where it shifted. And the most important thing to understand is the reason why it's not as drastic as it might initially seem to have all those agencies eliminated is most of the work they do is statutorily required. In other words, Congress says you must do this, you must do this, you must do this, you must submit this, you must submit that. All that stuff, there's nothing that the stroke of a pen from a president or secretary can do anything about that. So, and also all of the funding, almost all the funding for these agencies is provided by Congress through the annual appropriations process. The next time we're going to see a crack at that is probably late September or possibly later in the year. They might push it off till the end of the year. Now, of course, there's a big caveat though about the reorganization and whether that matters because you have these statutorily obligated functions for all of those sub-agencies that are now folded into a new agency or other agencies. But there's one big thing. If staffing increases or decreases, well, that is always going to affect the ability of people to do the work that they're statutorily required to do. So let's move to staffing at HHS. Okay, so there was another press release that came out from Secretary Kennedy a few weeks after the reorganization where I think people heard in the early stages of the administration, in late January, early February, we heard about people being basically let go wantonly with no notice, oftentimes maybe in violation of statute and so forth. And there were court injunctions stopping those things. So the administration sometime in March said, maybe we should try this the legal way. And they did what's called a reduction in force, which is they're allowed to do that. And so through this reduction in force, they aim to cut about 20,000. That's a typo there. That's a comma. That should be a comma. They're not trying to reduce it to 62 staff, 62,000. That would be pretty, I would have a different outlook if it was really just 62 people left at HHS. But 82,000 to 62,000, they've already accomplished a lot of that. And the rest of that's, 10,000 people are already definitely gone. And that the other 10,000 are on their way out or will be soon. It's very hard to figure out exactly who's gone, when they're gone, when they left, because when you ask people within these agencies, nobody wants to talk. Nobody wants to, because nobody wants to be next, to be honest. That's a lot of it. And so most of human resources, IT, procurement, and external affairs. So before these staffing cuts, each agency had their own HR, IT, procurement, external affairs. Now they're going to try to do most of that HHS wide. So a lot of the staffing cuts came in those departments. Again, like I just said, the specifics of the positions eliminated, that's very murky. I mean, if I'll have an example with SAMHSA in a minute. A lot of it's you go on the internet and it says that a person has a job, and then you go talk to someone else and then say, no, that person, they were let go. So it's very hard to determine exactly who's let go. We have a pretty good idea, informally and off the record, but it's still not really clear who's in and who's out. We just know a lot of people are out. Oh, and CMS. So CMS, that's a huge, and that's one thing I should note. The one source of funding within HHS, CMS, of course, administers Medicare and Medicaid. That funding is not provided by that's not through the appropriations process. That's mandatory spending, entitlement spending. So that's something that can't be affected by any of this. But CMS, they were spared. They only lost 300 people, which that does sound like a lot, but given the overall staffing at CMS, and the reason that they really didn't see the extent of cuts that other agencies saw was because they had somebody very well placed within within DOGE. That's Elon Musk's Department of Government Efficiency. So it was sort of a, you had someone who would come from CMS, was working in DOGE. He said, no, 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 don't cut my people. And they said, okay, you're the boss, you got it. So that's sort of a, helps lead to just understand how chaotic this has been. Just because somebody had a connection and liked people at CMS, they decided to leave that agency largely unscathed. Okay, so let's talk about SAMHSA. So we know at least 10% of the staff is gone. So there were 900 people going into this administration. That's now down to closer to 800. There's been rumors, and again, this is all very difficult to confirm or deny. There's rumors, though, that it could go down all the way to 50%. In other words, that you might see the staff drop to 400, 450 employees, whereas previously it was 900. So this is something, again, we've been checking in with people to see who exactly was gone, when they're gone. It's very difficult to get anyone to want to talk to you. So 6 of 10 regional offices had their leaders removed, effectively shutting those regional offices. Now, the one that is responsible for Pennsylvania, they still have longtime head Jean Bennett, and she's been there since 2011. She's still there. So if you go on their website, Jean is one of the four out of the 10 regional offices where you do still have the leadership. The other 6 offices, there's nobody. The leadership is there's nobody listed, and also staff at some of those other regional offices has been cut dramatically, effectively making them they're not technically eliminated or shut. But if you've got nobody working there, you really can't do it. They really can't do too much. So more about the staff cuts. So for example, the Center for Mental Health Services, what we understand is that doesn't exist anymore. There's no such thing as a Center for Mental Health Services, even though that's statutorily required. Congress created that center. Dr. Anita Everett, psychiatrist, she was the head of that. We do understand that she is no longer in place. But again, you go on their website, that they still list, there's still a Center for Mental Health Services listed in SAMHSA's website, still lists Dr. Everett as the head. So again, that just shows how chaotic it is. We are basically certain that that center no longer exists. A lot of the staff that work there are no longer there. But it's very hard to actually officially know if that is the case. And there are several other centers that were likely shuttered as well. So now the rumor has it there will be no Senate-confirmed Assistant Secretary for Mental Health. So that's the SAMHSA administrator. Up until 2016, the head of SAMHSA was called the SAMHSA administrator. In 2016, there was something called the 21st Century Cures Act passed Congress, and they created a cabinet-level position for mental health, the Assistant Secretary for Mental Health and Substance Use Disorder, and that person has been the administrator for SAMHSA for the last 8 years. What we've heard is that position is just not going to be filled. And it's not going to be a case where you're going to have an acting, because a lot of times you see in administrations where you have, a secretary or assistant secretary that needs to be confirmed by the Senate. While that process is playing out, you have an acting, acting Secretary of Labor or acting Secretary of Health and Human Services. So, but that's not going to be the case here. There's not going to be an acting Assistant Secretary of Mental Health and Stuff. There's just going to be nobody. They're just not going to fill it. That's what we've heard, and we feel pretty sure that's going to be the case. Somebody named Arthur Kleinschmidt, he's the Principal Deputy Assistant Secretary. He's basically going to be running SAMHSA for the foreseeable future. Again, no Senate confirmation like is statutorily required, but that's why they're not putting him into the actual. They're not nominating for the. Yes, go ahead. I know very little about him, but from the people I've heard that do know about him, he's been there for a while, and he's not necessarily seen as a political hack, for lack of a better term, but not necessarily someone. He's seen as a savvy policy guy, from what I understand. Not necessarily though someone who's had experience like you would expect for the role of administrator. So, but no, but again, it's very little is known, and this is not official. This is just what we've heard and we think is in fact the truth. So that just again shows you sort of the opaque nature of what's going on. We have a pretty good idea this guy's running SAMHSA right now. I mean, let's stop right there. Like, who's running SAMHSA right now? I think this guy. I think he's running SAMHSA. I mean, that's what my lobbyist friends have told me, who are very well connected. By the way, and I should say that we do have one thing that we here in the mental health community have an advantage within all of this, is that Secretary Kennedy, RFK Jr., he is a Kennedy, and his first cousin is Patrick Kennedy, my former boss. who is one of the leading mental health advocates in the country. And he's one of the few Kennedys that never said anything bad about Bobby, as he calls him. And he's managed to meet with him a few times since he was confirmed as the secretary. So we do. That's how we know. That's how we know about this. We know that from filtering out through folks talking to the cousin-to-cousin dialogues. So we're pretty sure this guy's running SAMHSA, but that's not generally how you're supposed to know who's running a federal agency, from what I've heard and seen. So again, lots of chaos. We're not really sure what's going on. And also, I personally know several former coworkers with the American Psychiatric Association lost their jobs that I know personally. In fact, for instance, the Office of Legislative Affairs, that's where, where people in SAMHSA, you need to work with Congress on stuff, so you need to have people whose job it is to go to Congress and talk to them about stuff. Those people don't exist anymore at SAMHSA. Yeah. There you go. That's more than the federal government has told us about them. So, okay. So why is this happening? That's always a question to ask when there's chaos. There has to be a reason, right? What's the rationale? Well, ostensibly, it's to save money and increase efficiency. I think you've heard the Elon Musk and Doge. They're cutting the fat with a chainsaw, and they've saved $7 trillion so far. No, $20 trillion, actually $2 billion, or maybe it was $500 million. Who knows? Overall, HHS cuts. This was in the press release. They were very proud. They touted this. $1.8 billion a year is going to be saved by this, and that is a lot of money. I could use $1.8 billion. I wouldn't mind having that. However, for context, federal spending in 2024, and this includes everything that Congress appropriates, which is about $1.5 trillion. But then the bulk of what the federal government spends is Medicare, Medicaid, and Social Security. And you can't touch that with a chainsaw with an independent advisor. So you look at 1.8 billion, that's less than 0.03% of federal spending. So if you want to cut federal spending, this wouldn't even be a rounding error. Like you don't when you see reports of how much money is being spent, it never goes to the 100th decimal place. It doesn't even usually go to the 10th. So it's something that this is such a minuscule, unnoticeable amount of actual federal savings. And efficiency. So there are some that are, and I'm not talking Elon Musk, I'm talking someone like, there's somebody named Russell Vogt, Stephen Miller, the president's senior advisor. They have this belief that government employees, government bureaucrats are these inefficient, ineffective, lazy slugs who just do a terrible job at whatever they're doing, and we need to cut the fat and make things more efficient. But okay, let's say we believe that. Let's say we believe the 900 people at SAMHSA are these lazy slugs. They don't like to show up at the office. Fridays, forget about that. Okay, so you cut 100 of them. Like, well, how is that going to make things more efficient if you still have the same lazy slugs working there, just there's 100 less of them? And so I don't know the answer to that, but they've apparently got it figured out. Okay, so how much do the cuts matter? So I talked about the reorg. How much does that matter? I don't know. It's very hard to say how much it matters that you change the names of departments, you fold departments in another. That's something that we'll just have to see how it plays out. But with the staffing cuts, probably a lot. Because like I said, most of the work, they have to do it. It's the law that they have to, and we'll give a specific example in a second. They can't just not do it. They can't say, well, we lost these people, so we're not going to do that anymore. You have to. It's the law. There's oversight too. Most of these things that they have to do also require at least biannual reporting to Congress about what in fact did you do. And that also goes along with the appropriations given. So now there's less people to do the work. Not only are there less people, not just less people, it's the people that now have to do the work they've never done that work before and they have no background in it. So like if you said, all right, Tim, well now you're going to be our chemical engineer. I'm like, oh, great. I know nothing about that, but that's kind of what you're seeing here. Like you have people that now have to do things, and that's another thing. I don't know how much direction has been given as to who's going to do what in terms of the people that were gone, who exactly is doing what, and who has the authority to even do that. That's one thing that I've heard from off the record in formal conversations with people at SAMHSA, is that no one's sure who can even say, okay, you do this now. Yeah, I know that these three people were doing this, they're gone. Now, no one's really sure who's allowed to even say that can happen. Okay, so let's do a case study. The National Survey on Drug Use and Health comes out every year. It's statutorily required. Section 505 of the Public Health Service Act requires that this report be produced, and it says what needs to be in it. And so this is a report that's incredibly helpful. It has, everyone's aware of the figures on overdose deaths, suicide deaths. This has dozens of categories of indicators related to mental health, substance use, violence. There's all kinds of things. And so that was formally produced by the Center for Behavioral Health Statistics and Quality, which also is statutorily required. The Section 505 of the Public Health Service Act says there shall be a Center for Behavioral Health Statistics and Quality. So instead of technically eliminating it, which they can't because it's statutorily required, they just fired everybody. So everyone that worked there is no longer there. So that report is that has to, and we in Mental Health America, we have something we call the state of, we do an annual report on indicators of mental health, substance use, well-being, and we rely very heavily on that report. And so the people within our organization that work on it, they have no idea who they're supposed to talk to. They usually before this center was everyone was fired, they would have regular dialogues. When's the report coming out? What are the earliest signals going to be? Can you tell us? They don't know who to talk to now, and nobody else within SAMHSA seems to know the answer either. So who's going to do that work? This is a very important study that people have relied upon for decades, and now someone still has to do it, but who exactly is going to do it? And the answer is we don't know. Okay, so proposed program cuts. So there was a leaked document that came out about 3 weeks ago. It's called a passback document. It's something that agencies like HHS will send to the Office of Management and Budget to say what they're looking at in terms of cuts that would go into the president's budget. So this document's associated with the president's budget. The president's budget was produced every year by every presidential administration, sent to Congress. And what the president's budget represents, it's not binding. So a lot of times you hear a lot of words expended over a president's budget, whether it's this one, whether it's President Biden's, President Trump's budgets, President Obama. Like you hear a lot about the president's budget, but it's just a series of recommendations. Usually it's not necessarily something that Congress, particularly when Congress is controlled by one party and the presidency is another party. The president's budget's a nice talking point document. And that's pretty much it. However, when you do have a situation when one party controls the presidency and the House and the Senate, the president's budget carries a little bit more weight, especially when there's a lot of momentum behind, for instance, in President Trump's first term, I don't not think he didn't have the kind of momentum and support in Congress that he does now. In fact, a majority of Republican House members have only known the Trump era. So in his first term, majority of Republicans in Congress predated him, and they were not within the Trump era of the Republican Party. That's different now, especially in the House. Not so much in the Senate, but in the House, a lot of House Republicans have only known the Trump era, and also a lot of House Republicans, frankly, they know that a tweet from the president could lead to a serious primary challenger that could cost them their seat. I won't list all so if you thought the first slide with all the agencies that were cut was a slide that was busy with lots of things, the actual program cuts within, I should have mentioned that. This leaked document had lots of draconian cuts within HHS and within mental health and substance use disorder. So CCBHC, SAMHSA funding, minority fellowship, crisis response grants, primary and behavioral care integration, assertive community treatment for individuals with serious mental illness, overdose prevention, comprehensive opioid recovery centers, improving access to overdose treatment, a lot more. Also, you look at that list and you think to yourself, how many people in America right now say, yeah, we've got too much overdose prevention going on? I think we need less access to overdose treatment. I don't think there's a lot of people, and I know there aren't a lot of people in Congress that would agree with that. So, in looking at this document, I was very curious into some of the things that were cut or that were listed as being. And remember, this is just a first of all, this is just a draft. It's not president's budget will come out in mid to late May. But two, even that will be just a series of suggestions. But still, why are we suggesting to cut all of these things that seemingly have a lot of, like the overdose, the substance use disorder stuff in particular? I mean, that's been a bipartisan rallying point for the last 8 or 9 years in Congress, and mental health has become that as well within the last 4 or 5 years. So it's something where it's just, I mean, I think one of the reasons I got invited to speak here was I was on a panel on Mindsight News back in December with Tom Insel and a number of other people, and I predicted this wouldn't happen. So it shows what I know. But now that being said, first of all, none of this has happened, and even if the president's budget comes out and has all these cuts, it's not necessarily, that doesn't mean these things will happen. And one thing it does do, though, so the only glimmers of good news, it does retain 988 and all the current levels of funding for that. Same thing for the mental health block grant, substance use block grant, state opioid response grants, which that's a huge number. That's about $1.5 billion each year. Project Ware and a few more. So there were a few. That's one thing. Of all the things we can know and can't know, I can say that if this document says, "Oh yeah, that's fine. We're going to keep that at level funding," that means it probably will be. Because if even this document is saying that's safe, then that means it probably is. Okay, so will the program cuts happen? I really doubt it. I really doubt it because like I just said, there's broad bipartisan support for addressing, first of all, absolutely the opioid epidemic. Also, we saw an improvement in opioid deaths over the last 12-month reporting period we have that ended at the end of September of 2024. Overdose deaths had dropped by about 24%. They're still horrifically high. Still more people than died in the Vietnam War and Korean War combined. I think it was like 84,000 people last year. But a significant improvement from the previous year. So when you're seeing progress like this, ultimately, again, like I said, that document that has all these cuts, that's just a suggestion. If you're in Congress, also, if you're in the House in particular, you're up for re-election every 2 years, are you actually going to want to make all of these cuts to popular bipartisan programs, particularly at a time when we've actually seen improvement in the opioid death toll? And also, we'll talk about this in a minute. Republicans are going to be especially loath to cut mental health and substance use disorder programs at a time when they're probably going to cut Medicaid too, which I said at the beginning, that could have the biggest impact. So for instance, tomorrow, the House Energy and Commerce Committee, and that's the committee that has jurisdiction over Medicaid, they're having a markup. That's a hearing where they consider several bills and several amendments. They're marking up something called the Support Act Reauthorization Act. And that's something that the Support Act was something that was passed in 2018, addressing the opioid epidemic. Lots of programs were created by that. They're holding a markup on it, even though there's no chance it's actually going to pass. And the reason they're doing that, as my Republican consultant has told me, is they just want some cover for potentially, if they're going to make cuts to Medicaid, they want to make sure that their scene is still focusing on the opioid epidemic, the mental health crisis. So that's something that when we get back to what was in that document, the cuts that were suggested, I really just, I can't imagine there's going to be any appetite in Congress, like CCBHCs, Certified Community Behavioral Health Clinics. Those were created back in 2014 in the Protecting Access to Medicare Act of 2014. Started out as a small pilot program. Over the last 5 or 6 years in particular, Congress keeps on putting more and more money into CCBHCs. They're very popular. They don't have their lead champions in Congress anymore. Senators Roy Blunt, Republican from Missouri, Debbie Stabenow, Democrat from Michigan. Those were the two champions for the CCBHCs. They're not there anymore, but it's still something that each of the last several Congress said, we need to give more money to CCBHCs. So eliminating the CCBHC funding from SAMHSA, now they get Medicaid funding as well, which would not be affected by that. I really have a hard time seeing folks in Congress wanting to do that. And also that third bullet point is the most important thing. Congress can and usually does ignore the president's budget. And you think, well, what did I just say about the unified control, presidency, House and Senate controlled by the same party? Well, that was the case in 2017 and 18. And President Trump's budget in both of those years was called for steep cuts. And Congress not only ignored the cuts, they actually added funding to all sorts of things. So it's probably just because there's unified control, that doesn't necessarily mean that Republicans in Congress are going to go along with it, particularly when you're talking about things that have bipartisan support and could be politically perilous to be seen as cutting, overdose prevention programs at a time we still have horrific opioid epidemic, and things have been getting better recently. Also, we'll talk about the partisan push in Congress right now on getting extending the tax cuts and potentially cutting Medicaid, which they can do without any Democratic votes. Appropriations bills, that's what we're talking about. This would be part of the appropriations process where Congress decides how much money each program will get, or if that program will get money. They will need Democratic votes to pass that. Almost certainly in the House, because they have a very small majority, Republicans do, and there are several Republicans that vote no for every appropriations bill that ever comes before Congress. There has not been an appropriations bill passed without Democratic votes in the last Congress and this Congress. And also in the Senate, so the process that Republicans right now are working through in Congress would only require a simple majority to get things through. But with an appropriations bill, they will need 60 votes. And there's only 53 Republicans in the Senate right now. So they will need Democrats to get an appropriations bill over the finish line. The level of cuts we saw in that leaked document, I think there was this was covered in the news about 2 months ago, a month and a half ago, when Democrats had the opportunity to potentially force a government shutdown over an appropriations bill that would just extend the current levels of funding through the end of September. And Leader Schumer took a lot of heat for providing the votes to keep the government open, even though the continuing resolution that they were passing was not good. And there's a lot of pressure for Democrats to stand up and show some fight. It will be different if you have this kind of stuff. If you have these kind of draconian cuts to mental health and substance use disorder programs, if that's on the table at the end of September, I can guarantee you that Democrats probably will shut down the government over that, because that's something very tangible that would have a real world impact that people would see immediately. So that's something that I think that just keep that in mind. As much as the doom and gloom we've heard about some of and I'm not trying to sugarcoat things, but with some of the cuts to programs that we've heard recently, I think it's very unlikely that you'll actually see those cuts. Now, of course, if there's nobody there to do the work that needs to be done, that's, as we covered earlier, that's going to be a problem. But the actual programs themselves, I'm pretty sure that most of them, if not all of them, will survive. Oh, but here's something that's had a real world impact, very negative one. One of our affiliates had to lay off half their staff because of this. So in February, HHS announced they were not going to disperse the $11 billion of funding that had been appropriated by Congress. And they said, well, that was all COVID money, and the pandemic's over, so there's no reason to spend that. However, yes, that funding was part of a COVID bill that passed in 2 Congresses ago. However, the funding that was provided for mental health and substance use disorder, that was not funding that was, okay, this is to address the pandemic. It's like, all right, we're addressing the pandemic. Let's address a bunch of other things too. Here's some money for mental health and substance use disorder. But it was big, and everyone had assumed that this money was going out. $11 billion, that's a lot of money. This is all going to states. And then the freeze or the announcement that it wouldn't be paid out, that caught a lot of people by surprise. And a lot of it was stamps of dollars. Now, a court has blocked that. A court has said, no, that funding has to go out. And allegedly, it is. We've heard that the funding is, I mean, if they're complying with the court order, that funding has to go out. We have heard some issues about complying with court orders in the last few months. But we've been told that and some folks have been getting some of that money. But our affiliate in Wisconsin, for example, they had to lay off half their staff because of the cuts or because of the cancellation of funding. And I'm not sure that they're going to be able to mobilize in time to bring those folks back. Okay, so let's talk Congress. All right, so the big story in Congress right now is budget reconciliation. So let's give a little bit. So generally speaking, in Congress, in the House, it's a simple majority. So there's 435 seats in the House. So if you get 218 votes in the House, bill passes. And right now, there's only 433 House members because of two deaths recently. But in the House, it's a simple, if you get one more than the other, then the opposition, the bill passes. In the Senate, even though it's not actually part of the Constitution or set by any law, long-term tradition and Senate rules say that you need to get 60 votes to pass a bill, or that's where you can override a filibuster, which is when someone talks forever, and they don't actually do filibusters anymore. They just threaten, and people say, all right, if you're going to filibuster, we won't do it. So the 60 vote threshold, that's the normal standard. So that's the standard in, say, appropriations bills, like we were just talking about a minute ago. However, with budget reconciliation, all you need in the Senate is a simple majority. So that can, there's 53 Republicans in the Senate right now. And remember, when if there's a tie in the Senate, the vice president, that's J.D. Vance, gets to decide. So essentially, Republicans have 54 votes right now to play with in the Senate. So that's beyond the simple majority that they would need. And now you can't just put anything into a reconciliation bill. It has to have a direct impact on spending. It either has to cost something or has to save money. So if it's something that has no effect on spending, it can't go within a reconciliation package. And the first step, and this is something that they just did a few weeks ago, right before Congress went on recess 2 weeks ago, you have to pass a budget resolution. And so what a budget resolution does is it says, this is how much money you have to spend, this is how much money you have to save. And it gives specific instructions to each committee in Congress about how much money they either get to spend or they have to cut. So that's the first step. So the budget resolution says these are the targets, and this is how much you have to spend, or this is how much you have to save. And once that happens, they have to hit those targets. So in other words, if for example, and this is the real number, the House Energy and Commerce Committee is responsible for cutting $880 billion. That's what the budget resolution says. They have to do it. They can't say, well, that's too much. Let's do 600 billion. No, they have to get to the target, or else that doesn't comport with the rules. And reconciliation was used to pass the original Tax Cut and Jobs Act that they're looking to extend right now in 2017. Also the American Rescue Plan, the Inflation Reduction Act under the Biden administration. Also, one common misconception is the Affordable Care Act was passed through budget reconciliation. That's not actually true. Most of the Affordable Care Act was passed through at the time, back in 2009, 2010, Democrats, for a time, had 60 Senate seats and a huge majority in the House. Senator Ted Kennedy passed away, and then the Democrats lost that seat in Massachusetts in November of that year. But what they actually ended up doing is they ended up passing a version that passed the Senate when they had 60 votes, and then they used reconciliation to fix a few things. But it was not a reconciliation-only bill like the Tax Cut Bill, American Rescue Plan, or Inflation Reduction Act. Okay, so many of the provisions of the Tax Cut and Jobs Act of 2017, they expire at the end of this year. So that means if nothing happens, if Congress said, well, we're just not going to do anything this year, everyone's taxes would go up starting next year. Now, there's no reason you couldn't do an extension of that with Democrats. Democrats, I don't think, would want to be on the hook for being responsible for people's taxes going up. But the reason Republicans aren't going to do that is they would have to make a lot of difficult concessions with Democrats that they wouldn't want to do if they were to use the regular legislative process, hence budget reconciliation. And also, Republicans want to pass border and security and energy provisions that would not garner Democratic support. So let's step back and say, talk about the why is this happening piece. Why all the things we're hearing about what Republicans in Congress are going to do with budget reconciliation? Why is it? Why are they? Because a lot of what's we've seen in the news is about some of the cuts to Medicaid. We might say, unlike 8 years ago when Republicans were trying to use budget reconciliation to repeal and replace the Affordable Care Act, healthcare, they don't care about healthcare right now. That's not why they're doing this. They're doing this to extend the Tax Cuts and Jobs Act, and also do a bunch of border and energy stuff that they could never get Democrat support for. So that's why they're doing it. But in order to do that, and we'll explain in another slide, like you can see the projected price tag for that is $4.5 trillion over 10 years. So if you want to extend the tax cuts, and if you want to do some of the border and energy stuff, but mostly the tax cuts, that's going to add $4.5 trillion to in federal spending. So hardliners in Congress, particularly the House Freedom Caucus and a few others, they are adamant that this has to be offset. In other words, if you're going to spend $4.5 trillion, you got to cut $4.5 trillion somewhere else, or you at least have to cut something substantial close to that. And as we said earlier, the Republicans have a very small majority in the House. And so that's why. So just stepping back a bit, the reason why we're talking about because if you think back to 2017, like no, wait a minute, they passed this Tax Cut and Jobs Act in 2017. And you're saying now to extend that, it's going to cost $4.5 trillion, and they have to offset the cost. How come I didn't hear anything about offsetting the cost in 2017? Did they find something to offset the cost that we just didn't hear about? Some wonderful source of cuts that doesn't hurt anyone? No, they just didn't pay for it. The Tax Cut and Jobs Act 2017 just added to the deficit. And nobody was all that concerned at the time. There were some that were concerned, but you have to remember back in 2017, when the Tax Cut and Jobs Act passed, Republicans had a pretty large majority in the House. So when you have the Freedom Caucus types that say you have to pay for this stuff, they just said, all right, thanks guys, we'll see after the vote. And so this time, however, they can't do that because if they lose, right now because of the 2 deaths to Democratic seats that have not been filled yet, they can lose 3 people. 3 people can vote no, 3 Republicans can vote no for a bill, and it can still pass. But if they lose 4 people, it can't pass. And there's more than 4 hardline conservatives that will not vote for something that doesn't have significant cuts in it. Or at least so they say right now. Okay, so the budget resolution, it passed. So that's the thing that sets how much money has to be spent originally or cut. It originally passed in February through the House. And that's the thing, with reconciliation bills, they all have to originate in the House, technically speaking. The Senate significantly modified it and passed it on April 5th, and then it passed through the House again on the 10th, 3 weeks ago. It passed 216 to 214. 2 Republicans did vote no for it. Congressman Tom Massey and Congresswoman Victoria Spartz. Tom Massey essentially votes no for every bill that comes up for a vote in Congress. Yeah, you have to give him credit. He's very consistent with what he does, and he will almost certainly be a no vote on the final product. So we've already said Republicans can only lose 3 votes. Looks like they can probably only lose 2. And I was seeing something this morning that they're thinking that Victoria Spartz is also going to just hold out and be a no vote. So now looks like you're looking at operating in a margin of 1 or 2 votes. So I will unpack a little bit about it. It's a very unusual budget resolution. You know how I said, but the budget resolution says how much each committee has to cut? What has different levels for Senate and House. So in the House Energy and Commerce Committee has jurisdiction over Medicaid. In the Senate Finance Committee has jurisdiction over Medicaid. So the House Energy and Commerce is directed to cut $880 billion over 10 years. How much is Senate Finance directed to cut? $1 billion. That's almost nothing. So the Senate and House have different numbers, and that essentially could matter a lot in the end, which basically gives them a lot more flexibility. So in other words, yes, the House has to come up with $880 billion in cuts for energy and commerce. Senate doesn't have to do that. And there's a lot of stuff, and there's all kinds of other cuts. The supplemental nutrition, formerly known as food stamps, that's potentially on the chopping block. But we're just going to stick to healthcare for now. Okay, so let's talk about Medicaid. So we've sort of buried the lead, or I did mention up front. This is the most important thing that's going on right now. Yes, the chaos in the administration that you're seeing within the agencies, the reorganization, the staffing cuts, that's a big deal. But what's going to happen with Medicaid, that could potentially have the most serious impact on, because remember, Medicaid is the largest payer for mental health and substance use disorder services. It covers about 25% of paying for mental health and substance use disorder services. So, okay, so we said $880 billion over 10 years. I think some folks have focused on the fact that the budget resolution didn't say anything about Medicaid. Didn't actually say that there's going to be $880 billion in cuts to Medicaid, but $880 billion within House Energy and Commerce, which Medicaid is within that jurisdiction. So if the committee said, all right, let's cut everything else under energy and commerce jurisdiction to nothing. We're just going to cut everything out. They'd still have to cut $550 billion from Medicaid and the Children's Health Insurance Program to get to that $880 billion target, or about $450 billion of Medicaid to get to that target. So it's just not possible. You cannot get to that $880 billion number without cutting Medicaid. There's no way. It's not mathematically possible. However, on the Senate side, they only have to cut $1 billion over 10 years. So the Senate committee with jurisdiction over Medicaid could essentially do nothing. They could essentially cut nothing, and that's what I think a lot of senators might prefer to see. Okay, so over the last several months, and really since after the election, even before this Congress was sworn in and President Trump was inaugurated, there's been a big push from a lot of advocacy groups, my organization, many other mental health and substance use organizations, many healthcare and consumer and family organizations, focusing on saying, don't cut Medicaid. Don't cut Medicaid. That's been a consistent message, and it's being heard. People are hearing that message. It's being heard. It's being shouted at people in town halls and things like that. And really, most Republicans in Congress, like I said earlier, this isn't like trying to repeal the Affordable Care Act. This is not. They don't want this to be a healthcare process. They just want to extend the tax cuts, do border and energy, and call it a day. However, because of those thin majorities they have, the hardliners were cornered leadership and basically forced them into this. If Republicans had a 30 or 40 vote margin, they wouldn't have this. They wouldn't have these steep cuts, because most members they remember how things went 8 years ago. And remember, the Affordable Care Act repeal and replace, a lot of that was about Medicaid. Back then, the proposal on the table was to turn Medicaid into a block grant, where just a certain amount of money would be appropriated to states rather than the entitlement program that it is now and has been since 1965. They were fundamentally going to reshape the Medicaid program in a way that would have led to significant, many people losing insurance coverage. Republicans remember how messy and ugly that was, and ultimately unsuccessful. They didn't want to have to do that, but the hardliners have backed them in a corner. And basically, and you look at what the last slide says. Many Republicans have taken to say, no, the budget resolution, it doesn't say anything about Medicaid. Why are people slandering us by saying that we're going to cut Medicaid? Where do you see Medicaid in this budget? It doesn't say Medicaid. What are you talking about? However, as we said before, it's mathematically impossible. You can't come up to that $880 billion figure without significant Medicaid cuts. Now, we just talked about the hardliners. What about the moderates? What about the ones that are a little squeamish about this, in particular from swing districts or where they have a huge Medicaid population? What they said, and this isn't a joke. What they said to them is, "Don't worry, vote for it, and the Senate will never let it happen." So that was basically what they said. Just vote for all this stuff that looks bad, and then the Senate's going to save you. And now the reason for that is the senators, and you saw that in the budget resolution, had very different figures for what the Senate has to cut. Senators, they don't want to do this. And there have been several senators coming out on record, Republican senators, pretty strongly saying that they aren't going to go along with those Medicaid cuts. So the end result, we hear about $880 billion in cuts. And then I just mentioned it could be $1 billion in cuts over 10 years. The end product is going to be somewhere, it's not going to be $880 billion, and it's not going to be $1 billion. So it's definitely going to be, there's going to be some amount of cutting to Medicaid, but it's probably not going to be at the high end of that number, although it could be close to that end. We'll see. So now this last bullet point, this bullet point has annoyed me, or the substance of the bullet point of why I put it on there has annoyed me. So I've seen a lot in the press over the last month, like Congressperson so-and-so says, we won't cut Medicaid. Absolutely not. I'm not going along with Medicaid cuts. No, I will not cut a single penny from Medicaid. But then they word it in a way where they say, I am not cutting Medicaid for people with disabilities, the elderly, women with children. I am not cutting traditional, they say traditional. This thing called traditional Medicaid. I've heard a lot about this. I do. If you look within Medicaid statute in the United States Code, the word traditional Medicaid doesn't exist. Why? And the reason they're saying that is they want to word things in a way so that when they make drastic cuts to Medicaid expansion, they can say, well, I never said that. That's not real Medicaid. That's not traditional Medicaid. That's not for vulnerable people. And if you remember, Medicaid expansion, that was part of the Affordable Care Act. So most Republican members of Congress were never on board with that in the first place. All right, but what will it look like? What will we see if we see so the first bullet point, that is a given. We will see work requirements in the Medicaid program. If a bill passes, if they are successful, and they probably will be, just to level set here, they're probably going to be successful, because if they don't, everyone's taxes go up. And generally speaking, Republicans have not caused taxes to go up since George H.W. Bush said, "Read my lips, no new taxes." Then there were new taxes. So that was the last time we saw Republicans raise taxes. So you are going to see a bill pass, and work requirements will be in it. Nobody disagrees about that. That's something that you look into the research on work requirements. First of all, most people on Medicaid already are working, and it's been shown that work requirements don't actually lead to more people working, and it leads to people being disenrolled from Medicaid that were working or would have qualified for exemptions. They just couldn't figure out how to navigate the process. But that debate's over. No one's debating that in the Republican Party right now. Work requirements, that will happen, and that will save about $100 billion over 10 years due to people being pushed off for not meeting the work requirements or the paperwork requirements. The main thing I just mentioned, Medicaid expansion, though, that's what they're targeting. So it's the work requirements, and then Medicaid expansion. The last bullet point is not Medicaid expansion. So we'll talk about that too. But right now, so Medicaid expansion, the federal government pays 90% of the cost for the Medicaid expansion population. Whereas the normal federal matching rate is anywhere between 50% and 83%. That's set by statute, depending on the state's wealth. So if you're a state like California or New York, you pay the federal government pays 50%. If you're Mississippi, the federal government pays about 78%. So what Republicans in Congress are talking about, or whispering about, or not talking about publicly, but writing down in private notes, is reducing the share, that 90% figure, to either something lower or something that is actually right at the state's normal matching rate. So if they did this, Medicaid expansion rate in New York would go from 90% to 50%. What this would do is this would almost certainly end Medicaid expansion. States can't afford to pay that. That's why it was set at 90%. The reason Medicaid expansion existed in the first place was to do something about the 50 million or so people that didn't have health insurance. Do that. Do you have a question? Yeah. So well, you have a microphone now. Go ahead.
Mike on the
There you
mic.
go.
Can you hear me okay now?
Yes.
Okay, so great slide. For Pennsylvania, our FMAP in that sliding scale there is 54%, meaning the feds pick up 54 cents of every Medicaid dollar. So going from that 90% down to 54 for a population of about 800,000 individuals would be about $2.7 billion.
Yeah, and the state could not make that up. The state could
Annually.
not cover
State
that.
can't make that up because the state already has its own state-related fiscal challenges. So that would be completely destabilizing, as you said. So just a little finer point there. So
Yeah, and most states, I'm almost certain Pennsylvania is one of them, have to have a balanced budget. And so if you have to have a balanced budget, you already have a problem right now, like Pennsylvania does, and you have another 2.7 billion, you can't do it. So that would almost certainly lead to Medicaid expansion and ceasing to exist. There's over 10 states that have laws that say the instant that federal matching rate goes below 90%, this is over. Like, and most of them are red states, which might matter politically. A more likely thing, though, is per capita caps. In other words, this is how much money can be spent on individuals in Medicaid expansion. That would not immediately lead to the program Medicaid expansion ceasing to exist, and it probably would survive that, but you would probably see lower enrollment, limited benefits, or lower provider reimbursement. So it would be a negative effect. The last piece, states use provider taxes to pay for some of their Medicaid services, and I won't go to the ins and outs of it because I don't even fully understand it. But they're targeting the Congress is targeting potentially eliminating states' ability to do that. And what that would essentially do is eventually states would be able to pay less. They wouldn't have as much money to spend on Medicaid, and therefore the federal government would eventually have to spend less money. I think that's actually probably the most likely thing that they're going to do, because it would not have an immediate effect, it wouldn't target any specific population, and it would essentially starve the program at the state level, which would then lead to lower federal spending. So that's probably more likely than the other two regarding the expansion, but the expansion thing is definitely still in play. Okay, so what's the outcome? Tough to say, but May 7th, House Energy and Commerce Committee is marking up the first version of getting, and they have to hit $880 billion. So you will see $880 billion in cuts on May 7th. So that's when the rubber hits the road. Up until now, it's all been theoretical. Well, no one's cutting Medicaid. No one's cutting Medicaid. But when that draft comes out, we'll actually see what is going to happen. And also importantly, Republican governors and Republican state legislators will see what's happening too. And you have to, there's a number of Republican governors in states that have expanded Medicaid where there would be a huge budget hole if suddenly they had to pay for it. So if you see something to the Medicaid expansion, like significant cuts to that in this draft, that's when you might start hearing Republican governors, if not publicly, but behind the scenes, lobbying Congress to say, don't do this. This will decimate our state. Please don't do this. Okay, so we talked about how the hardliners backed leadership into a corner. Hardliners can't lose they're in districts where they most of them are in districts where they win by 40 or 50 points. The moderates, if there's actually $880 billion in cuts to Medicaid, most moderates in swing districts will lose their seats. So if you're a moderate, this is an existential thing. And now, they've been talking about the expansion population, is that somehow different? I think when we get to the end of this, I think that moderates are going to realize that cutting Medicaid expansion, especially if you're in New Jersey, if you're in Pennsylvania, there are several swing districts in Pennsylvania and New Jersey that you have moderates that have been a little bit squeamish on this. They could lose their seats. So the question is, who's going to blink? Who's going to say? Because the hardliners, they blinked. They blinked when the budget resolution passed. About 10 of them said, "No, I'm not voting for this. I'm not voting for this," and then they voted for it, based on promises they said they got that they probably didn't get. The end result is President Trump will have to weigh in and basically settle this. That's the only way. So if the moderates seem to have the upper hand, and also President Trump, I've seen reporting, he does not want this to be a health care bill. He doesn't taxes, border, energy. My sense is he'll probably side with the moderates, but who knows? You never can know in trying to potentially predict what President Trump will do. But that's likely who's going to settle this. Are we going to see $880 billion in cuts or almost nothing? I think President Trump will be the one that weighs in on that. I would guess it's probably to be closer to the lower end than the higher end, just because of the potential that it could have on the moderates, and also the potential, the disdain a lot of Republicans in Congress have for those hardliners. Okay, last slide here. There are other things that will happen in Congress this year, but until reconciliation is out of the way, there will be I've got several bipartisan bills in Congress that I've been working on, and I've been told point blank, we're just not going to pay attention to this until the reconciliation is over. So until that's over, you're hearing different things in the timeline. It's Memorial Day, probably not June, probably not July, maybe. September, it has to be done by the end of September, just because the budget resolution instructed them that's when their deadline is. So this will be over by the end of September. When this is over, Support Act reauthorization, that's for the many programs designed to address the opioid epidemic. That certainly will pass by at some point this Congress, if not later this year. Annual appropriations bill that we talked about that will need Democratic votes. The deadline's September 30th, but if they don't get reconciliation out of the way until, say, early September, what they'll do is they'll pass what's called a continuing resolution, which says just keep on spending what you've been spending for X amount of time, and they'll probably kick it into December, and we'll probably see an appropriations bill in December. Also, there was a huge healthcare package that had the Support Act in it, and a bunch of other stuff, PBM reform, some Medicare Advantage pieces, that was agreed to by House and Senate leadership, and then Elon Musk went on a tweet storm 160 tweets he filed that day that basically killed that. And early in this Congress, we thought there was a chance that could be picked up and passed, but now that looks like that's not going to happen because they might be using some of that legislation. Some of that legislation had cost savings in it. They're looking to put that into the reconciliation to help pay for that bill. But some of those pieces will have a chance to be put on some packages. But basically, nothing happens in Congress except for reconciliation until they're done with reconciliation. So we'll have to. Usually, Congress actually functions in a pretty bipartisan way. But that will not be the case until after they're done with the very partisan reconciliation bill. Okay, and that's it. That's my contact information. I know we're at time, but any further questions? Oh, yes.
That was an extraordinary presentation, and I really appreciate the clarity out of the chaos that you've been able to get across to us, and while maintaining some sense of the chaos in it. I have two questions, and you don't have to answer both because we don't have time, but you can choose which one you want. The first is, how the hell do you stay sane in this process? That would be maybe the first, but the second one is kind of in that context. You started by talking about the reorganization of HHS and the limited capacity for that to have been explained or in any kind of way rationalized. Um, how much is the feeling in Washington that the sort of unusual, well, not, I don't want to use the word unusual, the normal processes of Congress, which you've kind of been outlining to us, these are not abnormal processes. They're sort of normal processes. The abnormal stuff is not spending the appropriations.
Yes.
It's the those kinds of, eliminating people, doing all the kind of crazy stuff that's gone on. How much do people in Washington, and yourself in particular, think that what's going to drive this is some capacity for normality to reign in Congress, to do whatever it's going to do, and for the American electorate to do whatever it does? Or are we looking at the just sheer chaos and power grabs of the Trump regime administration? How much can we rely on sanity? So either one of those two questions.
Well, my own sanity, I just keep my head down and okay. Well, here's part of how, like, as far as Congress is concerned, I wouldn't, if I'd been in a coma for the last 6 months, I wouldn't think that anything was different in terms of, yeah, there's a reconciliation bill going on and all that, but like that happens anytime. That happened 4 years ago right now. And Democrats had already passed a reconciliation bill, the American Rescue Plan, in March of 2021. That's just what Congress does when you have a majority and you have the presidency. And even though the bipartisan bills that I work on, nothing's going to happen with them until after people talk to me about them. So I still go to Republican offices, Democratic offices, and say, oh, this bill would allow states to spend this money on the block grant, blah 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 blah. And people, they're good. So in Congress, everything's completely normal. There's no chaos in Congress. It's very normal. I mean, the only reason you see Congress being at a standstill is because of the very small majorities that they have on the House side. So that's normal. And yes, the abnormal, people in Washington they've been freaked out about what's happening in the administration. However, there's been a series of setbacks in court. And while we've heard about, potential not complying with court orders, most of the healthcare related, not most, all of the healthcare related stuff, they have been complying with that. So I do think that by the time we get to the end of this Congress, we'll have seen a lot of stuff within the administration settle down. Also, the popularity ratings for the president and they've gone down significantly, and that always has a potentially moderating effect, particularly as you get closer to a midterm election when potential vulnerable members can get wiped out. You want to show maybe some level of independence. So I can't tell you that things are going to, I would say this, I wouldn't be shocked if we're back to the level of normality or normalcy that we saw in the first Trump administration, the first 2 years of that. How normal is that? I'll leave that question open. But I think we may be getting back to that. The shock and awe that we've seen for the last 2.5 months or 3 months, that may settle down a bit. But we don't know. That's the feeling in Washington. Nobody knows. And some people feel very differently than me. Some people feel like we won't have elections in 2026. I don't think that's the case, but there's a wide range of feelings there. Okay, well, I know we're at time, so thank you very much, everyone. Oh,
I believe we have one online.
So Laura Jordan asked, does anyone know how medical assistance for workers with disabilities will be affected by the Medicaid cuts?
that will not be affected. So that's the one thing that they're not going to cut anything for people with disabilities. It's just the expansion population that's probably going to face cuts.
Okay. Well, Tim, thank you again so much for your knowledge
you.
and sharing with
Thank
us this morning. We're going to take about a 10-minute break. We'll meet back here at 10 a.m. for our first panel.
So I was thinking of what we can do to try to transition from the national perspective to a state perspective. Last night, for those of you that were with us, Ken Thompson sort of challenged us to think about what we can do at the state because of all these things that are happening at the federal level. But I feel as the moderator for this panel, I should let you know that I've downloaded the Signal app and I'm looking for a text from Pete Hegsteth just in case there's some updates. So I'll let you know if I get anything. I'm Stan Morzowski. I'm a consultant with PCPA or with Pennsylvania Psychiatric Leadership Council.
I got you
You have me. Lynn and I were talking about PCPA a little while ago. And it's my honor to facilitate this panel in which we're trying to understand what the Governor's Council on Behavioral Health is all about, what the advisory committee is doing, and to see what we can do as an organization and as individuals. And we're lucky to have two people that have had some personal experience with the advisory council. And so we want to hear from them and see then what we can do. So I think I can begin by saying that I'll ask Lynn and Jennifer to introduce themselves as we go along. That the Behavioral Health Council was established by the governor in. Thank you. And I probably have to turn it on.
There we go.
Thank you all. Behavioral Health Council established by the governor in October 2023 to ensure that the state agencies are working together to improve mental health delivery and recovery services and are not operating in silos. The specific charge to the council was to develop and recommend to the governor a statewide action plan to address gaps in affordability, access, and delivery of services, removing the silos that I earlier referenced, and decrease wait time. This council's work is supposed to center on new and innovative care models, workforce challenges, related social needs and inequities. I think this social determinants of health issue there. Collaboration between criminal justice, public safety, public health organizations. And then specific recommendations to decrease the wait time for services in both mental health and substance use. The structure, Dr. Christine Finello, some of you remember we had her come to this group, was it about a year ago, Val? Yeah. 33 members, much of I think almost all of the state agency directors. So the Department of Human Services, insurance, education, as well as county and local governments, provider community representation, advocacy, and individuals with lived experience. Again, another charge was a more holistic healthcare delivery system. And then there was an advisory committee established. I think it's 25 members. Does that sound still about right? To support the council, and to elevate issues from various communities. Now, a bit of a sore spot, Pennsylvania Psychiatric Leadership Council had requested, we proposed that one of our members would be part of this advisory committee. We weren't selected, but talking to Lynn and Jen earlier, there were a lot of people that wanted to be part of this, and not everyone could be included. So I tried to figure out like what's the most recent update, and then of course I want to have Lynn and Jen speak to this. But the most recent minutes that are published, and you can go and see the minutes of each of their meetings. They're not Lloyd Wirtz minutes. Lloyd would give us 3 or 4 or 5 pages of an hour meeting. They maybe give 3 or 4 lines of their meeting. So these are the minutes from the December 2024 meeting. That there was a draft list of recommendations and recommendations and tactics, which the group discussed. Then Dr. Finello led a brainstorming session on the ideal system of care. The council members generated a list of additional topics, and that would be covered through meetings through this year, 2025, with the goal of a complete and comprehensive report. As far as I know, there's no projected timeline when that report. So that's the update. Let me just first see if there are any questions about kind of this basic structure. Go ahead, Lloyd.
You cannot. That's right.
A 5-page report. Okay. Just making sure. Thanks.
Okay, so part of our goal of this panel is so you understand the structure. With that now, I'm going to ask Jennifer to introduce herself and give a little personal perspective on what you've been doing and what it's all about.
Absolutely. Hi, can you hear me? Is this working? Okay, great. I'm Jennifer Jordan, Vice President of Equity and Behavioral Health at the Hospital and Health System Association of Pennsylvania. HAP represents hospitals and health systems across Pennsylvania. We are the member services and advocacy organization for hospitals and their community, striving for better health. HAP also represents over 235 emergency departments in communities across Pennsylvania, as well as psych units and freestanding psychiatric hospitals. So HAP as an organization really has a diverse perspective on behavioral health in the current system. I thought it would be helpful for me to talk a bit about some of the policy goals and aspirations that HAP is bringing into the space. I participate in the advisory committee as the HAP representative to bring a hospital voice to the conversation. And I think that it's both what I'm going to talk about and then also what Lynn talks about that really starts to speak to the diversity of stakeholders who are currently convened around this innovation and policy process, which is both the challenge and the opportunity of having a really wide table to think about systems change in Pennsylvania. So Dr. Kunkel is on the HAP board and could talk more about the sausage making that we do at the association to come together around behavioral health goals. But I must say that overarching the stressors that kind of drive HAP as an organization and our hospitals writ large have to do with sustainability. And you just heard Tim talk about all of the threats there to hospital operations and the ability to survive in the landscape that we're in and headed into. So I think that when you think about behavioral health within that process, I do think that we're at a place where hospitals understand that the behavioral health of their patient population is a core need to their operations. I think that, maybe pre-COVID, that perspective was differing across the hospital community. Some of our hospitals have actual mental health capacity and psychiatric capacity, others don't. Everyone has an ED. And so I think that at this point we understand access to meaningful behavioral health services as a key need for every community. So when we're thinking at HAP about behavioral health policy, I think that the ED focus is really driving a lot of my work and where we are as an association, thinking about opportunities for diversion, opportunities for timely access to crisis care, and HAP is definitely supporting Pennsylvania's crisis services rollout or buildup. So there will be alternatives for timely, high-quality crisis care for every community. Additionally, we're thinking about that end disposition and the discharge delays that happen when folks are ready to go to other care settings and those settings aren't available. I'm working closely with Lynn to think about behavioral health, SUD, and mental health access for our community members who live in nursing facilities across the Commonwealth, and the ability to discharge from inpatient acute psychiatric stays to supportive nursing facility communities. And looking and exploring and pushing, I'd say pushing opportunities to expand capacity where people actually live. So there are more community based options for older adults in Pennsylvania. I think that is what we're bringing to the conversation as we sit with all sorts of folks with different perspectives on the behavioral health and mental health and SUD system. HAP is there really thinking about some of the things that drive kind of operations and throughput in our hospitals and bringing that perspective to the conversation.
My name, as you heard, is Lynn Cooper. I'm the Behavioral Health Policy Specialist at the Pennsylvania Association of. How about that? Is that better? Thank you. I hate these things. I don't know how you guys feel, but I know they're necessary. So thank you for the help. I'm the Behavioral Health Policy Specialist at the Pennsylvania Association of Area Agencies on Aging. And I was hired about 4 years ago to help the AAAs, which there are 52 across the Commonwealth, and every county has one, access to a AAA. They have been having very serious problems accessing mental health services for the older adults they serve. And there's all kinds of reasons why that problem exists. But I was hired about 4 years ago to help them. One of our biggest problems was in the crisis programs, but we're doing a whole lot better. I do want to say that. My background is that I worked for what often people know as PCPA, RCPA. I spent most of my years working for PCPA, which is the Pennsylvania Community Providers Association. And I was at RCPA and worked for RCPA for about 4 years after the merger took place. And I worked there for 26 years, and 10 of those years I was the deputy director and enjoyed every minute of the policy work that we were doing. I think that my reason for being there is because our secretary for the Department of Aging insisted that I be there, and the Department of Aging keenly understands the problems of access to mental health and substance use disorder for older adults. Couple of things I want to say. First is that I know there were a lot of people who wanted to be on the council or the advisory committee. That's another thing. Jennifer and I both sit on the advisory committee, not the primary council. And then the other very important message I want to send, and Jennifer alluded to it also, we are not here on behalf of the Behavioral Health Council or the Behavioral Health Advisory Committee. And I promised I would say that. So, not that anybody's worried about what Jennifer and I are going to say, but, you know, they might be. The council, one thing we know is it will continue. There was speculation that the council would only function for 1 year till the end of December. Then there would be a report and work to implement the recommendations. That's definitely not the case. As you can see, we're already into April. There will be at least 5 more meetings of the council. Most of our meetings have been spent just collecting data and hearing reports from folks from all over the Commonwealth. And I don't know if you've, but I mean, the list of topics, Jennifer and I were just meeting last night talking about it. I mean, it's ideal system of care, lots of time spent on insurance and reimbursement, regulatory and licensing, ideal crisis structure, children and adolescents, of course, workforce. I have them here if anybody wants to see the full list. Those are the topics that have already been covered. What's coming up, we're very excited about it, is in my part of the world, there's going to be one entire session devoted to the needs of older adults. So we're very much looking forward to that. Apparently, once these 5 meetings are completed, then the group will be working on, there is a list and there is a preliminary list of priorities, recommendations that are being reviewed right now. They're not ready for public distribution, but they will be. What's going to happen is those recommendations are going to be fine-tuned, and the new topics, of course, that are covered will be added to that piece of work. It'll be approved by the council and the advisory committee, and then it will go out for public comment. So please know that you will certainly have an opportunity to provide comment on what those recommendations look like. I can tell you right now, I mean, a lot of them are very complex, and because they include all kinds of regulatory issues and legislative issues, it's amazing. But another thing that I definitely wanted to share is, and I guess I'm bragging a little bit, is that we had 9 recommendations from the council that actually made it into the governor's budget. One was the 10 million. Now, of course, there were other folks that were lobbying for these things too, so I don't want to take full credit. I mean, not me, but the council anyway. See why I had to make that statement right up front? 10 million to expand primary care loan repayment, 20 million, of course, the base funding for county mental health, the 10 million to support 988, 5 million for maintaining mental health walk-in crisis, 4 million to develop an all-payer claims database. And if you have any questions about that, I'll have to get back to you, because I have no idea what that is, but maybe somebody in this room does. Directing the Department of Health to work with healthcare providers to implement universal postpartum screenings, call for the end of the loophole that allows insurance companies, I especially love this one, to deny coverage of mental health services delivered within the walls of the school. 4.8 million to provide seamless medical assistance coverage to assist Pennsylvanians entering the community. And this is all about incarceration, people coming out of the prisons and providing them MA accessible to them 90 days prior to leaving. I know at RCPA, we spent a great deal of time because many of the folks that are suffering with mental health problems, especially substance use disorder problems, do find themselves in the criminal justice system. And so that's a very big piece. And then last is 1.6 million for community hospital integration project, the CHIP, which has always been an important part of what we do, but allowing for 20 more individuals to be supported. But in terms of once this report is complete, we've been told that this group, which, you know, we didn't know this in the beginning, I need you to know, but that we will be working together as a, and it is huge, even though it might seem like it's only 25, but when you include the council, and that doesn't even include, you know, a lot of the state folks that are a part of this, we will be putting together ways in which we can implement the recommendation. And the 5 major areas are legislative, funding, policy, regulatory, and administrative. Those are, and I know when I worked for RCPA for many times I shared with my provider members that from all that we could see, there was no new funding. You know, I would have to say to them, there is no new funding. You can pay me to go out there and, you know, beat the drum for more money, but you need to know there's not more money available. Nobody liked to hear that, of course, but what I think is important is that we look at a lot of these other areas. One of the ways that we had always been able to be effective at saving our providers money was through regulatory changes. And one of the big ones was the outpatient, psychiatric outpatient regs, which we were able to make some Deb Shoemaker, in fact, was a major part of that work. And we made a big difference. The problem is, it took 13 years from the time we wrote the first white paper until 2019 when the regulations were published. So one of the things that we're going to be advocating very much for is to improve the regulatory process and that timing. Nothing should take 13 years to get passed, especially when we had all the players at the table and they all agreed. The Psychological Association, the hospitals, everybody was there. It shouldn't take that long. Anyway, I'll be quiet now and see if there are any other questions.
Well, thanks for both of you for
Sure.
explaining that. Lynn, could you elaborate a little bit more? The report of the council will be sometime perhaps this year. I mean, there's 5 more meetings and you're discussing, as you said, very complicated kinds of things. When the report is out, then there'll be an opportunity for comment.
Yes, sir.
And then after that, did you say that the council will continue to work?
Yep. The
Okay, so
council and the advisory committee will continue to work beyond the period of the report to come up with recommendations in the 5 categories that I shared with you of things that can be done to make system improvements.
thanks for that elaboration. Any questions about what you've heard so far?
Hi.
Go ahead, Elizabeth.
Hi, Elizabeth Kunkel. I'm the Chief Medical Officer at Pennsylvania Psychiatric, which is part of Penn State Health. Can you explain the interworkings between this advisory board and the council itself?
Yeah.
That's a little murky.
My understanding is that we're actually both having the same content and conversation. I think what differs is that the council is pretty broad, has more folks with lived experience than are on the advisory council or the advisory committee. The advisory committee are folks with more technical depth in the area. And so there are discussion questions at the end of every agenda. And I think that the depth of discussions in the advisory council tends to be more technical and operational about the system's current structure or function.
Wait, Gordon, we're bringing the mic to you.
I had a similar question as to the interface between the 2 organizations, the 2 groups. Who facilitates the advisory committee?
I think that Christina facilitates both. And there has been a joint meeting in person in January. I wasn't able to attend that, but I think you were there.
Yeah, it was our first time of meeting. We really do not interact. The advisory committee that Jennifer and I sit on, we do not interact with the council very often at all. Well, at all, other than this one meeting. But like Jennifer said, they sort of get the initial presentations. The council always meets about a week or 2 before the advisory committee does. So they get all the initial discussions. And then if there's something that, for instance, I'm fortunate enough to have one of our area agencies on aging that sits on that council. So if she has any questions or wants me to look into anything, she'll contact me and I'll hopefully be able to bring that up at the advisory committee if she wasn't able to. That's how it's supposed to work, I think, in theory, but not everybody has those direct connections. But as Jennifer said, we all met for a day. Boy, it was just amazing. I mean, we did a lot of hard work, but it is a bit chaotic when you have, 60 people in the room that really are all very passionate about their particular issues. Folks in insurance couldn't be more passionate. Folks in the criminal justice part of the world, judiciary, they're all there. And it was pretty intense, but we haven't seen the report out from that one-day event. Ken, did you have questions?
Yeah, I appreciate this presentation, and I really, your candor and willingness to come and talk with us is much appreciated.
I know, right?
However,
There's a but there.
but go
Yeah,
ahead.
no, there
Ken.
is a but here, obviously, and it's
Go
kind of
ahead.
following up on Elizabeth's comment about murky, in terms of the interactions between the council and the advisory, and the interaction between the council and the advisory and the rest of us in the world. It's been, I'm trying to think of the right way to put it. It has just been,
Disappointing?
yeah,
You don't have to do that. You don't have to do that.
not
I know.
transparent and a little, I mean, I hesitate to use the word, but just a little weird. And I don't know. So part of the question that I have is, is there a there? Meaning, do we have any way to understand what it is that the direction is, that the entities that you are in are trying to get to? I mean, it could be that all we want to do is just refine a few regulations, or maybe refine the regulatory process a little bit, or,
Yeah.
but the reason I think that we had this council and advisory created in the first place was this general sense that behavioral health services and the state of the health of the state of Pennsylvania was not doing as well as it ought to for the effort that we put into it, or we're not putting enough effort in the right places or something. And yet I don't find, or I'm not hearing any sense that there's a sort of direction that can be clearly communicated as to where this whole long process that just seems to keep going is going.
Well,
So
and
I guess the question is, do you guys have a feeling at all that there is a direction that we're heading, that we're getting somewhere, or does it remain murky?
well, and Jennifer, I'm sure we'll have some thoughts to share too, but being inside of it for a year and a half, I think there's a lot of great work being done. I have to tell you that. I think that when we saw the first list of recommendations, they're pretty impressive. If we were able to accomplish half of what's on that list, I think it would be extremely helpful to the system. And you are right. The governor heard a lot early on about the fact that the mental health system was in crisis in Pennsylvania, that the staffing issues alone are enough to, meet that criteria. But there were other problems in terms of how the systems may not be working together as well as they should be. So pulling all of these folks together, that was the whole purpose, is to see if there were ways that we could find to work together. I do think that one of the biggest complaints that I've heard everywhere I go, and many of you in this room know Joan Ernie. She manages to bring it up with me in every single encounter that we have, and how disappointed she is that it's not more open and more, and I can't really speak to that. I know that the decision was made early on that that the report would not be provided to the public until all of the bodies, the council and the advisory committee, till all the topics were completed. And then once a report was reviewed by those two bodies. And I know that plus the fact that they're not public meetings. When the Behavioral Health Commission was taking place, I wasn't on that commission, and I made every single meeting. You know, I had the opportunity to be a part of every single meeting. And I know that that is frustrating for people. I can't speak to why those decisions were made. I think that part of it was trying to contain, of course, and control what's happening. And do you have any other?
Yeah, no, sorry. I think that there are opportunities available through the structure to build consensus in ways that we need to do anything. I don't know, that I can speak to a vision, an overarching vision, but I think that having folks on the same page about a myriad of priorities allows us to move more than we currently can. So I think that even just having the diverse stakeholders who are at the table right now agree on some priorities, like helps move forward motion. And I do think that the scope of the recommendations that will come out of this report, really thinking about the impact of regulations, thinking about financing, just the breadth of what underpins the system, that is helpful. I think that it's useful that it's not how to allocate one-time state dollars, right? Like the conversation is broader than that. And I think that the output will actually be in the implementation. And that is something that we all have to do. That doesn't just get done from the governor's office.
So I'm Mary Ann Alba. I'm a child and adolescent psychiatrist from Erie, Pennsylvania, and I'm going to channel Joan Ernie because that was my question, is around messaging and how do we help with, in this midst of mistrust, misinformation, how do we understand as a community and as providers and as family members what's going on? And is there a way to do a different job of messaging for this? So those 9 items, I'm like, oh, can you send me those 9 items? Because I would like to absorb them better in my brain and see where they're at and how they mesh with other things that we are working on, let's say at the Pennsylvania Psychiatric Society or other places. So how do we get the message? It's like we're going to be in this vacuum until we finally get to see and have public comment. But in the meantime, is there not a way to show what the timeline is? Kind of like, when you're doing an application, okay, we got to 1, 2, 3, we still have 4, 5, 6, 7, this is where we're at. How do we share this information in a way that can be shared to help us continue to trust the purpose and the process?
I know that one of the things that challenges Jen and Lynn here is that they can't divulge, obviously, they can't talk about the recommendations. They can't say, yes, we will, get the leadership to produce a timeline. But perhaps you could take questions,
absolutely. I mean,
recommendations back.
In fact, I just wrote here, I think what needs to happen is that Christina, and anyone who knows her probably knows she's very capable and competent. And she's a physician, she's an attorney, she's very smart, and she's pulling all of this together, which I can't imagine how she's doing it, but I think that what Jennifer and I can take back from this discussion is a recommendation to Christina. She knows, that we're here and that we're sharing our perspectives, but we can definitely take a recommendation to her. I think what would be helpful is just a brief update, an overview in general out to the community that talks about those 9 items that made it into the budget, that talk about what topics we've covered so far, what still has to be covered, and how we're going to work on implementing some of the recommendations. I will be happy to do that. And I think it is very much needed. No question about it. You know, everywhere I go, I get those kinds of comments. So I think it's much needed. I'm happy to share that. The one thing I do want to mention, very important, is that the advisory committee members are set with 2-year terms, and that's going to end at the end of December, January 1. Now, those committee members, if they really want to stay, can reapply rather. But there will absolutely be new seats available. There are several seats that are empty right now. We lost one of our aging representatives recently, so there will be new seats available this next year, starting in January, I believe.
As I
Hi.
pointed out earlier, Lynn, I was very interested in the fact that that this will be ongoing, that once the report is out and finalized, there will still be groups. So I think that's another thing, because I think that would be reassuring to the field to know that this isn't just a report, that our work is done. So I think that would be
Absolutely.
another recommendation.
Lynn, I was frantically trying to take notes of the 9 items that are going to make it into the governor's budget. Could you say again what the 20 million was going to go towards?
Oh, the 20 million is for, go ahead.
It's county baseline dollars.
Say more about that.
Who's here from the county? My understanding that it's used for
Yeah, supporting,
services like outside of the Medicaid.
yeah, uninsured, underinsured folks.
Yeah.
But this is money that the governor promised several years ago. First year, his budget, he put 20 million in. The second year, this is the second year, this is the second 20 million. So, you know, to really say that it came from the council, it's probably not 100% fair because it was already planned, but we certainly made the recommendation that it be continued.
Yeah.
And the promise is there'll be another 20 million in next year's budget for county funding.
And I think that as the association, when we talk about those dollars, it's not only funding for uninsured services, but it's also funding for those recovery wraparounds and supports that can't be paid for by Medicaid.
Absolutely.
And it's additional money. The county allocations from the state have been ongoing since 1966. This 20 million was, as Lynn said, the second 20 million increase to what's the kind of the standard state allocations to the counties.
And just to throw it out there, this is sort of unrelated, but I'm paid to say these kinds of things. And that is that we are, the Older Adult Committee of the Mental Health Planning Council has unanimously agreed that we are going to be requesting that a portion of that new money go to the special needs of older adults, that older adults be included in a priority population. The priority populations for drug and alcohol are crystal clear. They're IV drug users, veterans, and pregnant women. We want to see older adults added to that list because the consequences of older adults not getting the mental health or substance use disorder services they need are quite dire.
And there's more and more of us.
Yeah,
Yeah.
yeah,
And
absolutely.
I also think that it's important to think of those monies in the governor's proposals as a first step in the process, and something to watch through the budget, the actual budget process to make sure that they get funded. So it's not a given that everything in those proposals
Absolutely.
makes it
Good point.
to the bottom line.
Alice?
Hi, I'm Allison Swigert. I'm a psychiatrist with Penn State Health. My question is just sort of about the timeline in which the work needs to be completed. Is this still really tied to an initiative from the governor's office? Does that mean potentially that with reelection for the governor's position in 2026, that a lot of this gets dismantled or things need to be complete by then? What is the possibility for this sort of initiative to continue on?
Well, everything you said is true. I mean, if this is the governor, this is this is Governor Shapiro's initiative. And, you know, he was the one that came up with the plan. And of course, if he is not reelected, and if someone that does not support mental health or substance use disorder services is elected, it's likely that they will not support the continuation. But we're hoping that once we get some very specific, and we believe those recommendations in the categories that I shared with you, legislative, funding, et cetera, we believe those will be complete, certainly before, because they're already planning a public response, or a public, what's the word I'm trying to, promotion almost, of the results of this, just like Aging Our Way. I don't know if any of you are familiar. By the way, if you haven't seen it, please go to the Pennsylvania Department of Aging website and take a look at Aging Our Way. That was another one of the governor's major priorities, and there were meetings held all over the Commonwealth. Thousands and thousands of older adults were involved in group events to get their feedback, along with all of the state, even parks, you know, economic development. Everybody was involved in that report. What we're hearing is that there will be a report out from the governor similar to that.
Good morning. So I have two questions for you. So the first one is around workforce development. So just a quick caveat. So my day job is Director of Workforce Development for FTAC. And then also I'm the president for NASW. So I kind of get workforce from both sides. And so I know that you were mentioning and speaking to some of the priorities. And I just want a better understanding, or maybe I missed it. Is workforce development its own priority, or is it built into some of the recommendations that you mentioned? And that's my first question.
We definitely dealt with it as its own topic, but it's in the room every time we're talking about anything. So I would say both.
Okay. That actually, now I got another question for my second one. So when you say that you're in the room and you're talking about it, is there an understanding of what the workforce challenges are? Because sometimes when I hear workforce development, we're always talking about student loan forgiveness, which is very helpful. As someone who has a lot of student loan debt, I would love student loan forgiveness. But I think in my work that I have been doing and the conversations that I've been having around the state, there's a lot of work that has to happen before student loan forgiveness that we should be front loading. And so is some of part of the conversation when you're talking about workforce development? So as far as like student stipends, right? So right now, social workers, we have a bill in the legislature, House Bill 66, just in case anyone has student social workers, and you can have them call. But House Bill 66 to help social workers with student stipends during their master's level internship. We're also looking at some other regulations around our examination. We are looking at sort of what does it mean when we're training in helping students and early career professionals when it comes to professional development. So are these some of the questions too? Because what I've heard in the past is that, you know, no one wants to do this work, and we as a system is putting the onus on the individual, when in actuality it's the system that has to change, because the way that we the lack of support that we have for behavioral health workers right now is contributing to the workforce shortages. And I never hear that be part of the conversation, because then that requires the system to change and not the individual.
I'm trying to think of the actual agenda for it was a September meeting, and you could go on the council website and see who was in the room and what sort of presentations they brought to the council. But I'd also say send something to Christine, right? Like, I think that like there's a acknowledgement that like while there is an advisory committee, like no one person holds all the depth of all of the different issues going on in the system right now. And I think that she is very much open to hearing additional input and especially that forward thinking about the workforce development that you just spoke to, Sierra. So please, I don't, it's a closed process is who's in the room, but I think that the input that we're receiving is coming from lots of places across the Commonwealth.
Well, and one thing can I add very briefly is that the list of who is on the council and who is on the advisory committee is available on the website. It's crystal clear. So and I'm sure you know some folks that are on there, and you just met me, and you might have already known Jennifer, but you know, we welcome any kind of recommendations. The specific ideas that you shared, I've not heard about. But those are the kinds of things that I think are going to be more integrated when we start. Right now, what we're doing is mostly identifying what the problems are and making some initial recommendations. But when we start to get into the nitty-gritty of specific legislation, that's coming. And I think the other place you could provide that input is once the initial draft report is finished, be sure to take an opportunity to include those recommendations that you've made today.
Thank you. Last question, I promise. So this has more to do with, and I don't even know if you have the answer for this, but it's something that I've always been curious about. Does this committee and this council, I'm going to ask the question and you can let me know if I maybe need to rephrase it. But is this advisory committee or council helping the state understand that it's their role to help produce competent workers, especially in the public system? I know, sorry. Very, very tough question.
Well, no, I mean, I think that's a given. I mean, I think when you're looking at workforce and a lot of the discussions that we've had before were about professional development, you know, training needed, innovative projects. But in terms of that, the global sense of what you shared, I would think that has to be considered. Competency of the workforce.
Maybe a question back to you. What does it look like when a body acknowledges that it's the state's role to produce competent workers? Like I'm interested in the counterfactual. Like what would that look like in this planning phase?
Yeah, so I think part of it is that when the state recognizes that it's their responsibility to help produce competent workers, then we see the support in terms of budget. So I think one of the largest things that I have seen in my work, and I've heard a lot of experts in this room talk about, is that so much of what we do to support the public system is based off of grants. It's based off of one-time funding. So there's no dedicated, there's no long-term investment in behavioral health workers. So maybe 30 years ago, it looked very different. That's why you had people spend time or spend 30 years at one facility because they received everything that they needed. Now we have this idea that, oh, people are leaving jobs and job hopping, again, putting it on the individual, but people are leaving and job hopping because someone's giving supervision here. Someone is providing money for professional development here. So as someone who wants to expand in their career, I'm going to go where where the agency is providing that help for me. I'm also going to go to where someone is paying me well. So part of that investment is that the state really needs to look at how are we paying our or our behavioral health workers. I have data that says that in the state of Pennsylvania, as a social worker, master's level or LSW, the salary is $42,500. If you are a LCSW, which is our terminal licensure, that your salary is around 62. That is not acceptable, right? So we are master's level prepared clinicians. We pass state board exams. We do 3,000 hours of supervision. And you mean to tell me that someone's only going to make $62,000 a year? So the conversations, so what that would look like is having real conversations about sort of the funding piece, but then also how are we helping when it comes to professional development? How are we helping when it comes to education and training? Because when you have have a competent worker, that then means that the communities, the families, the individuals that we serve will have the care that they need.
I'm gonna take advantage of that question. And maybe piggyback it just a little bit. We have actually put together a document on sort of reimagining what the mental health world services might look like, which we have shared with Christina, I believe, multiple times. And to be honest with you, part of the feeling that you're hearing from us is that we've really never gotten anything back. We've been in no position to even raise some of the issues that you're hearing with her, let alone the council or the advisory. So we do feel, I think it would be fair to say that we've been a little bit stiff-armed. At least that may be a way to describe it. But to answer the question of what I think a state, to add to what, was just being said, a state that was concerned about health workers and behavioral health workers would have some focal point within the state that you could go to get information and data about what's happening with the workforce and where are the challenges and what are the issues that are being addressed. And there are states that are doing this. There are states that have got, sort of executive initiatives to look at the behavioral health workforce for those states. And we could easily model ourselves in some of those states. A similar issue, which I would like to raise, and I don't know if this has been raised within the commission, is moving, we have historically had our behavioral health services been very clinically based, focused on sort of individual care of people one at a time. And one of the things that's very clear is that that's just not an adequate approach to the behavioral health challenges of the time, that we need to move to some kind of public health capacity and prevention and health promotion initiatives. Some states, Ohio, for example, within their Department of Mental Health, have an office on prevention and health promotion. We have nothing like this. I would actually be very surprised if you guys have heard anything about what it would take within the state to get a focus on prevention and health promotion and its connection with the larger initiatives around public health. My suspicion is that you haven't heard about that. And initiatives to build a public health response to the mental health challenges that we have been likely ignored. I don't know that for a fact. You can correct me if I'm wrong, but if it's not wrong, then that's the kind of feedback that the commission and the advisory should be in conversation with the rest of the field about, because my notion of this isn't something I'm just generically, sui generis coming up in my own head. It's going on in other parts of the country and other parts of the world. So how do we, part of our question is how do we crack open this process a little bit more so some of these kinds of ideas, the kind of stuff that we've just been talking about, can get inside?
Well, prevention and early intervention was in one of the earlier meetings that we had. I can't recall who was actually the folks that were represented at that particular meeting.
I don't remember either. I'll see
Yeah,
if I can find it.
but there's no doubt there's a lot of discussion about prevention and early intervention and what we should be doing, especially as it relates to criminal justice system, for instance, even in no doubt in the substance use disorder area and in mental health, but I can't really speak to exactly what kinds of models they were talking about. We had things like, should we have an Office of Prevention and Early Intervention? Things like that are further down the road for this group in terms of those specific recommendations, you know. Right now, the recommendations are increase prevention and early intervention as it relates to, you know, those kinds of things. But in terms of specifics and how that's going to happen, there really haven't been those discussions. And I do want to just respond to, I know that you feel stiff-armed by the administration in terms of your paper. I'm definitely going to talk to Christina today, and I'm going to tell her, if it's okay with everybody here, that you were disappointed that you submitted your paper on more than one occasion, and that you haven't heard back, and I would recommend that I think she was a little surprised that she wasn't being invited today, because she did tell me that she was here last year. And I think that you should invite her back for an update. I think a lot more has happened in a year, you know, since the last time she was here. And I think the plans and the ideas of where it goes next are much more formulated in her head. I don't believe it was stiff-armed as much as it was, there was just so much coming at this area, and she's a one-person show. She doesn't even have a lot of administrative support. I mean, she has some, but she's pretty much a one-person show when it comes to pulling all of this together.
Val, is there one last one? Okay.
Hi, my name is Laura Simmons, and I manage family programming at AFTAC at PMHCC in Philadelphia. I'm looking at actually the Behavioral Council website, and I'm looking at some of the folks on the advisory committee, and I see there's a ton of people across, like, you know, juvenile justice and sexual abuse and suicide prevention and whatnot, and some folks who come with a family perspective and lived experience, which is great, because I think that we're seeing now the past several years a big focus on integrating people with lived experience into conversations that involve making changes to them and about them, right? So the question that I have, I see that there's a meeting schedule that you all seem to meet once a month. Is there a way for family members or other people across Pennsylvania with lived experience to get involved in some way, to give feedback or to see what is being discussed in these meetings? Because I work a lot with families, and I get a lot of questions about, not just locally, but statewide, what is going on in terms of all the different pockets and the avenues that impact social services and behavioral health, and very interested in the work that you all are doing. So do you all have a public forum or a way for family members or people with lived experiences to give feedback or to get involved?
I would say that the public comment period for the report, once it comes out, is an avenue for input. I don't know that there's any additional avenues for input until there's some work product coming out of the group.
So I just want to commend you guys on hearing some of the heat in the room and staying calm, cool, and collected. I would like to return to your concerns about the state having a role in workforce development and workforce itself. I can tell you specifically for geriatrics, it takes 3 years at a minimum for me to get a geriatric psychiatrist to come to our facility, and at least 2 years for most of the child people. This is all going on at the same time that we're seeing skyrocketing rates of mental illness in all ages. So this is what we're up against, and it is a really complicated problem.
Well, I want to pick up, Elizabeth, on what you just said, which is that I talked to Jen and Lynn, and they were a little nervous about this. I think the reason that we wanted the two of them rather than Christina is that we wanted to have an understanding of how the work was being done from an insider standpoint. Not, this is going to sound mean, but not kind of varnished, you know, not a public relations presentation. The two of you walked a fine line between not sharing stuff you couldn't share, but sharing a lot of information with us, and I'm very grateful. So I
Can
think
I
we need
just-
to recommend to.
Can I just add one quick thing? I want you to know that we told Christina that we will not be speaking on behalf. And when she asked me why, and we have a very good relationship, Christina and I can tell you that. I talk to her often because of my concerns about the needs of older adults being more highlighted. And she did question, and I did tell her, Christina, I think they're looking just for some personal experience of friends. And I am very good friends with a number of people in this room. And I think that's why I'm sitting here. And not for, and I said that if there was a desire to hear a response from the Commonwealth, I'm sure the Commonwealth would have been invited. And I think that that might be a next step.
I think you've given us some room for hope that this can be something. So I'm grateful. Let's please show our appreciation.
All right. Just really quickly, just one more, not even a question, more like just a comment. Hi, my name is Lisa Makovsky. I'm from Allegheny County Department of Human Services. I manage a program called BH Fellows, and it's a workforce initiative that was launched 2 years ago to help stabilize the public behavioral health workforce in Allegheny County for direct care in community workers because of the high level of vacancy rates and just a lot of other issues that we're all quite aware of in the, particularly the direct care in community public behavioral health workforce. And just there's just a couple of things that we've learned from talking to the direct care staff, as well as talking to folks who are coming out of school who want to get into this field because they're so passionate about helping people. And just in talking with a lot of other folks over the past couple years is to really look carefully at the pipeline from folks who are coming into school, even from high school to college. And then when they're in the public behavioral health workspace, interested in getting their licensure so that then they can move out of the public health workforce into the private, and just making sure that we have folks in that pipeline, because from what we're seeing, it's we don't want that pipeline to dry up. I guess that's all I have to say as far as folks who are able to have a living wage, a better than living wage. They're looking at getting out of the public and getting their licenses and moving out because they literally can't afford to stay in the public. So that's one thing to look at, but having the education system be part and integral of developing the workforce is just something to be mindful of. That's all I wanted to just make that comment.
And I think your program is an example of projects that can be expanded upon. It can be done. It serves as a model. So thanks for that.
We can give a round of applause to our panel. Thank you, Stan. Thank you, Jennifer, and thank you, Lynn. If you have questions, additional questions, I believe they will be here through lunch if you'd like to have a conversation with them. All right, at this point, I'd like to welcome up our next panel. Dr. Serta, I'm gonna hand it over to you.
Dr. Klein. You agree to this, come on. I'm going to stand here. Is this on? Yes, great. So we have to have the slides up. We spent so much time working on them. So again, as I mentioned earlier, I'm Ken Sert. I'm a psychiatrist at Jefferson in Philadelphia doing ER and inpatient work primarily, and I've been very involved with a lot of the advocacy for our mental health system for a number of years. And I am joined by this panel that is going to be really talking about what it's like out there right now. I will wonder about this being after the blue skies that we were just hearing about, but this is what's really there right now. I'm joined by Doctors Kathleen Klein, who is a program director at, or a medical director at the consortium in Philadelphia, a community mental health center there. I will do a brief introduction so that we can move on. She did her her medical school training at Yale, and then her residency and child fellowship training at the University of Connecticut. Following her is Ashley Unn, and I am pleased to say I'm at a stage in my career where Dr. Unn was actually a medical student that I worked with at Jefferson some years ago. She went on to do her residency at the University of Pennsylvania and then the Child and Community Fellowship there. She is now the medical director at the Hall Mercer Mental Health Center and runs the Community Psychiatry Fellowship. And then finally, Dr. Clarice Dixon, who did her medical training at LECOM, as well as her residency there, and also did the child and adolescent, the Community Psychiatry Fellowship. I think of child because, as you see in her bio, she has 4 sons. And it's like hard to imagine a more effective child fellowship than having 4 children, as I myself do. Anyway, so what we're going to talk about is, we want to go to the next slide. Never mind. I forgot I have this here. Oh no, there we go. So we're going to talk about what's currently out there in the community mental health center system, what the challenges are. We're going to talk a little bit about how we train people to do this, specifically psychiatrists. I'm sorry, I'm biased in that way. We're going to talk about the differences between urban and rural, and then how adults and children differ a bit. Going the wrong way. So it was hard. I wanted to talk a little bit about how we got to where we are, and Dr. Klein is going to go through that in a much more effective way. But this is kind of where we start. Back in 1963, the Community Mental Health Center Construction Act. Heady times as we move people from long-term institutionalization into the community, and community is what we're all here about. But things have changed, and so now I'm going to ask all of you to do a little audience participation, some Mentimeter if you haven't done that before. There you go. If you could focus on the QR code up there, that will enable you to respond. And if you don't have a phone, I'm sorry, you're going to be out of luck. And if you don't have a phone, why? And how do you live without it? As my children tell me all the time, as their batteries run down. Anyway, we're going to be talking about a number of things, just trying to figure out where people are, what their current practices are, and then some ideas about what they would like. I'll give people a little time to do that. This also enables some of the folks who are out in the field to be able to give some responses. So if you can do it. Do we have the larger one, maybe? Yeah. All right, some real audience participation. Get up and move up so you can Everybody got it? No. It would be helpful to have as much participation as we can, but anyway, so let's move on to our questions. Which I need to do. So trying to figure out sort of where, and I know this is not inclusive, but I wasn't able to go through every kind of thing, but mainly, are you still in training? Are you at a community mental health center? Do you work in a hospital setting? Do you do private outpatient practices, or are you non-clinical? And I know there's academic, there's policymaking, there's pharmacists and so on. So do the best you can, pick one. You got it? Is everyone able to answer? Okay. Oh, We're supposed to be able to see the results, but I guess not till later. So what about the resources that you have? Do you have basically what you need? Do you sometimes need things you don't have but can get them? You go without tolerably, and is it scary sometimes? Oh, it's not running? Oh, it's still calculating. Okay.
We could actually raise our hands for the people that are in the embodied people in the room.
You know how many times we tried to get this going for Mentimeter? If we're just going to do hand raising, what was all that for? It was hours trying to get this to work.
We have a backup system.
We do have a backup system. That is true. Is it working? Because if it's not working, we go back to the hand raising. It is not working according to Carolina Stabile. Sorry. All right. Well, let me go on to some of the. So, do we have a time frame here? All right. Let's. But only one.
There's 40 people in the chat. It's not that we can't include them, but we could find when we actually get this to run, we can find out how representative the people in this room are of all the people that are out there trying to make this work.
We can try. Do we have any idea why this isn't working? You can see it. Okay, so you can see it. Do you want to just read the numbers to us then? Sure. I'm surprised that you can see it and Lucy can't. You only have 31 people voting? Yeah. All right. Well, rather than waste any more time, if you want to just read them, can you do that? All right. Shout it out. Or you want a mic? Need to turn it on.
Okay, 18 said non-clinical, so that's the top. 3 said private outpatient practice, 3 hospital, 4 community mental health center, and 3 still in training.
Okay. All right. So we have heavily weighted to non-clinical and in training. All right. Next. Forgot I flipped it around. So what best describes the resources where you practice? Again, what we need, sometimes need things but can get them, go without, and scary. If you want to just vote on that. All right, this is proving much more of a bust than I'd wanted it to be, obviously. But we'll, since we are 15 minutes into the, is it working?
The next slide.
Yeah. And are people voting, but people can't vote? All right, I suspect this may have to do with the Wi-Fi availability in the room, because when I did this myself earlier, one person, it worked great, but not with this many people. All right, so let's do the hand raising. Dr. Klein wins, as always. So who votes with number 1? We have basically what we need. Raise it, show of hands. I work in a big hospital system. I'm lucky. Next, and you can answer in the chat. Yeah, although the chat obscures things. So the next one, as I recall, is we sometimes need things, but we can get it if we really try. How many would put that in? Nobody wants to vote. 1, 2, 3, 4, 5, 6, 7. Okay. Next is we go without tolerably. All right, we got 2 people, and now we're way out there. And scary sometimes. We got 2 there. Okay. Well, now we have the whole chat. I don't think we need that chat. Please. Okay. The results came up on your phone? The question? Okay. Let's move on. Next here. What percentage of individuals served by your agency are seen virtually? It's a big issue now, whether or not, do we need bricks and mortar anymore? Are we 0 to 10, 10 to 30, 30 to 60, 60 to 80, or 80 to 100? Since there's some agencies that are 100% virtual. You want to, let's do a hand raise again. What percentage are seen virtually? 0 to 10? Anybody? 1, 2, maybe? 10 to 30? Seems a lot, okay. And if you're non-clinical, I'm sorry, I know it's a little hard to, well, you're in an agency anyway. 30 to 60, virtual? 3, 60 to 80, anybody up that high? And is anyone in the all virtual universe, 80 to 100%? Okay. Again, please continue voting if you can, because there's a chance that we'll be able to pick this up later. Voting online, I mean. And then how would additional funding for your agency best be spent if you had to choose? This is probably the more important question. Since the dollars are scarce and finite, what do you want to spend it on? More money for us, people where it exists, hire more clinical staff, improve infrastructure, things like medical records and communications, or hire more support staff. So who wants to do number 1, increase pay for staff that exists? Again, you only can pick one, and I'm going to be watching. Right? Yeah, okay, that's a pretty solid number. 1, 2, 3, 4, 5, 6, 7, 8. Hire more clinical staff.
They are related.
They are related, but you can't, because you can't hire if you don't have the bucks. But okay, that's 5. Improve infrastructure. All right, 2 administrative people here, yeah. And then hire more support staff. Because, I mean, we've got clinicians, but our support staff have been decimated, and they turn over so quickly. That's part of the problem. All right, so increase pay and hire more seem to be the winners there. Moving on. How would you rate the education we give psychiatrists about community mental health? About right, not enough, too much, not the right things. About right? Psychiatric education, who cares? Not enough. You think? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Wow, okay, not enough. Too much. Nobody in a community organization room. Not the right things, that's where I would go. Because a lot of the things, like the stuff that we're talking about with budgets and so on, you never learn about in medical school or residency or anywhere, and it's so important. To put my plug in for my answer. How easy is it to track your patients through the system of care? Very, it takes work, can be done, nearly impossible, and why would I do that? And anyone who answers the last one, we should talk afterwards. But so very easy. For me, it's very, I mean, I have access to Epic. I've been around for 40 years at my institution. I know the city pretty well. I know how to get in touch with people. Takes work, but can be done.
I have the results.
Again, try to vote online if you can, but hand raising is good. Nearly impossible. I'm afraid of that. Yeah, that's what, whenever I call a community provider for somebody I have, it's like, nobody ever calls. And it's true for a lot of good reasons. A lot of bad reasons too. Everyone thinks, HIPAA, I can't do anything. It's nonsense. And then finally, well, these things we'll leave to later. Anyway, let me move on. If we can switch back to our main talk so we can get going. All right. So now we're going to talk about now, and this is going to be Dr. Klein. This is one of the outreach teams that the consortium has, one of the many innovations that was not thought about at the time of the original Mental Health Act. And Dr. Klein is going to be talking about these issues, and that's not supposed to be there. Where's Dr. Klein's talk? Oh, we're going to go there. You're right. I'm sorry. So we're going to go to Dr. Klein's talk, if you got it. There you go. All right. I'll give you this.
How do I move? Which way do I push to move them ahead?
You have to do trial and error like I did. Here, this one goes
The one,
forward.
okay,
Yeah.
great. Forward and backward.
Yep.
Great. Well, thank you everyone for having us here and inviting us to talk about this. It's great to be with you. And it's especially great to be at the Pennsylvania Psychiatric Leadership Council. I remember the first council meeting I was invited to about 15 years ago with the late Dr. Larry Reel. And I remember walking into a room like this, maybe even this room, and Lloyd was standing at the front giving a talk. And I thought, who is this group and what do they do? And why did Larry say to come? And, it took me, it took me a while to figure this out. And, but it's really been a pleasure getting to know everyone here, both those present, those who have passed, and those who have joined us, who are the next generation of leaders. It's really been wonderful. And especially those who met very regularly virtually through COVID to support us doing this important work as we got through the pandemic, and continue to meet in a semi-regular fashion to sort of address challenges as they come up. So what I'm going to give you is a picture of community psychiatry then and now, a 15-year Philadelphia-centered perspective, because that's what I have 15 years ago when I came from California back to Pennsylvania and Philadelphia. I'm the Chief Medical Officer of the consortium, which is a behavioral health agency located in West and Southwest Philadelphia, for those to whom that means something, serving an urban population largely, although we do also serve folks from Delaware County. And during the pandemic, we served people from all over the city, partially because many other agencies closed services. So and telehealth was available, which really increased access. We have a very large smorgasbord of services, from recovery addiction treatments services to adult outpatient services, the crisis service that you saw, supports coordination for individuals with intellectual disabilities. We have adult outpatient mental health, child outpatient mental health. We have a community integrated rehab day program. We have family-based behavioral health for children and functional family therapy for children, which are also both mobile services. So a very broad spectrum, which has blended case management for both children and adults. So that is both some pros and some cons. It's a very broad spectrum of services. At the same time, maintaining leadership in each of those services at every moment, and the infrastructure can be quite challenging, and you're often feeling like you're putting a finger in the dike. You got one thing spruced up and something else is happening. So we'll get to the challenges of the system a little later. But I want to reminisce from the time. Oh, by the way, I wanted to introduce myself, and I wanted to also say that in addition to being the Chief Medical Officer of the consortium, this is my 41st wedding anniversary, and obviously I was a child bride. So 15 years ago when I came into the room and Lloyd was standing at the front, these were some of the things that I found. I came from Children's Hospital in Denver and the University of Colorado. I had spent the first 20 years in academic medicine at the University of Colorado in Dartmouth. And I was curious to find that Children's Hospital of Philadelphia had no inpatient academic unit serving children at that time. And in fact had very limited specialty care for children. They had a pretty well-developed eating disorder program, but in terms of a more developed psychosis, mood program, they were sort of trending in those directions, but had not evolved anything like that, and no intensive outpatient, except I think for the eating disorders program. Outpatient public psychiatry centered at Penn, centered largely around Hall Mercer, and there was limited availability for Medicaid patients in a small residence clinic. Similarly, the public psychiatry participation in for children was a small CHOP clinic and some rotations through community mental health agencies like ours. There were 0 to few electronic medical records, few nurse practitioners, sparse peer involved in mental health. We had 2 long-acting injectables at that time, if you remember, Haldol and Prolixin. We had few federally qualified health centers, no community certified behavioral health centers. We're in the process of a transition from day programs to community integrated rehab programs. We were moving from grant-funded service to fee-for-service funded services. We were moving from residential programs to mobile therapy programs, and there was a new enthusiasm for evidence-based care. So, next thing that happened is evidence-based care and the recovery movement started. So in Philadelphia, Community Behavioral Health, Department of Behavioral Health and Intellectual Disability Services promoted evidence-based care. That was a chief goal of mine, was to bring research-based, evidently valid programs and make them available to real people in real communities. It increased the excellence of services. But one of the challenges that we continue to see is outside of medicine, where I think we really are largely trained in evidence-based programs, many of the academic counseling programs lack evidence-based training. So you cannot count on individuals coming to your agency already trained in cognitive behavioral therapy or interpersonal psychotherapy, or even, standardized psychodynamic psychotherapy or trauma-based CBT or prolonged exposure. You find people very interested with a good heart, they want to do the work, but a lot of the training has to happen while they are working. And that takes a big investment of time and energy and dollars. And there's very high therapist turnover. And one of the reasons is because we've talked about low pay and their stressful conditions. People are motivated to get some of this training and get the hours for their licensure. But then as soon as they get them, they go off into private practice or a better funded hospital system where they can get paid. And you are back to square one in a 18-month to 24-month cycle. So the ability to keep and sustain well-trained clinicians over a period of time is very challenging and hard on the patients as well. We've had some treatment breakthroughs. In terms of psychopharmacology, I have to say, I find it very disappointing. In 15 years, I would hope that we would have some much bigger advances, especially in the treatment of severe mental illness. We've developed many Me Too drugs, many copycat medications that can come out as a new, expensively priced brand named medication, but not really fundamental mechanism of action things. And so it's a long road ahead of us. And I hope and pray in my love-hate relationship with the pharmaceutical companies and academia that we can continue to make progress in that area. We have made some, I think, progress in smoking cessation treatments and medications and in some anti-tardive dyskinesia meds, although it's a little too late on that cycle in some ways, because it's less of a problem, at least in my experience, than it was when I was in my training several decades ago. I do think we've made significant improvement in medication delivery systems. I think long-acting injectable medications come to mind, and Suboxone as delivery vehicles for good enough medications that when we can deliver them in a way that people with compromised organizational function for taking oral medications can be more effectively treated, I think we have made some significant progress in that area, although we've not cured any of the underlying diseases. We've also had some new devices that are more readily available, but that we can use, like transcranial magnetic stimulation, direct current stimulation, vagal nerve stimulation, just to name a couple, but they are not widely available in the public sector. Oops. We have specialized psychotherapies and internet-based resources. Technology, EMRs and telehealth. There were none of them. Now everybody's got to have them. They're essential. They help with record keeping, help with patient support tools, but they do have privacy concerns. I think they can have some electronic barriers to empathy involved in looking at your computer all the time rather than looking at your patient, and an administrative burden of switching costs back and forth to the patient, to the computer, to the patient, et cetera, et cetera. Telehealth, major revolution that when I came from Colorado, we already had residents flying across the Rocky Mountains to deliver care once a month and providing telemedicine services in the interim. And it took, actually, in spite of me mentioning that urban people had the same transportation challenges to get to services at times, it took the pandemic to make telehealth widely available in the public sector. So it has improved access and convenience. I think extended some providers' careers and allowed us to continue to serve when there is a shortage of care available. But it has changed the therapeutic frame of coming to the office, of sitting, of getting constant attention. You know, we have to both train ourselves and our patients to sort of create an atmosphere where there can be focus, attention, and real reciprocal care given. And it cannot fully replicate inpatient care. Workforce evolution. We have decreasing number of psychiatrists, increasing numbers of nurse practitioners and physician assistants. We have more primary care, managing psychiatric care with and without the support of psychiatric subspecialists. We have an increase in the use of peers in caregiving settings, and we have a severe therapist and support staff shortage. Conflicts of interest. So various healthcare roles are susceptible to conflicts of interest. And I think physicians have been sharply had our hands tapped with the opiate crisis in terms of conflict of interest and also conflicts of interest with big pharma in general. I think other specialties, including nurse practitioners, PAs, pharmacists, program directors, county medical and psychiatric directors and decision makers, all these people have influence on the use of psychiatric medications, devices, and are all decision makers and influencers, and therefore targets for commercial entities that have the opportunity to make millions, if not billions, from your endorsement on a treatment algorithm or a standard of care or whatever. And I think there needs to be a more increased awareness of it. It's not that we can avoid it entirely, but even the PLC has, from time to time, been approached in some very subtle ways to make endorsements of devices or medications that we're always approached with, the best interest of our patients at heart, or appeals to improved access or parity or justice or efficacy. But you have to work hard to make sure that you get underneath what's going on, what you're being asked for, and that we do the work that needs to be done to really evaluate various claims. I think we need to be aware of the psychiatric equivalent of pain as the fifth vital sign. And this is an example of one of those subtle things that happened that probably helped instigate the opiate crisis when there was a big movement that started within the Veterans Administration to, we don't adequately address pain. Pain is the 5th vital sign. Everybody has to measure it. If you measure it, you've got to get rid of it. If you got to get rid of it, we got to use these fairly harmless drugs, which many physicians who should have known better and should have thought twice really became seduced and promoted this, many thinking that they were doing the best for their patients. So we have to be enormously vigilant. And I wonder what's the equivalent of that for us? And we should consider thinking about that. There have been changes of the systems of care. The funding models have evolved, as we've said, from grant-funded programs to fee-for-service programs to capitated programs to now value-based programs. So it goes on and on. There are consolidation challenges throughout healthcare, and there's an increasing consolidation within healthcare agencies, mergers, acquisitions, hospital systems taking up agencies. Margins are razor thin for agencies, and the infrastructure that we require, the billing mechanisms, et cetera, they end up being unsupportable by sometimes smaller agencies. So we have to recognize that these stresses are happening throughout the healthcare system and affect us in a big way. And sometimes even major payers. We heard the rumor the other day that some of the larger public funders really wanted to work with just a few systems, and they were tired of working with so many different providers who build them and serve their people in so many different ways because it was so complicated. And financial management is crucial. I also want to say that compassion over the long run is not an excuse to pay attention to your fiscal solvency. I love the organization I've worked with, but it's encountering some severe fiscal challenges. And the fiscal challenges were not caused by the current federal administration. They predated back way beyond that. And many of those wonderful things that we did, like treating all these people during the pandemic when many other agencies didn't, there are fiscal consequences to those things, which is not that you can't do them, but you have to pay the bill at the end of the day. And you have to figure out how you're going to do it, whether that is through federal funds, state funds, philanthropy, other creative funding solutions. If you do not do that, you face the sudden collapse of critical programs. And if we don't address these things and really prioritize how we are going to take care of these things ourselves, they will either collapse underneath us, or we will, someone else will come in with a chainsaw or sledgehammer. Fiduciary responsibility. It's our trust to act in the best interest of another. Historically, it's been the responsibility of individual clinicians. Systems may or may not act as those fiduciaries, and we have to think about that. Who is taking the ultimate responsibility for the care of individuals, and who can we trust? As Reinhold Niebuhr said, no system is so perfect that it absolves individuals from the tasks of being good. So, in conclusion, there have been many changes over the 15 years, including changes in times of struggle, to which I suggest when I first came here, it was in the beginning of the Great Recession that we got through and built all these things and made all these changes. And then there was a time of more abundance. And then there was the pandemic. And then we came to where we are today. So progress continues, but which season are we in now? And what tools do we need now? So those are my thoughts. Thank you, everyone.
If we can go back to the main slide deck. Great. So now we're going to talk about education and training. How do we make sure that the people that are doing this work know what they're doing? And these are the people that tell us. This is the headquarters of the Accreditation Council for Graduate Medical Education in Chicago. And this is the American Board of Psychiatry and Neurology, just a few miles away in Deerfield, Illinois. And this is Pennsylvania Hospital, the nation's first hospital, where Hall Mercer Community Mental Health Center sits, which is directed by our next speaker, Dr. Un. You going to come up?
All right, so I have been asked to talk about some of the progress, challenges, and opportunities specifically related to academic medical training in community psychiatry, including medical students, residents, and our fellowships, as well as briefly touch on academic and community partnerships. A brief history of community psychiatry training in academia. So the first fellowships were created in the 1960s. They were around for less than a decade. And then in 1981, there was a revival of fellowships with the creation of Columbia's fellowship program, and then much more rapid expansion in the early 2000s, including 3 centers of excellence in Pennsylvania in 2007, in Erie, Pittsburgh, and Philadelphia. Starting in 2008, the AACP started creating a database of active fellowships as well as guidelines for developing and evaluating fellowship programs, and also created an exam in 2018, which is not required but available to demonstrate competency in this subspecialty. And then starting in the past few years, there's also been more movement towards creating a model curriculum for residency education as well, which I will talk about in a little bit. So the ACGME and ABPN have very basic requirements for residency education. Resident experience in community psychiatry must provide residents with a panel of persistently and chronically ill patients in the public sector, as well as teaching them to both use resources and work with other interdisciplinary members of the team, including case managers, crisis teams, and other mental health professionals. The AACP, which is the Association for Community Psychiatry, created this model curriculum, which has presentations, facilitator and presenter handouts and resources, and suggests topics to be covered within residency training. So in the PGY 1 year, there's overarching content related to racism and mental health, social justice and mental health, the recovery model, clinical competency, systems of care, and structural competency. And this models the training that we get going from 1st through 4th year. So in the 2nd year, what's covered is more acute care topics. And then in the PGY 3 year, ambulatory or longitudinal care topics as residents progress from doing primarily inpatient work to more outpatient-based work. Just for an example, this is what our curriculum at Penn looks like in residency training. So some of the content suggested in the AACP model curriculum is covered in our didactic curriculum or covered elsewhere, and there's some content that is different or not covered. Our clinical experiences in the 1st year, primarily in academic settings or at the VA, but as there are elective opportunities available in the PGY 2, 3, and 4 years in community-based programs, including Horizon House and Hall Mercer, which is a community mental health center with an affiliation with Penn. And then there are some experiences that allow residents to see other models of care, such as ACT and CIRC programs, and first episode programs as well. We do have a certificate program in community psychiatry, which residents can elect into and can demonstrate specific focus in this area of interest, and offers additional mentorship as well as responsibilities for doing additional didactic work, experiential work, and involvement in conferences and academic pursuits. So as residents are concluding their training, they're oftentimes deciding whether or not they want to pursue a fellowship in community psychiatry. Unlike some of the other subspecialties, it is not required to do a fellowship in community psychiatry, and we don't have a board certification that is required either. And so it's often a difficult decision to pursue additional training at a salary cut to do this, but it does offer specialized training as well as specific opportunities in leadership, policy, organizational advocacy development, as well as networking and career advancement opportunities. I have listed here at the bottom all of the states that offer fellowships according to the AACP website, and currently we're at 27, with Pennsylvania having 4 of those, which is the most of all of the states that have been noted. Some of the community fellowships that are available are resident tracks, which do mitigate some of these barriers to accessing training, but also at times require people to opt in very early on in their training. So I think there are probably pros and cons of different fellowship opportunities, but some limitations with the way that it is. Specifically, our fellowship at Penn is a full-time 1-year post-residency fellowship. We have fellows are placed at various public sector agencies in Philadelphia for 3.5 of their days. And then we have also a policy and administrative rotation that includes rotating through various Philadelphia DBH-IDS divisions, including behavioral health and justice, the coordination of care team, homelessness and housing, as well as CBH, which is our Medicaid carve-out program. And fellows also receive additional supervision and mentorship from various leaders in the field and the community leadership as well. So there isn't much that's like published about community psychiatry training in medical school, but we do know that medical students are more and more interested in going into psychiatry, as well as interested in social justice within medical training. From the national match data for this year, there was an increase in positions filled in just a few specialties, psychiatry being one of them, with a 1.5% increase in the positions that have been filled. And at Penn, psychiatry was the second most popular specialty that med students matched into, with 11 students going into psychiatry, which is pretty exciting. We have just one elective that's available to med students, and that's based out of Hall Mercer, which I direct, and there's opportunities to experience and participate in both clinical and non-clinical programs that we offer, both in the community and in the office. So they can see like traditional outpatient care with case management support, as well as some of our more unique programs, such as the Southeast Asian program for clients who have TCM services. Some of our specialty clinics related to people who have been recently unhoused. They can go out with homeless or street outreach, or even go to the shelters to kind of observe engagement at that level of care. I'm just going to talk very briefly about a really cool project that I've been involved in, and it's been very inspiring, and I've been very lucky to be involved in it. So we've created a new LGBTQ clinic at Hall Mercer that is facilitated and was conceptualized by medical students. So just an example of ways in which academic medicine can partner with community partners and really work to both increase opportunities for patients, as well as educational opportunities as well, and service opportunities. So a very small group of very passionate medical students came up with this project and modeled it after a program that was already existing at Cornell. They partnered with 2 organizations who work with this population, including Philadelphia Fight and the Mazzoni Center. Came up with a proposal involving the Department of Psychiatry as well as the School of Medicine to move this project forward, and we started this past July. And it's been a great experience to work with the students in helping their vision come to fruition. So just a few takeaways. Our system is very complicated and also quite fragmented, but there's increasing interest in psychiatry as well as academic training in community psychiatry. But there is not very much information, especially recently, about what is offered in training, especially earlier on in medical school and residency. There's likely a lot of variability across programs and some limitations to improving this as well, just given the amount of information that is required in medical education. and a lot of competing priorities and challenges with resources and knowledge. But AACP has been making some strides for making some of this content a little bit more accessible, but still needs to improve and also integrate earlier on in training. Training and community psychiatry can both have opportunities for increasing high quality care, but also for allowing providers to feel more comfortable and confident and be able to affect more organizational and system changes at the clinical level. So that I will pass it off to.
Well, noticing that we only have 8 minutes left before lunch, we will move on to a presentation from someone who just finished her training and is now experiencing the system for the first time and can tell us what it looks like for someone new to the job. Dr. Dixon, let's see if we can put that up there. Do you have it? Please. There we go. Come on up. Dr. Dixon finished the community psychiatry fellowship under the tutelage of Dr. Albaugh here in Erie and continues to work there. Please go ahead.
Thank you. So my part of the presentation is more about my personal experiences and what I've learned in the last 2 years of being an attending psychiatrist. So I'm going to start with some background. I'm an osteopathic physician. I'm employed by Deerfield Behavioral Health. I specialize in rural and community psychiatry. I completed my fellowship through the UPMC Centers of Excellency in Psychiatry in 2024. So I'm almost done with my second year as an attending because that coincided with my fellowship that first year. So presently I work at Sarah Reed's Children's Center in the partial program and in the residential program as well. I also provide some psychiatric care at Gage House, which is a dual diagnosis drug and alcohol residential facility for adults. And then I have worked in Stairways Outpatient just starting recently. So as a student, I was a non-traditional candidate. I started at LECOM in 2015. So by the time I was applying, I already had been married and divorced with 2 kids, some life experience. So I had a little different perspective from most of my cohort. So even though I wanted to be a doctor since I was a small child, I wasn't quite sure I wanted to be part of the healthcare system for many of the reasons that all of you, I'm sure, are aware of. So I've always been kind of a leftist since I was 14. When I did my electoral college map, they called Florida. It was ruined, 2000 election. So since then, I've had a lot of strong opinions about how things are done in this country, up to and including the healthcare system. So I've been pretty unimpressed about how the nation that's supposed to lead in everything you can measure is failing its citizens in healthcare. How can you pursue life and liberty and happiness without your health? So despite my misgivings, I overcame many obstacles. I became a doctor. I graduated in 2019, and we all know what happened in 2020. So all of my experience is colored by COVID-19. I don't know what it's like to have workforce shortages or burnout. That's my life. Like that's what I live in every single day. So I came to the community because I was hoping to become part of the solution here. So although I don't really talk a whole lot in the meetings outside of when I'm giving my talks, I'm a big complainer in the office. I've had some elder colleagues tell me that I'm too young to be this jaded, and I counter that with I'm a millennial. So there's that. So whatever setting I find myself in, whether I'm working with children or adults, the grievances are the same. We don't have enough personnel. Our clients are too high needs. We're working too hard and too long without adequate compensation. The only thing that keeps most of our staff working is the sense of obligation to their clients and their colleagues, as well as needing to put food on the table and pay their bills. So the passion for working in mental health is somewhat waning for what I'm seeing. And that's only gotten worse with more and more bad news that we're seeing. And that also might make it so that's less and less appealing for current students and residents and other personnel who are not physicians to want to work in mental health. So while Dr. Owen is saying that that number is still going up, I'm glad to hear that. We really don't know what that's going to look like in the future. Some of us are already starting to see the impact of that uncertainty. I mentioned at the dinner last night that a couple of places where I worked, one is already closed down, the other one is going to be, well, not closed down, but I'm no longer working with them because of liability. And then the other one is going to close down entirely. So I used to work at Erie County Prison until April 1st, when Journey pulled its contract. While there's many challenges in forensics, I lamented the loss of that because I know what it means for the clients in the community. I don't know who's going to fill in that gap or how that will look, even though I already know that the care that was provided there was woefully inadequate to begin with. So just this last week, I was informed that Gage House, the dual diagnosis drug and alcohol, will be closing at the end of June. And that's yet another resource that has provided a lot for the community that won't be available where there's already so many gaps. So there's so many worry and uncertainty that I worry about the other facilities where I work. The financial picture is bleak. We're already understaffed. We can't keep up our census despite having numerous intakes and referrals on a weekly basis. We just can't keep up. And the acuity is high. The staff is chronically overwhelmed. There's no relief in sight. There's a vast immigrant population in Erie. I've already had some of my clients voice how they're fearful of their future. They can't go visit their families because they might not be able to come back. They rely on their mental health services here and their other services. And of course, their families here, they have their lives here now. So on the other hand, there's underserved minoritized populations who don't get the care in the first place because they have to work. You know, they can't take off a day to come do a meeting for their kid. They have to provide food for their kid. So that's another problem. So we're not reaching nearly as many people as need services. So unfortunately, we've seen the effects close up. A lot of the adults who don't get the adequate care end up in the carceral system where they continue to deteriorate. Their children are left without their parents, so they end up raised by family members or unsupervised, and they can end up in residential facilities using substances. The cycle continues. So we're failing, and then we're continuing to fail as we fail. So, you know, I know, very positive, right? So I can't say I have any concrete solutions to any of these problems. But one way I keep from despair is knowing I'm not alone in this fight and that people like the ones in this room are like helping come up with solutions and working together to address these issues. Every time I participate in a PPLC meeting, I feel reinvigorated and have a renewed sense of hope for the future of mental health. It's been reiterated several times that building community and collectivism are our first steps. Connecting with our colleagues and clients on an individual and human level is a skill in which many of us excel. And I feel that as a group, mental health professionals are uniquely positioned to influence and lead the way to make changes, one interaction at a time. So what we need is a fundamental shift in the way we think about mental health and recognition that we are all part of the larger global community. And instead of taking the attitude that we are the gatekeepers of mental health, we should spread the message we're partners in empowering the community to work together toward wellness. And through participating with PPLC, I've already learned about many ways that people in this group are doing that, such as including families in decision-making, training peer specialists, collaborative care, and integrative community therapy. So we know that we're divided as a nation, and when it comes to political identity, having these conversations are difficult. But if we get to the heart of the matter, we find that we're a lot more similar than we are different. And while there are many who are not maybe in the mental and emotional place to have those conversations, those of us that are, I feel it's important for us to recognize that we do continue to spread empathy, even to the ones who think that empathy is a weakness, especially them. And I have to believe that we can make change because otherwise everything that we do here is meaningless. So in parting, I'm glad to hear that while we're fearful and we're uncertain, there's hope in this room and your voices matter.
All right, well, it's after 12, but we could maybe take a couple of, time for just a couple of questions or comments or, there's not a lot to discuss here because we have heard how the system has evolved, what we're doing about educating for the next next generation than what the next generation is finding in the system that we have, which is not pretty, but which is not without hope. So I was asked to talk a little bit about the role that emergency rooms and hospitals have in the healthcare system, the community healthcare system, and I'll just say that we're kind of the safety net. When all else fails, you can bring people to a crisis center or an emergency room. What we do with them is not always the best. Hopefully, we get folks reconnected with the services that exist in the community, or try to build them as best we can. The whole issue, what to do about undocumented folks, is a very real one. I mean, in Philadelphia, where I work, we have a very large population of undocumented folks, and we have very limited resources that are available to us. And then we try to send them back out into the community, where Dr. Klein has even fewer resources and not nearly as deep pockets. So it's a challenging part of the system, and not one that is receiving a lot of empathy anywhere in our current healthcare system. But again, I'm curious what other people think about the system and how we should focus on making changes. We heard one from about the social work bill, trying to get and every profession has the same kind of thing about loan forgiveness, because the amount that it costs to get us to where we need to be in terms of our education is quite costly in this country, not everywhere else in the world. So advocating for loan forgiveness, but then where's that money going to come from? It's a challenge.
Dr.
Yes.
Sutter, we have an online question.
Yes.
How might the current U.S. immigration narratives and proposed policies, such as ending birthright citizenship, affect psychiatry workforce shortages, given the critical role of international medical graduates in serving Medicaid, Medicare, VA forensics patients?
Yeah, that's a big one, and it's actually very personal, because I chair our government relations committee for the State Psychiatric Society, and one of our members is here on a green card and has decided to step back from her political work just for that reason, because she does not have permanent U.S. citizenship and is worried that she might be targeted. It would sound far-fetched, except we know that the far-fetched has become commonplace. So it's an issue. Birthright citizenship, fortunately, I don't think is going to go away. That would be pretty horrendous if it were. But to get to the specific question, our ranks would be decimated if folks who were born overseas were denied the rights of citizenship. I don't know how we would function. Dr. Thompson.
I just want to comment on the panel itself. It's just community psychiatry is a labor of love, and you guys have clearly demonstrated that. And its spirit and its heart is about doing the work that you have all just been describing. So thank you very much for that description and for all the years that you've put into this. I want to, I'm going to put a little bit of a challenge to us, because Ken, you mentioned the numbers of undocumented people who live in Philadelphia, and the obvious current administration's antipathy to those individuals, and the tendency to deny them even basic human rights. What are we going to do? How are we going to manage that challenge to our heart and our spirit, to deny care to people who are right in front of us, who are human beings, who desperately need it? And yet we're being told by our government that that's illegal and a crime even. What are we going to do? I don't expect an answer here, but I think that is the level of the challenge that we are facing coming at us. The moral injury and the moral decision about what we do, being the community psychiatrists that we are.
I think Dr. Klein mentioned that in her talk about stepping in when COVID hit, and because they had the resources, they used them, but at some cost. I mean, it puts institutions in some jeopardy. I mean, if I see somebody who's undocumented in my ER and they need hospital, I admit them. if I have a bed. Trouble is, if I don't have a bed, then where do I send them? And what I usually do is keep them in the ER until I get a discharge. Or if they're really so impaired that the ER can't manage them, then we admit them to medicine. And then medicine will hold them until we can do that. But I am using resources that I know are finite, and I'll do it as long as I can get away with it. Other comments? All right, well, it's lunchtime. Thank you all for your attention.
Thank you so much. So at this time, we're going to break for lunch. We have about an hour. We will be back at 1 o'clock. Just a reminder, if you need CE credits, so social work counseling, family therapist, please reach out to Lucy Green, L Green like the color, at pmhcc.org for people online. If you're here, you can go see her at the table. If you need CME credits, if you are a physician, we have some paperwork for you that Lucy can share for you for category 2. If you need a certificate of a completion, please also reach out to Lucy. She's going to be your go-to for all credits. Please email Lucy. So again, L Lucy Green like the color at pmhcc.org. It's up on the break information on the slide. So we will see you back here at 1 p.m.
Yes. Yes, unless you prefer to be here.
Okay, we're about to start.
You going first or so? Me, our kennel lead us. Yeah. Oh, good. No, we were gonna leave it up to you. Okay. Okay.
Good afternoon, everybody. Can we get that picture up just there it is. Okay, thank you. This I am really pleased to be bringing this panel to you today about an area that I've been very concerned about for a long time, and we've been able to get 2 really extraordinary panelists to come talk about this issue. Maybe the best way for me to start off is, does anybody know where this is? Anybody want to guess? No, it's not Pittsburgh. It's Brownsville, Pennsylvania. Has anybody ever been to Brownsville, Pennsylvania? Lisa, can you say a word about Brownsville?
It is an economically depressed area. It's an economically depressed area in southwestern Pennsylvania. And they had a hospital that closed, but actually that hospital has essentially reopened. So that's a good thing.
Brownsville is one of the most depressing places you can drive through. And unfortunately, Pennsylvania is filled with communities like this. Brownsville's down the Mon Valley. And there are large numbers of communities scattered throughout Pennsylvania where it's clear that economic times have gone in the wrong direction. If you look at this is a lot of brick buildings that are run down. You can see this obviously in our cities, but it's not just in our cities. It's all over the place. And when we look at this kind of a photograph and we see what's happened to the Capitol, the financial capital, the social capital, what you can also imagine is that the people who are living in this or around this are suffering, right? You don't have this kind of environment and have people thrive. So what we're talking about is large parts of Pennsylvania that are not thriving, that have been left behind. And this is we've been talking about, and I've obviously been talking a lot about the current challenge that we have in the United States, the circumstances that we are in, it has long roots. And some of those roots are in what has happened to communities like this. So this panel is called How to Address Concerns and Empower Distressed Communities for Those Left Behind. And I wanted to have this opportunity to bring this panel here so that psychiatry, mental health could begin to think about what do we do for places like this and the people who live there. And this conversation is really just an opportunity to begin to think and talk about it. I'm actually a little bit surprised that I haven't done this panel many, many times before. It's been on my mind a long time, but I've never really quite found the right terms or ways to think about it. The two people on this panel have helped me get to this point. And I'm going to introduce them just quickly and then turn it over to them to speak. Thad Pulowski is a professor of urban planning at Columbia University. But that's not how I met him. I met him because a friend of mine, a guy named Gary Belkin, is a psychiatrist who's been working a lot internationally and previous to that in New York City around organizing response to climate change and to thinking about what it takes to create a resilient community. He started a project in New York City called Thrive New York, which is a large-scale mental health promotion initiative. He and I have been working together, and he introduced me to Thad in the following way. He said, Ken, I've got a guy, he's working in Johnstown, and he's interested in having a conversation with somebody in Pennsylvania about the mental health issues of Johnstown. So got on a call with Thad and Gary, and Gary asked me, or Thad asked me a question that I'd been asked before by somebody who was working in the Little Washington. You guys know Little Washington? That's Washington, Pennsylvania, just south of Pittsburgh. A woman there had asked me this question, same question. And Thad asked me, what do you do when the whole town is depressed? When everybody in the town is depressed? And then he followed that with another question, which was, and what do you do when all of the young people only dream about getting the hell out? Those were some pretty dramatic questions. And as a psychiatrist, I did not have a particularly good answer for them. I've been looking for them since. So that's how I met Dad. I said, Dad, I got to get you to a conference here and let's talk about this a little bit more. So we're going to turn to that in a moment. But before I do that, I want to also introduce Lisa. Lisa Davis is the head of the Office of Rural Health for the state of Pennsylvania. And I met Lisa on a webinar of something called the State Health Improvement Plan, the SHIP. Any of you guys know what the State Health Improvement Plan is? Well, you guys know, but the rest of you. So this is a little bit emblematic of some of the challenges we have within the state. The state has a giant initiative to pull together people from across the state to imagine what it would take to improve the health of the state. So that's the State Health Improvement Plan. It is run out of the Department of Health. It has very little crosswalk with OMSAS or DDAP that I can find. So we asked Lisa to talk about the mental health issues that are going on in rural Pennsylvania. And she started talking about the same kind of stuff that I had heard from Thad. The challenges of the deaths of despair, suicide, drug overdose, alcohol use, just a sense of hopelessness in a lot of places. So, so Lisa, you got to get on a panel with Thad, and I would love to have the two of you come and talk a little bit about what you're seeing and what you know to the Pennsylvania Psychiatric Leadership Council, so that we can begin to think about left behind Pennsylvanians and what are the things that we in mental health might think about in a more focused way about the challenges in these places. So with that, I'm going to stop and ask Thad to talk, and then Lisa, and then we'll get into some questions from all of you guys. And I think that's going to work.
Okay.
You want to talk from the podium or
whatever.
however you're comfortable?
Yeah, I guess I'll talk from the podium. Hi, everyone. I'm Thad Pulaski. Thanks for inviting me, Ken. I'm really humbled and honored to be with all of you mental health care providers. I admire the work you do, and I'm a fish out of the water here. I'm an architect and urban planner by training. And I spent the first half of my career working in the public sector in New York City government. And I work at Columbia University now. Maybe you can I pull up my slides? Okay, this is a title from, I work at a place called the Center for Resilient Cities and Landscapes at Columbia University. We help communities make long-term plans for climate change. It's at Columbia University. So I feel like this, what Ken started talking about this morning, I feel it very viscerally, like the walls of our institutions collapsing, all these things that we really trust, like government or have, in some formulation in their minds have come to trust, just falling down in front of us. And like Columbia, I feel like the walls are collapsing. Yeah, so it's in this moment of reorganization, there's some future coming, I think, and maybe that future involves more like interdisciplinary, for lack of a better term, like collaboration beyond our field. So when and this is how I came to talk to Ken, is like in my desire to be better at urban planning, helping communities do long-term planning, I realized like we don't know how to really talk to people about the future, because people are traumatized, and I shouldn't be out here talking to communities without trained therapists with me. And so I feel like we've got to build some more bridges between our different fields of work. So anyway, this title for my talk is like very aspirational. That's what we do. That's what my field's all about, being aspirational, like dreaming big about the future. And I'm from Johnstown, Pennsylvania. I grew up there, and like everybody who had some hopes for the future, I left, and it hurts me, I still feel that pain of leaving all the time, actually. Like my parents are still there. They're in their 90s. I was just with them. They're still alive. It's amazing. They're really resilient. But yeah, but that pain of leaving and coming back and leaving again is like kind of constantly with me. And I think that pain is also like present in the place. So here's Johnstown. It's just over the mountains from here, like further west. America's first frontier, really. It's also, that's the town. It's down in the valley, which is consequential. Like the topography is destiny, as the geographers tell us. It's down in the valley. It's also part of the Ohio River Basin, which, 100 million years ago was like a big lake, and it was like rich with aquatic life. And all that aquatic life got compressed under all the sedimentary rock and became coal and gas and oil. So this is like America's first extraction landscape. It's like where the fuel that powered the industrial age of America came from. And when I was growing up in Johnstown, the rivers, and still in many cases today, are like orange with acid mine drainage, complete ecological devastation. The hillsides were denuded of all their forests. Before I was born, the skies were black with smoke, but the factories closed around the time I was growing up, and that stopped. But still, even today, like 8% of the country's energy generation comes from this region. There's a lot of still fossil fuel burning power plants all around. And, a lot of people think the future is in this pattern of industrialization. although that's not really where the job growth is. Even though the state of Pennsylvania gave Shell Oil like $4.5 billion to build this cracker plant near Beaver, Pennsylvania. Anyway, I'm someone that's concerned about climate change, about industrial, about, fossil fuel consumption reduction. But that's also like climate change is almost like a re-traumatization for me. I don't know. I'm going to try to borrow some words from your field. I don't know if that's appropriate, but because Johnstown has this like deep trauma in its past, it's famous for flooding. There was this terrible flood in 1889, and it was completely human. All floods are human caused. There's no such thing as like a flood that's natural, because like nature, water comes and water goes. It's only when you build something there that there's a flood. So, but this flood was particularly man-made because there's like a big dam above the town that was owned by Andrew Carnegie and Henry Clay Frick and all these other industrialists from Pittsburgh. The great the Elon Musk and Jeff Bezos of their time. They own this club up in the hills above Johnstown, and they like stocked this lake, this artificial. They thought it was a lake, or they called it a lake, but it really was a reservoir. It was behind this big earthen dam, and they stocked it with fish, and they like cut off the spillway so they could keep the fish in the dam, and the dam collapsed, and 3,000 people died, and it was a really, it was like a big media event for its time. The telegrams were going out all over the world, and people were really concerned about the Johnstown flood. And there was an amazing, disasters can actually just sort of accelerate existing trends. And that was in a moment of great growth, industrial might of the nation. So Johnstown rebuilt like immediately and thrived with the steel industry. And then it flooded again in 1930. And at this time, it was the Great Depression, and the recovery wasn't led by like the industry, but led by the federal government. It was the New Deal. And they built these big river walls to protect the town. But then it flooded again. The river walls didn't work. Turns out that you can't just put rivers in boxes and expect them to stay there. It doesn't work. Really, if you want to hold water, you have to rebuild the forest. That's what holds the water. But so in that year I was born, 1977, it flooded again. And at this point, this movie Slapshot, which I highly recommend, with Paul Newman. It kind of captures the anxiety and desperation and sadness of the place in that moment. And everybody was just like, fuck it, we're leaving. Like this is too much. A lot of people, and then the mills and the steel industry felt that way too. And also matched with globalization, they, systematically disinvested here and in Braddock and in the Mon Valley and Bethlehem. It was like a great exodus of industrial jobs, which we're still feeling the trauma from today. And in fact, somehow, some of the economic trauma that we're all seeing in our 401ks and in the news every day is actually a sort of Trump's tariffs are a response to this old trauma. And so anyway, this is my dad. My parents stayed despite this economic collapse, and they had, dreams about the future. And that's my mom and her kids, me when I was young. And my mother started a ethnic arts center in this town when I was a kid. She took over an old factory and said, if the jobs are gone, we're going to use these buildings to create a new kind of economy based on things that bring people together, arts, our different ethnic traditions. My grandparents were all born in Europe. They're all migrants. Everybody in this town comes from somewhere else. We're all migrants. And part of the bargain of entering white America, to accept the kind of all the benefits of home ownership and suburbanization, is to sacrifice your identity. you know? And so my mom saw this kind of erosion of identity as a real degradation of our community resilience. And so she wanted us to embrace our different traditions and identities, whether we're from Eastern Europe or Africa or South America, to bring that to this town and celebrate it. Our differences can unite us in a shared humanity. So that's my mom. She's still doing this work today. This is the Bottle Works Ethnic Arts Center in Johnstown, Pennsylvania. And recently she just started a new art gallery at the age of 83 in downtown Johnstown. Right now, just a few things about what's happening there. It's getting wetter. This whole region's getting wetter. Oh, is that my time? Okay. 5 more minutes, sorry. Okay. Johnstown's getting wetter, which is like all the eastern United States. The west is getting drier, the east is getting wetter with climate change. And that could be an advantage in some ways, more flooding for sure. But an interesting thing is that, well, when the factories closed and the mines closed and people, and it wasn't just my mother, she's just an example, but a lot of people started to think about different kinds of models of economic development. The other thing that started to happen over the last 30 or 40 years is that nature is rebuilding. Nature is regenerative. The forests are rebuilding themselves. The rivers are rebuilding with a lot of help from the government, by the way. Pennsylvania's cleaning up the water with, you know, treatment centers and forestry programs. So we can move from, you know, an environment of extraction to regeneration with nature's help. So I've been going back here a lot with my students from Columbia University to have conversations about the future of infrastructure, rebuilding the economy of this place. And a few years ago, I did, you know, in the first Trump administration, we did this like Green New Deal studio for Appalachia, like how could a Green New Deal, if it ever comes, how could that, you know, create jobs in renewable industry and other kinds of sustainable agriculture and community colleges for everyone, all the tenets of the Green New Deal, which later became, frankly, the Inflation Reduction Act, how that could provide a new model for economic development. And, you know, it wasn't so well received by everybody, but, you know, some people put some of those ideas into a grant application. It turns out the town got about $50 million of Inflation Reduction Act money to build infrastructure, and including this RAISE grant. So I helped to lead the town through a community planning process for using this infrastructure money to build a new kind of economic future. And so it went from like the kind of laboratory stage to the implementation stage, and I had a lot of very intense community conversations about rebuilding the main street in the Central Park in the middle of the city, like trying to rebuild the spirit of the place through the public space that everyone shared. And I, you know, worked with a lot of different kinds of people. Very important to work with young people, you know, because those are really our you know, who we're trying to serve with infrastructure and urban design and community planning projects with these people, trying to keep them in town. But then also with veterans. The veterans showed up at our first public meeting really pissed off because they thought we were going to throw all their war monuments away. And that was not the case. I was like, no, we're here to talk. And they didn't believe me. I had to like go to the VFW and have beers a few times and just get to know them, and then learn about all the different monuments and how we could like not just, you know, serve the monuments well, but really create a space to reflect on their service and sacrifice and just the concepts of service and sacrifice and the things that bring people together. And so the veterans became pretty big advocates for the project in the end. And then the jaded young people, all the people that were like sending out their resumes to go work in Pittsburgh or Philadelphia, trying to talk to them, and they were like, nothing's going to happen. We're not interested. No one gives us power. And I was like, no one ever gives anyone power. You have to take it. So we put these ideas together, had this like community planning process. And yeah, and then so I'm going to keep bringing my students back here. My students come from all over the world, and I have them work with different community partners on the next generation of projects like these. And yeah, I'm looking for people to partner with. That's the last thing I'll say, is that like, want to do more of this work in small towns throughout Appalachia, Western Pennsylvania. So yeah, I'll leave it there because I spoke for a little while, but here's a website for our work at Columbia, and thanks for listening.
Hi, everyone. I'm Lisa Davis, and I am delighted to be here. I'm going to see if I can pull up my slides. Oh, I can. Somebody did that for me. Thank you. I can tell you that many, many years ago, the person who started PPLC, David? Yes. And I had lunch in State College, and I was so very, very glad to meet him, and we had just a delightful conversation. And I have been very fortunate to be on the distribution list for every single meeting that you all have had, none of which over 20 years or however long it's been, I've been able to come to. But I'm really glad every time I see L Green pop up in my email. I'm really glad to see it. Yep, yep. I want to tell you, before I talk about what I'm going to talk about, I want to tell you just a couple of personal things, and that will demonstrate how grateful I am to the field of psychiatry and mental health for all of the work that you did and have done over the years. So I grew up in Pittsburgh, and then I went to high school in Little Washington, otherwise known as Washington, PA, or WashPA. And I was a single child living with a single mom. My mom had been severely depressed her whole life. When I was 13, she told me that she was raising me so when I turned 18, I would be completely self-sufficient, and then she could kill herself. So that was something that, note to self, keep that in mind. And so we were living in Little Washington, and I was about 16, and my mother was so severely, severely depressed. That was not for effect, just so you know, that finally she got referred to a psychiatrist, a Dr. Leibowitz in Pittsburgh, and he prescribed her, I think it was trazodone. Would that have been one of the first antidepressant? It was back in, excuse me, this is going to tell you how young I am. It was in 1975, I think. And that changed her life. And I was so grateful that when I finally met Dr. Leibowitz when we were in Pittsburgh, I actually burst into tears and started hugging him because he had given my mom back to me. So that, I just want to say thank you to all of you for everything that you have done over the years. And in listening to the conversations that took place right before lunch, it's amazing how what you all are experiencing, talking about psychiatry and services and payment and workforce, mirror exactly what we talk about in rural health. When I started in rural health almost 31 years ago, workforce was the #1 issue. 31 years later, workforce is the #1 issue. And one of the challenges that we have is attracting and recruiting mental and behavioral health providers and psychiatrists. And even though we have internet, even though we have telehealth, we still find that it is really challenging, even if we are doing something virtually, to be able to bring healthcare services to rural communities. So I just want to say thank you to all of you for everything that you do. So what I'm going to talk about is a really uplifting conversation about farmer and rancher depression and suicide. And much of what Thad just talked about, I think, is really important for when we talk about rural communities, because just like in urban areas, or just like in Johnstown, which I drove by all the time and am sort of related to UPJ, what we find in rural communities is that everything revolves around church, school, and the community at large, the service organizations and so on. Many years ago, we did a project looking at farm worker injury and fatality and what the economic impact was. And we found that the farmers who we were talking about were the central part of their community. They are so important. And so when we lose a farmer or a rancher, it reverberates not just across the family, but across the entire community. So what I want to say is that I just want to start by saying my whole point of all my work has been to say that rural matters. It really matters. 20% of the population in the United States lives in areas that are rural, and that covers 80% of the landmass of the U.S. Here in Pennsylvania, we have 67 counties, 48 are considered to be rural, and we were just having a conversation about what's rural and what's not rural. It all depends on one of the 40 definitions that you're using, but those of us who work in rural health have a pretty good sense of what is and isn't rural, and we know that these rural communities are the backbone of the country and also of our state. So I say to everyone when I start talking, if you woke up in a building this morning, chances are you had rural to thank because it was built out of wood somehow. If you had breakfast, or if you had lunch, or if you're about to have dinner, you have rural to thank because even though we have urban farms, most of what we eat is grown in rural. And if you are wearing clothing, which I can see that most of you are, which is good, if you have any natural fabric in what you're wearing, you have rural to thank. So rural is really the backbone of what we have in this country. I understand that we have the Liberty Bell here in Pennsylvania and all of that, and that's really important. But rural is where so many of our keepsakes are kept, where we have our culture. And when we talk about Appalachia, Appalachia has brought so much to the United States. And what we also say is that your zip code should not determine your house status. And it should also not determine not only how you live, but whether you live, because we do know that zip code and access to care are very closely aligned. So I want to tell you about one farmer's struggle. This is from Wisconsin. 57-year-old Leon Statz committed suicide in October of 2012 after financial struggles forced him to sell his 50 Holstein dairy cows and to begin to look at beef farming, which he did not want to do. So this is very much rooted in what we see as rural values, connection with family, connection with community. So he had started a part-time job, which we know is also very important to farms. But his wife later said that he was punishing himself because he felt so awful. He felt that he had let everyone in his family down, including his parents, his children, his wife, and his community. So I have a little bit of a video here that I want to show you. And in theory, this is going to work. I heard that it will work, but I don't know how to make it work. Oh, do we have audio?
Highest yearly rate of suicide on record. What leads to someone's suicide can be a mystery to loved ones because they were reluctant to talk about their struggles. Special correspondent Megan Thompson reports from Wisconsin on the burdens farmers often have to deal with and what's being done to help them.
All of them are that buffy tan. They're so pretty. I hear ya.
Days start early for Brenda Stotts.
Usually 4:30, I'm wide awake. And so I get up, get chores done, usually do chores in the dark.
Stotts runs this 300-acre farm in southwest Wisconsin with her 2 sons and her daughter-in-law. The farm's been in the family for 50 years. Brenda's husband, Leon, inherited it from his parents.
We met in 1981, my senior year of high school. He just loved the kids, loved the farm, showing them how to farm.
But farming is a hard way to earn a living. Brenda works a second full-time job in town to give the family health insurance and extra income. After the birth of her second son in 1989, Brenda left her job for a while to care for the kids. Leon and the farm became their only source of income.
He told me that one day, he says, if I fail, we all fail. And that's when his first bout with depression started. He couldn't function, couldn't get up in the morning, couldn't get down to the barn.
Leon struggled on and off with depression for years, the weight of running a farm at times overwhelming. In 2017, the Stottses sold their dairy herd and started raising beef cattle. But Leon came to regret it.
He said, I should have kept my cows. I'm a failure. I wasn't good at farming, even though we were financially, we were fine, but his mind would not let him see that.
In October of 2018, Leon Stotts took his own life.
Whether he's here or not, somebody still had to get up the next day and feed the cows. Somebody had to get up and do the chores. The crop still had to be harvested that year. There's so much that has to do. You didn't have time to just stop and. Didn't have time to grieve, really. No.
Farmers are 3.5 times more likely to die by suicide than the general.
So that's just one story that is replicated across the entire United States and across Pennsylvania. And so Leon said to his wife, I'm a failure. I wish I hadn't done this. I wish I could go back and change. And he said, it's like you're at the bottom of this hole, this pit, and you can't see the top, and you're climbing and climbing and struggling your way to the top. And just when you get to the top, it gets higher, and you keep climbing, and pretty soon you get tired, and you just can't climb anymore. And his son is the one who found his father dead. And so I know none of us wish that on our children or anyone in our family. So farming is really big business. Farming is actually one of the top economic drivers in Pennsylvania. And across the country, there are 1.88 million farms. Well, there weren't in, wait a minute, sorry. I had to put my glasses on and then I got completely confused where I was. So in 2024, that should have been 2024, there were 1.88 million farms in the country, and that was down by 8% since 2017. And even though we think about these really large farms that are out in the Midwest, about 90% of farms are family owned, meaning that they bring in about $350,000 a year in gross income. And what we say about farmers is that they are resource rich and cash poor because they are often ineligible for Medicaid or to get their kids on CHIP or whatever because they have so many resources. So across the country, the farms have contributed $1.5 trillion in gross domestic product. Here in Pennsylvania, we have about 8,800 farms, and that's down 200 from 2023. All of you, I think, have heard about the avian flu and so on, and some of those chicken farms have had to close. That represents about 3% of total gross domestic product in Pennsylvania. And the total amount of economic impact in Pennsylvania is about $132 billion. And I can tell you that we have standards here in Pennsylvania for food production that are actually copied by other states. I was in Scotland and I picked up some shortbread, and it was licensed by the Pennsylvania Department of Agriculture. So it's recognized across the world. Most farmers receive off-the-farm income, and that for many is absolutely essential because for some, that is where they get health insurance, just like Brenda Stotts. So there are a myriad of agricultural pressures. I'm sure all of you have driven by farms across the country, across the state. What I always say is it doesn't matter if it's June or January. It is always snowing. It's always raining. It's always cold. It's always the middle of the night. You're always tired, and something is always broken down because that's generally what it's like. So there are financial pressures. There are pressures from the farm. There are pressures that are both within the family and external to the family. I've heard farmers being interviewed since the tariffs have gone into effect, and they are worried because they don't think they're going to be able to either sell their goods, or they'll be able to buy what they need, or they will not receive the funds that they had been promised. Well, I heard one farmer from Nebraska say that he had spent $400,000 on equipment because that had been guaranteed him, and now he's concerned that that funding won't come. Machinery breaks down all the time. And also, farmers are out there working by themselves. And I can tell you that farming is one of the single most dangerous occupations across the country. Farming, mining, quarrying, logging, they're all the most devastating and difficult. And I can tell you from Center County, where I live, about a year and a half ago, we had an Amish farm family that had a son get run over by a buggy. About 6 months after that, one son went up into the grain bin. He became overcome with the gases that come off of grain. He fell into the grain bin. His father went up to rescue him. He fell into the grain bin. Another brother ran up to get the son and the father out of the grain bin, and he died. So there were 3 people who died in one day, in the space of 20 minutes on one farm. And a friend of ours lost her husband because he had been working clearing big rocks, and something had fallen off a front loader and had crushed him, and he was fine because as you all know, if you're physicians, you know that if the blood is cut off and you don't bleed out, everything is fine. He called his wife, he called 911, and his friends thought that they were doing him a favor, and so they lifted the rocks off, and of course he bled out within like a minute. So it is really, really challenging. We know that there are people who have lost arms because they have put their hand into an auger and a sleeve has caught, and so they've lost their arms. I mean, it's really dangerous work. But they are so committed to the work that they do. So, as I was telling you, it's a very, very, very dangerous occupation. And we also have programs not only that help with first on the farm and first responders and ag rescue and so on, but we also have programs in the state that work with farmers who might get something called milker's knee because they are up and down so often. Or they've had, let's say, a car accident and they can't keep farming, but we get OVR in and they will help make changes on the farm. And this seems ridiculous, but I cannot find data on how many farmers have committed suicide in the country, and I can't find them about how many farmers have committed suicide in Pennsylvania. I'm sure that those data are out there, but I just can't seem to find them. But we do have a reporting process at Penn State, which looks at non-suicide fatalities in Pennsylvania. And in 2024, we had 19 ag fatalities. These are just the ones that were reported. But I wanted to show down at the bottom, as you can see, the largest proportion of individuals who have died are 65 plus. But what is really heartbreaking is that we have 26% of fatalities from 2024 that were from age 0 through 9. And I know, well, I won't tell you any more gruesome stories because we just had lunch. Most of them are male. And we also have a very large Anabaptist population here in Pennsylvania, which are the Amish and Mennonite. And they account for about 42% of the fatalities in the state. The rate of suicide among farmers and ranchers is 3.5 times that of the general population. And over the 20-year period from 2000 to 2020, suicide rates climbed 46% in rural areas versus 27% in urban areas. And most of well, almost half of the suicides were by persons over the age of 65. And part of what we see is that there are so many, there's mounting debt, there are mounting pressures. There's always that question of what if. There are things that one can't control, and there are things that one can control. What about flooding? What about drought? What about windstorms? What about, the locusts that come out every 17 years? I mean, there are all sorts of things that farmers cannot predict. What about things like avian flu, which is going across Pennsylvania? What about if we lose the bees because now they're not going to be able to pollinate? So what we see is that even though farming communities are very close-knit, we have the Farm Bureau, we have all the women's auxiliaries, and farmers are very entrenched in their communities. These are not things that they talk about. They don't sit down with their best friend and have a cup of tea and say, you know what, I'm really feeling sad today. That just absolutely does not happen. And so they can feel very, very isolated and very alone. And even though I'm sure they talk across their groups about what's happening across their community, they don't share that information. So some of the signs of depression are changes in routines. Let's say, for instance, that, Joe is always at the coffee shop in the morning at 6:30 a.m. And by the way, if you want to find out what's really happening in a community, go to the coffee shop that has at least 6 calendars in it. Okay, it doesn't matter if it's the current year, but that is where you will find out what is happening in that community. And that's often where farmers are hanging out. So Joe doesn't come. He has, where's Joe? I don't know. I haven't seen him for a while. Oh, he wasn't at church the other day. Well, he didn't come to the county meeting. If you are driving by and it looks like the livestock have declined, let's say that they look as if they are unkempt, or the property looks as if it is unkempt, and maybe there's split rails that have fallen down and so on, that might be an indication. Or if there's an increase in illness, I'm sure all of you who work with those who are having some significant mental health issues may experience also physical health issues. If there's an increase in the farm or ranch accidents, those can also be signs of distress. And just like with anything that we have all talked about and we've all learned, if you see something, say something. There are a lot of resources out across the country and also here in Pennsylvania to target farmers who are experiencing depression, isolation, suicide ideation. Please reach out to them or reach out to any of these groups that are on here. There's a program in Iowa called the AgriSafe Network, and they have a whole set of mental health programs just for farmers. We have an AgriSafe nurse in our office who also works with the agricultural community. So get this information out there, because remember, rural matters and the people who live there matter as well. So thank you very much for your time.
So we have some time. Is that on? It's on, okay. So we have some time. Anybody have any questions or thoughts? It's while you're thinking about that, I do think that this linkage between left behind communities in rural Pennsylvania and the farming crisis that's been ongoing and continues to persist in Pennsylvania and across the United States are interlinked and present a real challenge to the profession of psychiatry and to the mental health world in general, because we have really not spent a lot of time thinking or talking about what's happening in the rural parts of America. And I think we're paying a price for that in lots of different ways. So for this group, I hope we can consider this the beginning of a conversation that we continue to address as we go forward. I'm not going to leave the cities behind, but we need to make sure that we don't forget the places that, as Lisa makes a very good point, we wouldn't be here without. So, yes.
Lisa, I wanted to say I spent most of my life in rural Kentucky, specifically in Appalachia. I'm the daughter of a bee farmer, grew up on a bee farm. So lots of, like, that message really resonated with me, what you were saying. You were wanting to know about statistics revolving around like farmer suicide. I wanted to know if you were familiar with the Agri-Stress Network.
I am. Oops, I don't know if I'm on. I am very familiar with that, but I couldn't find any information there. And the Agri-Stress Network is national, but we also got some funding here in Pennsylvania from the U.S. Department of Agriculture, I think, several years ago, that went to the Pennsylvania Department of Agriculture to set up an Agri-Stress network here in Pennsylvania that has an 800 number and so on, and had some psychiatric nurses who were doing some work around the state.
I did some research with Natalie Roy over there for a while.
Oh,
and
did
I
you?
almost took a position with them before I came to here and came to PMHCC actually. So I was just mentioning I figured with the work you do that you were familiar with them, but they also have a specific like suicide and crisis hotline for farmers. And it's run by volunteers who have lived experience and people who are familiar with the rural community for folks who may not feel comfortable dialing 988. Or the Suicide Prevention Lifeline. They can call and talk to someone who is familiar with some of the same struggles that they're going through. So I really like the work that they're doing. And I thought you'd appreciate it if you didn't already know.
Thank you so much.
Thad, I wonder if you could talk a little bit about what the people of Johnstown want to have in their resilience plan.
Yeah, well, I mean, it's, always hard to represent, a diverse population, which is, part of the work we try to do is get voices that wouldn't normally feel comfortable speaking up at a city council meeting or in any kind of formal process to feel empowered to speak. And so what comes out of that kind of work is not like a singular, set of objectives, but more, we start with values, and those values are, I would say, nonpartisan. Like it's a very, like Trump, or it's like Obama Trump country. It's like blue dog Democrats that became overnight really enamored with the message of "Make America Great Again," and so that there's a political complexity there that you always have to navigate. And so the values, though, like supersede all that. Values of like caring about each other, attachment to nature, and resilience as a value too. Like people, they use that word, which is uncommon. In most places people would say, oh, like in New York, people say we're tough, but in Johnstown, because I guess all the floods, they say we're a resilient community. So that's a fundamental value, I would say. And then from there, it's like, okay, how do we take our values and turn them into action? And that involves infrastructure. They were like, great, Inflation Reduction Act, build us infrastructure. Now they're like, great, tariffs, build us infrastructure. I think that's the I would say problem solving is a kind of like principle of the resilient city for Johnstown. I don't know if that helps, but
I want to just to make the fine point of it, that the underlying link that we're talking about here between the farming communities and the left behind places of Pennsylvania are the trauma that people have been experiencing and this sense of not having a voice. So I think these questions about what it is that people are aspiring to and being aspirational in how we think about these places and the people in them is part of what we need to learn. On the mental health side, I think we also need to learn how to think about places as the place that we work, and that it isn't just the individuals who come in to see us. It is the whole gestalt that they're living in, and the opportunities that they have in that place to make their voice and their lives visible, to be participants in and creators of the lives that they live, and not to feel like they've just been neglected and left behind. And that's a trick that I don't know that we can do any better than to at least recognize that we need to figure out how to pay attention. Not that we're going to tell them what to do or how to do it, but we at least need to be part of the journey and in the process of listening. And I think that's what you're hearing today. Aylin.
Also, what I get out of observations from my part from what you're saying, that there is a lack of sense of belonging, from what I understand. Like, for instance, you're trying to create belonging for them, but they feel that there's no belonging, therefore they kind of have a depression, therefore go through all these different steps that we're talking about. I want to know, Thaddeus, from your experience being a city slicker, somebody from the New York State comes over, although you're from Johnstown originally, comes into a small town. How do they take that? Like, I know there's open conversations, but they might say, you're from a big city, you're not from part of us, you left.
Yeah. No, I get that all the time. I always say, I never left. Like I go to all over the world and talk about Johnstown. Like it's just like constantly imprinted in my mind. So even though I don't always live there, but yeah. Well, I guess the other value that helps with the kind of dealing with the outside, and you must have this, too. I mean, wherever we work, where we're not from there, there's always this challenge. And I think one of the things, a value that's hard to locate, but resilience means embracing change, and embracing things from outside. Like a lot of us are freaking out right now about what's going on in the world. And part of what I think I need to do to tell myself right now is like, the world is changing. The old world is dying. The new world is struggling to be born. And we've got to embrace change. Like, we have to change. And I feel like people in Johnstown are like, this place is messed up. We know it has to change, and that's hard to do when everything around you is like in ruins. And I think that what, at least when you were talking about at the very beginning about like just the depression in rural communities, it strikes me that's strange that people who get to work with animals and nature all day and cultivate the land wouldn't find so much joy in that. But then you do see it, that like these places are falling apart. We can just see it driving down rural roads in Pennsylvania, how barns are falling down. And you see that evidence of inertia. And part of what I feel like maybe this whole crowd of people and people working in your field can do is help people embrace change. Not that like, to go back to making the barn straight again or making the country great again, but to like embrace a new world.
My other question's for Lisa too. I was wondering, what is the role of pastoral counselors in helping those who are farmers who are going through their bouts of depression, mental health problems?
The role of what kind of
Let's
counselors?
say pastoral counselors. People
Oh,
from
yes.
churches, like what is
Yeah.
their involvement and how have you seen that work?
So we always, I really encourage that anyone who's trying to do outreach in rural communities always go through the faith community, because that is such an important part of rural communities. So actually, this project that we did years ago looking at farm worker injury and fatality, we were hearing from farmers, I am not putting on a rollover bar on my tractor, even though that's the number one that's the number one injury and fatality reason. I'm not putting on my seatbelt. I'm not blah, 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 right? So we actually put those messages into the bulletin so that they would get those messages essentially from the pulpit, and that because they have so much respect for their pastoral community. The other is, and nothing against you guys, but there's all the women's auxiliaries out there and they are a powerhouse. And I wouldn't mess with them if I were you, right? And so if they decide that something is going to happen, they are going to make sure that it happens through the firehouses and through the churches. Those are really great places to go if you want to get some information out and be able to even, you know, talk with like the interfaith councils or whatever. But I want to say something else too about rural communities, because I feel like I would be remiss if I didn't do this, is that what we say about rural communities is that they do well either because of or in spite of any sort of outside influence, input, whatever they might have. They are incredibly resilient. They are incredibly creative and work very, very well together. And yes, we do have downtowns in these small rural communities that are boarded up. But I can tell you that in places like Bradford, Pennsylvania, up in McKean County where Kinzu Dam is, that they have come up with a solution to actually have some sort of a lottery to have people come in downtown Bradford and open up storefronts. They have 150 more applicants than they have space for. In beautiful Coudersport, Pennsylvania, which is in Potter County, which is the rattlesnake capital of Pennsylvania, just so you know, they have opened up things like coffee shops that have high-speed internet access because they can't get a high-speed internet access outside. So there are lots of really wonderful things going on in rural communities. And so I would be completely remiss if I didn't say that. And that, yes, there is despair, but our despair in rural is, I don't think, any different than despair in urban.
Marion.
So thank you very much. I grew up in Meadville, Pennsylvania, and I still have a brother that lives in Harmonsburg. It's a little burg, a cross section. And now I live in the big city of Erie. The thing that I wanted to just hear your input to is really along these similar lines. We earlier were talking about virtual resource for providers, for psychiatrists and therapists. And without some kind of introduction, understanding that what this environment is that a person lives in, no matter what. So even if I would say you are beaming into a city or a neighborhood where you're going to be providing care, the importance of how do we help our practitioners understand how do they get immersed? What would be the ways? And you started to talk about some of those ways. Lisa, with you know, the women's auxiliary and the so getting to know, or how to get to know the communities where you might work, but you might not live.
And can I tell just another quick short story? When I was first out of college, I was working in a community-based residential treatment center with schizophrenics. And then I moved to working in trying to do job placement with many of the same clients that I worked with. And there's a family in Center County that was just, you know, notorious, right? You know, I mean, they just had a horrible situation, lots of incest. And so, you know, and it was just terrible. And they had some bright shining stars in their family. And I remember talking with one of the clients, and she had come to me to talk about looking for work and how challenging it was. And of course, you know, they all had, you know, there was sort of, I mean, they had everything that you would think about you would have if you grew up in extreme poverty, and including poor dentation. And so I said to her, you know, well, maybe, you know, about brushing your teeth. And she was so embarrassed and she was so ashamed. And I was so ashamed because I was approaching her situation as a girl who grew up in, you know, Mount Lebanon, Pennsylvania, and, you know, who had health insurance, who went to the dentist, you know, and I have never, ever, ever forgotten that lesson. And I still, that was 30 some years ago. I am still apologizing to her all the time. So I think you're absolutely right about understanding what the framework is that the person you're speaking to is coming from. And I think that's one reason why telehealth sometimes can be really helpful, because if you are working with someone in their home, you can actually see what their home looks like. And you can get a sense of who is there and what are some of the issues that they're dealing with.
Ken.
Yeah, I wanted to raise the issue about telehealth very specifically. I mean, we think of it as one of the solutions to access issues, but that's our solution. Is that something the communities want? Do they value? Can they use it? I mean, I worry when I hear about the lack of high-speed internet access. It's very hard to do video without high-speed internet access. Are we mistaken to think that virtual is the way to go?
I'm sorry, I feel like I'm the one doing all the talking. But so when telehealth first came out, it was viewed as sort of the, you know, the light at the end of the tunnel that was going to solve all access. And it is not a panacea for in-person access to care. But, you know, flash forward to 2020, and suddenly virtual care was essentially the only kind of care that any of us could have, and it became enormously popular. And I think Medicare saw something like I want to say a 50,000% increase in the number of telehealth claims that they were getting. That might be a total exaggeration, but it was really close. And what they ended up doing was to recognize how challenging it was to reach rural communities and also to reach older persons via telehealth. They used to require that there be a face-to-face contact by video, and they did away with that. So that became a waiver, and some of this we hope will continue to remain permanent. But now that the pandemic is over, the virtual health is still very much requested, but people are really beginning to move back toward in-person. I do want to say through the Infrastructure Act, so thank you, sir, for whatever you did with that. Pennsylvania received an enormous amount of money and developed the Pennsylvania Broadband Development Authority, and they are just getting the first grants out now across the state with a specific focus on rural. So we hope to be able to see high speed across the state.
One of the challenges I think, Ken, that you're alluding though to is that, and I don't know how to square this, is that, you know, to put it in combination with Mary Ann's question about becoming engaged with or related to the communities that people come from, is that the telehealth is obviously you're at great remove potentially, particularly from the rural communities. And I don't know how we help people make the larger connection that I think actually gets helpful. And maybe it sounds like a strange thing to do, but it probably is a good idea for a community psychiatrist to visit the various pastors in the community. It's probably a good idea for the psychiatrist to go visit the volunteer fire department. It's probably a good idea to visit the Women's Auxiliary or the Grange, or whatever community relations, you know, community organizations there are, just to be a known person. Now that's a heavy lift, and most psychiatrists don't think about that. But I do think it's actually the way that we begin to have an idea about two things. One is the life world of the people that we're actually trying to be helpful to if we're in those settings, but also because I think it helps put together an imagination about what the resources are that are in a community that can be pulled together to do things in the way that Thad's mother was doing, right? Pulling together the art center, which, by the way, just to reflect on, I was thinking about this in particular because I'm about to go visit my mother on my drive home. She's in 97 and in a nursing home right off the highway, which is very fortunate today, right outside of Pittsburgh. But I did think about the impact of parents, both for good and for bad, and the challenges that they confront to us in helping us carry some of this capacity to address the challenges of the communities that we're looking at. Maybe there's something in those connections that tie to what these communities are actually about, which is some sense of past tradition and connection that we all have in our own lives and we can imagine other people have in a way that might help us think a little bit better about these places that have been left behind.
Well, you know, I tell my students in urban planning, you know, that it's intergenerational work, you know, and I always have them reflect on where they're from and what their families have gone through over many generations. I don't think you can like work anywhere authentically unless you're in touch with that. Because it takes many generations to make a place and remake a place. But you know, on the this is totally out of my field, the virtual care thing. I don't know anything about this, except that I will say in Johnstown, in lots of places, the more time people spend on their devices, I feel like is a major threat to the ability to build social cohesion, social resilience. Facebook is a cesspool. We should all delete it like immediately. That social media is a virus that is affecting these communities like in a horrible way. And like it used to be like, oh, maybe it's good for some things. No, it's not. It's really bad. It's spreading so much misinformation and lack of trust. It never got any regulation, and it's turned into something that could have been a public utility into something that we really need, like all of us as citizens need to think about breaking up these big tech companies because it's a real sickness. And I feel like it's spreading, you know, it's probably affecting your ability to give care to a lot of people, I would think. So as an urban planner, like the coffee shops, the main streets, the churches, and the schools are so much more important now as we struggle against Mark Zuckerberg for the attention of all the people that we're trying to make lives better for.
Do we have any, I just want to ask, just so I know, do we have anybody online who's asking any questions or anything? Okay, good. Go ahead.
So
sorry.
one other potential avenue, I think, for some really great outreach is through community health workers. Have any of you ever done any work with them? Do you know what CHWs are? So I think that CHWs are really the unsung heroes of healthcare delivery lately. And there's been a group of us across the state that have worked for years to try and get community health workers integrated into healthcare policy, payment, and practice, because I think that is one way to be able to do bidirectional outreach. So you, as the provider community, engage with the CHW, who then is going out into the community and seeing Mrs. Smith in her house, and then bringing that information back. So I think that's one really great way. The other is we have seen in some communities the use of paramedicine as community outreach, and taking paramedics and first responders and taking them out and putting them into homes, having them do home visits, especially with older persons, to do things like clean out the refrigerator for moldy food and look at trip hazards and so on. So there's lots of ways to be thinking about getting your expertise out, and then you also getting some input from the populations you're serving.
Those might be interesting panels to have on how we might work with CHWs and paramedics.
My next comment is just a purely personal one, and that is the role of porches, and that we have lost the role of porches. And I just lament, growing up, that was the best.
Porches are the best. Yes. Bring back porches. I worked on flood recovery in New York City after Hurricane Sandy, and we had to change our zoning resolution to allow for people to build higher houses. Like we had 20,000 houses that were destroyed after Hurricane Sandy. And so we wrote urban design requirements, because once you elevate a house, then there's no relationship between the house and the street. So we required porches in the reconstruction and help people pay for them.
We have a question in the chat from Jess from Westmoreland County. She said, what we are seeing is adult children whose parents have either passed away or are no longer able to care for them. These adults are very sheltered and have been cared for their entire lives. And now they are entering the mental health system very late in life. This is a huge transition and getting supports and services in place are challenging on both ends. Just curious if this is something others are seeing. Have there been any discussions or resources to help this population?
So the population is adults who have been, do you have any?
Isolated older persons.
You know,
Yeah, so adults whose parents have passed away, but they're the ones that have been taking
Okay.
care of them, so they
So
don't
they're,
really.
they're adults with a psychiatric issue previously.
They
who's
think
older.
that adults are very sheltered. It didn't say that.
Okay.
But yeah.
yeah, like if you're the primary caretaker for your older parent and then they pass away.
Yes.
Yeah.
Yeah.
Like my Aunt Wanda took care of my grandmother for 40 years and then she died. And my Aunt Wanda's reason for living was like, what do I do now? You'd think it'd be very liberating, but it's not always, right? Is that what they're talking about?
Well,
Yeah.
can I tell you a quick story? I'm so sorry to be telling stories, but CEO who had come to a health system here in Pennsylvania had come from San Francisco, and he was now in rural Pennsylvania, and he'd never been in a rural area before. And so he was going out with the home health nurses, and they went to a farm, or they went to a house that was at the end of a long road. And, the house had, the front door was nailed over, and there was a freezer sitting on the front porch. And so there was the mom and the dad, both of whom who had, every chronic health condition you can think of. And then Bubba, the son, living behind in the trailer. And when the CEO and the nurse got to the house, the Bubba and the mother were at the hospital because she was getting some work done. And of course, they came home with big tubs of Kentucky Fried Chicken and walked into the house. And the CEO, like, he just could not get over this, okay, how this whole system was set up. And then he said to them, "Why is the front door nailed over?" And they said, "Oh, well, the bear came on the front porch and tried to get at the deer meat in the freezer on the front porch." And he was totally, he kept saying, "A bear. There was a bear." And I said, yes, believe it or not, that, we have those. It's not just in Goldilocks. So I think, understanding your community is everything. I'm so sorry. You were raising your hand and I just kept on talking.
No, that was a great story and better than anything I had to say. However, I want to say I spent a lot of time in Connecticut and I've had bears on my porch. Running across the grocery store in New Hampshire. So bears are real. I wanted to say that thank you both so much for your presentation. And I like everything that Thad said except one thing. When he started and he said, "I don't know how I can even think about walking into this community without a mental health counselor by my side." And I thought, are you kidding me? I thought you are doing the most important work yourself going into that community. And Ken brought it up again with everything your mother has done. That is fundamental primary prevention mental health work. And it is rebuilding the life of the community. And you guys know it inside and out. And it doesn't need, nor is it best done by professionals. And you've pointed out in the stories that you've told that it is done within those, units of civil society and those little dibs and dabs of community that you're working so hard to strengthen and support. And I think, the model of you bringing, what I can imagine to see your highly progressive students from Columbia into Johnstown in a way where there is mutual listening and respect and building from people to people is just tremendous work. I really want to applaud you and thank you for doing that. So that we can have save the professional mental health workers for people like Lisa's mom, who really has that level of severity that we touch. So I just want to thank you and say.
Kathy, I'm gonna
Thanks.
push that just a little bit though. Because I think actually it's easier to walk into the community knowing that there's somebody like you engaged with and believing what you just said. So for somebody like that to make it happen, having somebody like you who he knows, who he can refer people to in the case that we were just talking about, that's very helpful. And the other side of that is if you walk into a community and you're trying to take care of somebody, or you're trying to help make the community be the better place that it can be, is to find the people who are like Thad and his mom to work with, to make the community a place that people can live. Because I think it sounds a little bit too much. I know you don't mean this, but it sounds a little bit like you go do your thing and I'll go do my thing, and that they don't intersect. But I think they actually actively intersect all the time. And it's in the lack of intersection that we may make trouble for ourselves, just as a thought.
I mean, one addendum to that too, and I appreciate it so much. Those are very kind words. Is that I worked with communities after disaster, particularly in New York after Hurricane Sandy, and had like, community meetings like a month after the storm. And, people showed up really agitated. So in that case, I was beyond my capacity to, to help, like, what do you want, a porch or not a porch? And they're like, my life is gone. And so I was sort of at my limits, and I think that often happens. So that, again, to Ken's point, maybe that deeper collaboration there, but also, to Ken's initial prompt for this session, like what do you do when everybody's depressed, like, and that has felt to be the case, in many situations where, to show up at a public meeting and say, here's this great plan for the future. And everyone's like, nothing's ever going to happen here. This is all just another failed promise that you're making. And we know how this is going to turn out. And so, I feel like I'm not addressing the root causes with my fancy plan for the future. There's healing that has to happen before anybody can embrace change. So that's also where I think there's a lot of space for collaboration.
Happen in the community meetings. I mean, there's a significant amount of that stuff happen, down at the VFW, when you're having beers with people, and when you're.
Yeah. Yeah. That's a great point. And I love that point. And it's so true. But I do projects, and I do my project and then I'm done. And so it's like the sustained healing that really has to happen. We do plans. We try to drag them out as long as possible in most cases, especially if we're doing like a community plan, like, oh, we just need another few months. But, there's a limited time span, and healing has to just keep going, right?
We have to heal. I've heard a definition of resilience recently, which is, it is healing while fighting on. I wanted to just, the other thing I think I wanted to kind of say about this is that if you think about the whole state and the circumstances of these places and the people we've been talking about, and this notion of trauma and loss, I don't think that we are very good, and we have not had a good conversation in this state about the huge changes that have gone on and the losses that people have sustained. We're not very good at mourning things publicly. And the loss of vitality of a lot of communities has just been sort of like, well, why don't you just get over it? And there's no conversation about, well, let's figure out how we recognize it. Let's figure out what do we do with the history of trauma and loss that we've had? What do we do with the successes that we've experienced in the past? And how do we put these things in some kind of emotional perspective? And those are conversations that the communities, they don't have. We have a culture that actually actively tries to dissuade people from talking about some of this stuff. So part of the challenge is to help surface some of these feelings in a way that allows people to work, in my mind, to work through them and to talk about them. And I think that's a role that psychiatry, along with our colleagues in other areas, could help focus. So we go into a place, people are really pissed off. And we say, well, okay, tell me about how pissed off you are, what's going on that you're so pissed off, and what's happened to you. You know, let's think about this a little bit and talk about it.
So I can say that in rural communities, there's sort of this thought, that rural folks don't want anybody coming into their community and so on. And I think that that is true to a certain extent because they feel as if they are infiltrated by urban areas or research universities and so on, coming in and telling them what it is that they know and what it is that they need. And I find that we really need to switch that upside down and say, what do you need? What are the issues here? Some real inquiry, appreciative inquiry, because there's no doubt that the people who live in the place where they live are the experts on that place, and that they are the ones who know what the issues are, and they also know potentially how to create the solutions.
I have, I've been secretly using this whole session here to help guide me. In a month, I am going to be going to a little community outside of East Palestine. And I'm meeting with an organizing group there about the mental health challenges that are going on among the community there. And I've gotten entree interestingly, through a guy who's an organizer in the Mon Valley, and done a lot of work with the communities there, and has reached out and gotten engaged with the East Palestine folks for quite some time now. So he's invited me to come with him because he doesn't know what to do with all the mental health issues that he's facing there. So everything we've just been talking about, I'm going to be trying to figure out how to address in some way, and I will. I look forward to being able to talk about that at some point.
Yeah,
Yes.
I hear about that.
So Stacy Joe said, what about more resources for those who have psych concerns getting released from jail?
Everybody's nodding their head. Yes,
Yeah.
more
Yeah,
resources
yeah.
for people being
Yeah,
released from
yeah.
jail.
So this sounds so weird, but I used to spend a lot of time with inmates, and there is very little that is out there for them. There's very little for them who are in there, and that there's I think that those who have prison records tend to have some real challenges, and many of the people I knew in prison, I knew from my mental health counseling days. And they, it was, I mean, it was sort of generational, and it was untreated, and it was really challenging. So I don't know the answer to that, and I wish I did.
Just briefly, the 1115 waiver has a portion in there that allows for 1 year MA coverage for folks coming out of the DOC. I wonder if there are other parts, like the nutrition portions of that billionaire grinder at the top of our government, but are there other portions of that waiver that can be helpful in these regards?
Is that waiver still in place? Because I know that there was a waiver that was approved. There was a waiver that was approved, but now defunded, I think. And then there's a waiver that's in review, I think. But thank you for bringing that up. That's a great resource.
So one question, and then I just want to make a quick comment, and we are going to be finished.
And it's really just a comment to add on, Dr. Thompson, with what you were sharing. And when we speak about the rural community, I just wanted to add a comparison with the immigrant culture, or if we're from different immigrant backgrounds. I say that because there's a different awareness and a knowledge base of those groups. And so with the rural community, if you're coming in, they could feel like you're trying to change things, especially with mental health and depression. And let's go back to North again, and it's like an invisible disease that you're telling them about. And like immigrant cultures, sometimes mental health is not per se a real thing. Like my dad wouldn't validate something that I very much are aware of, at least in my generation. And as far as healing within those both challenged populations, like rural or immigrants, the other part of that that's difficult is that they're always in survival mode. And if you're always in survival mode and you're thinking about shelter, safety, just core things, it's hard to have a moment to actually feel the essence of or appreciate depression. And so to have the space to heal, the environment to heal, the break to heal is a different discussion as well. Thank you.
Thank you. I'm hopeful that this has been a meaningful and useful conversation. We got to spend an hour and a half talking about this, which I'm really absolutely thrilled about. And I don't know if we somehow didn't do a break we were supposed to do, but anyhow, I didn't dismiss you all, so you're stuck here. We're about to go into another session. The one piece that I want to carry out of this, though, is that I think an area that we need to, I think we need to work with the state around is this concept of how we really learn how to focus on a place and the people in it and the resources that they have to maintain and sustain their health and well-being that they can draw on and that they can build, and that we can be of some help in the process of their healing to do that. And that we have a much clearer view of how important it is to think about the relationship between place and the people in that place. That's I think the key for these left behind areas and the farms that are out scattered around Pennsylvania here. And thanks to our wonderful panel. Thank you, guys. That was great.
Unfortunately, no, we don't have a break. We're just moving on with some more wonderful education. A slight change in our program today. We're not having a fourth panel, but we're still going to hear from Dr. Gina Perez, which I'm very excited about. One of the reasons I was so happy to have Dr. Perez close us out today was because she's doing some great work with community building with psychiatry. So I really thought that she would be the perfect person to give us some hope and to help us think about the things that are working to bring us all together. So oh, she's there. Okay. So I'm happy to introduce Dr. Gina Perez. She's the Associate Chief for the Behavioral Health Network and Telepsychiatry at UPMC. And she's going to be here talking to us about connecting and engaging a psychiatry network.
Great. Hi, everybody. Thanks so much for having me. And I've really enjoyed listening to the discussants before me and all of the panelists as well. And so I appreciate you having me here. So let me share my slides. And let me just get it so that it is. Okay. Is everybody able to see that?
Yes.
Okay, thanks. All right. So what I'd like to do is just kind of share what my experience has been since I've joined here in Pittsburgh at UPMC. And this is one approach that we've had as a system and an organization. And I'm also very interested to hear if this sparks other ideas or if people want to share in the chat or in questions after anything that you've noticed that has been particularly helpful. Okay, and so I'll begin. Okay, so first a picture of my cat Scoops on my front porch. I have 2 cats and 2 dogs. I'll share my dogs in a minute. Okay, so my goals, I'll just kind of tell you a bit about our UPMC Behavioral Health Network and kind of structures that we have put in place to try to make sure that we stay as engaged and connected as we can, which is really a challenge when we have providers and teams that are spread apart so much across the state and a little bit into New York and Chautauqua and into Western Maryland. And so we don't do it perfectly, but a part of my main job is to make sure that that's what I focus on. And so I've really enjoyed it. I also talk through some things that are kind of, I think, universal challenges for all of us. And that's it. All right. On to my dogs. This is Ruby Lou and Lottie Dottie. They're 2 years old. They're mostly good 90% of the time, and I'm still trying to train them. Okay, so a little bit about my background. I went to Pitt Med for med school and then Western Psych for residency. Then I worked in Baltimore City at University of Maryland on the inpatient unit, outpatient services, and I also worked a lot in education and did administrative roles in education. And then my second bullet point, after 23 years, I still love being a psychiatrist. I love patients. I love hearing people's stories. I love being there with people. And I also really enjoy organizing things and trying to think about how we're functioning as a system. Currently, I'm Associate Chief for our UPMC Behavioral Health Network and for telepsychiatry. And I report up to Ken Nash, Dr. Nash, some of you may know him, and to the chair of our department, Dr. Lewis. Clinically, I work in the Center for Autism and Developmental Disabilities on the adult side, and that's been a population that's been near to my heart even before medical school, and so I love my clinic. I'm Senior Director for Med Student Education and for Clinical Faculty Development, and I'm on an associate professor here in our department. Before I came back to Pittsburgh about 8 years ago. Before that, I worked in an underserved area in New York, and I went there for personal reasons. And it really had a big influence on me. I got to see what it was like to work when there are limited resources, when my patients would get denied from being admitted into the hospital. There was nobody else but me. Well, that's not completely true. I did have other colleagues, but all of our schedules were completely booked, and I'm sure a lot of people can relate to this. It was really eye-opening, and it can be very stressful. And so it was through that experience that I realized I have to figure out how much I can do. And if I'm full with what I'm able to do, I need to figure out a way to share my knowledge as a psychiatrist with the community around me and be sure that I'm continuing to teach other people around me so that I'm not alone. I also realized how vital it is for me to have people that I can call to ask questions to, so that if there's a stressful scenario with a patient, or I'm doing my best to figure out what the right thing to do is for a tough patient, that I don't have to figure this out by myself. And so that was really something that I learned a lot during that 7 years about. And so for personal reasons, I decided to move back to Pittsburgh. And that's when Dr. Nash had let me know that there was an opportunity to help oversee our psychiatric network. And I say oversee because truly I don't have all the answers, and people are licensed to practice, and so I don't need to tell people how to do their job. And so I'll talk a little bit about my philosophy, but I was asked to come back to help keep our network together and to make sure that we have enough support. And it's been really challenging, and it's also a lot of fun too. And we have a really good team, and so I feel very proud of our network. So, okay. A little bit about UPMC. So it's large. There are 41 hospitals. I'm guesstimating about 30 of the hospitals have some type of a psychiatric service within the hospital. They're also affiliated outpatient clinics, and we average about 35,000 behavioral health visits per month. That includes everybody. It includes peers, case management, therapy, psychiatry. So that is all encompassed in that 35,000 per month number. We have about 240 academic psychiatry faculty. 60% of them are physicians, 40% are PhDs. A lot of the PhDs do mostly research work, and the physicians do mostly clinical or part clinical and some research, but the majority are doing clinical work. In addition to our academic department, I'll show you a bit about what makes up our community of psychiatric providers. And we have about 100, and there are 60% physicians, give or take 40% nurse practitioners and PAs. This is a map of Pennsylvania, which you all know. And so I've put dots where we have services, and I'm not quote over all of the services. And so a lot of this is, I have my psychiatry consult colleagues who help to coordinate care across different parts of the state. I have my telepsychiatry emergency department colleagues who have begun to provide care into different emergency departments. So I will just go through kind of what the dots are. So we have several inpatient units across the state, and they're the green dots. Outpatient services are the orange dots. The yellow dots are consult liaison services. The blue ones are when our consult service from Oakland beams into different counties. And the purple dots are our newest dots to the map, and that is headed up by David Yancora, who's a psychiatrist in our psych emergency room. And he has a team that is now beaming, I call it beaming into different UPMC emergency departments. And as I'm sure most people know here, this has been one of the biggest challenges when you have patients that are stuck in the emergency department and you don't have a place for them to go. The red dots are locations where we have one of our UPMC psychiatrists who maybe beams into a non-UPMC clinic. And so we've kind of provided a doc to be embedded within their clinic. And so it may not be the only doctor there. And so you can see that we go into Cambria, some sites in Allegheny that are non-UPMC, which is the Heritage Valley system. Tioga County, that's Laurel. In Cambria, it's ACRP. And we have a doc going into Berks County as well. One thing that I keep very close eye on are all of our spots that are J1 approved locations for any physicians who are looking for a J1 spot. And so you can see those are like the red stars. Okay. If we look at our inpatient beds across the network, this is a listing of all of the current inpatient beds. Sadly, Heritage Valley Kennedy will be closing soon, but you can still see all of the other locations. And this is, in addition, we have a Western Psych that has a max capacity of 255, but we tend to have a census closer to 200. Okay, so when I first started the position, I thought, how am I going to figure this out? Because every place really is unique. And I'll reference what our panelists were saying before, just about the importance of not pretending like I understand a community. just because they have UPMC on the name of their hospital. And so just the importance of taking the time to get to know who it is that's working in a clinic or at a hospital, and knowing the people. And every place has its own culture as well. And so trying to get out to visit the locations, making sure I understand who's there, who has really strong like connections and awareness of what's happening on the ground, because I certainly can't figure all of it out. So this has been my philosophy that's been developing over the past few years, and hopefully other people share in this, and it applies to pretty much anywhere that you work. And so really prioritizing people, and not looking at a psychiatrist that we're trying to recruit or support who maybe works in, we'll just say UPMC Somerset, not focusing on necessarily filling a position, but focusing on the person who's going to be joining us, and am I thinking about their career goals? One of the comments to a panel discussion was about thinking through, how do you support somebody once they start a position so that they're not then jumping to a new job in 2 years? How do you give them the things that, keep them inspired in the work? Because it's easy to get burned out and frustrated. And also making sure that, we all have the same goal of prioritizing patient care. And so that's a common thread that all of us here have, and our docs across the network and providers across the network. I look at my goal as trying to be available and being a connector, so that people, if I know somebody who may be a great mentor for this person, just making sure I connect them at every possible opportunity. I try not to be intrusive and get too much in the weeds. People know how to do patient care. I'm not there to teach patient care. They know that. And then the fourth bullet is really respecting the local culture, and being very thoughtful about, if somebody has joined our hospital system, not jumping in with thinking that I know the answer, but really taking the time to get to understand their local culture, and what people might be particularly sensitive to. I'm always thinking about mentoring, and who would be the best mentor for somebody, especially early career psychiatrists. Just being very thoughtful about how stressful the first few years can be, how stressful it is to learn a healthcare system that's really complex. If they're coming to us from a different state, just adjusting to Pennsylvania, it's very different from other states, and making sure that I get people the right mentors, and that I don't overwhelm them with mentorship or supervision, but I meet them where they are in their career. I see success is when I have introduced like one of our docs in the network who has a question about addiction, and I have him connected to a doc who's very knowledgeable and skilled with addiction. Once they're texting with each other and they leave me out of it, I consider that success. It means that they've made their own connections. And that's really what's the most meaningful in our job, our patients and the people that we work with. The other piece is, I always think about, whenever I'm looking at the network, how can I potentially connect what's happening in our network to something interesting that's happening in our academic department, and vice versa? Are there times that I can bring in the perspective of our network teams to something that, an initiative that's happening within the department, or an initiative that's happening at one of our other sites? And then I think about education. We all love to continue to learn. I feel like that's what keeps me motivated. And so I think about, what are ways that we can learn from each other and make sure that it's always going bi-directionally. And so that's sort of been my philosophy. Okay, so this reiterates a little bit of what I said, but just adds a few more elements. So patient care is something that everybody is focused on, and that must be our priority. We talked about our community, the local culture in the community, who are the people in the community sites, what are those sites like, what resources are around the community, and how are they unique. Telepsychiatry, it was mentioned earlier, and everybody already knows this. It used to be something unique and kind of fancy. Now everybody does it, and so it's really integrated into everything that we do. And I always think about, if I can't recruit a person in person, what can I do through telepsychiatry that can be helpful? How do I make sure that it's still the right care? And how do I make sure that the psychiatrist isn't just there? I never want anybody there to just fill scripts. And do they really understand the clinic, the people, the community? And so we'll talk a little bit more about that. We talked about our academic department, and then another huge piece of our system is our growing team of nurse practitioners. And we have some PAs, but mostly psych nurse practitioners. And this is an area that I have focused on a lot in our network. And it stems from my experience in New York in an underserved area. It's the first time that I had the chance to work with psych NPs. One of my best friends is a psych NP, and I've created a program to provide ongoing education and support for any NPs across our network, if they choose to participate. And then, I also think about, like, what's our impact to Pennsylvania, and are we doing enough? And the answer is always no. Like, we can never do enough. There's always a shortage. So I don't know that our job is ever done with trying to help Pennsylvanians. When COVID hit and we were doing telepsychiatry to everywhere, a lot of our providers and teams wanted to begin to branch out beyond Pennsylvania, and there are a lot of hurdles and challenges with doing that from a telepsychiatry perspective. And so I really took the vision of, we just need to focus on Pennsylvania. It's what we know. We know there's a dire need here in our state. And so we've really drawn in, or narrowed our telepsychiatry resources into Pennsylvania. And of course, our Maryland team focuses on their Maryland community, and our Chautauqua team focuses on theirs in New York. Okay, so what I've done is build structure for how we connect, and some of it's been a ton of fun. Okay, so in my role of helping to oversee our psychiatrists and psych providers across the network, I am one piece of a team that's like a senior leadership team to help all of our different locations feel supported. I can't give advice to nurses who are trying to manage the unit. So we have a nursing team that helps support those nurses on the ground. And I'm not an operations expert, so we have a team that focuses on operations and regulatory. I do know a lot about telepsych regulatory stuff, so I can be very helpful for that. And then we have a social work / therapy team that helps when there are kind of really challenging patients across our network. And they'll help troubleshoot with the team, understand how the team is feeling about this challenge, and go in on the ground and try and be helpful. And then my piece is focusing on psychiatric providers. Okay, so I talked a little bit about the importance of identifying mentor-mentee pairings, making sure that people don't feel alone in the network, because that can happen very easily. Oddly, in outpatient, I think it's easier to feel really alone because you're just sort of running from patient to patient, and you don't have as much time to bond necessarily as a team. Over time you can, versus inpatient teams where you have like such a multidisciplinary team that is there day in and day out. So I always try to think about, are people connected enough with other people across our system? Are they worrying alone? Are they stressed about cases when they could be calling 20 people to get help? So I just want to make sure that people reach out when they need help. we really prioritize extended orientation so that you have a chance to get acclimated to the system that you're going to be working in, to EMR, you know where the bathroom is, you know where the printer is. And also it takes about a month to get people on insurance panels too. So it builds in like a nice extended orientation. But that's really critical because you only get one first impression with somebody. And so it's really about balancing this. Like there's, when you're recruiting to a rural area, there's such a dire need and you needed that person to be there 3 years ago and they're there. But you have to prioritize. I need to make sure that I retain them and that they stay there and they love it and they have a chance to just learn the nuances of whatever clinic or location it is. Okay. I covered the rest of it. Another priority is making sure that the clinics block time so that people can meet with their mentors. And this always over time, sometimes schedules will get changed. And so I just try to make sure that we keep that as protected time and protect their time for different education events, within reason. And a lot of times they're kind of over somebody's lunch hour, but we'll talk about some of the education stuff that's available. I try to do regular check-ins with people as much as they want without overwhelming them. And we talked about the rest. So one thing that I've been doing is a quarterly network psychiatry meeting. And so we'll have a topic that is, I try to make it really clinically useful. And so I'll invite somebody from our team to come and speak about something. So this is an example of a topic that was done recently. Tomorrow we have a quarterly network meeting and we'll be talking about ECT and most common questions that our ECT team gets asked. As part of the quarterly meetings, I always try to do, a provider spotlight. And that is so people get a chance to know all of the 100 people across their system just a little more personally. And so they just give a little blurb about themselves. We also do a service line or a clinic spotlight. And so people can just talk about like what they're, what's unique about the clinic where they are, or just say hi to everybody. This is an example of our network spotlight. Some of you might know Dr. John. I got her permission to share this. She's fabulous. She's in McKeesport and works at our Montauk outpatient program. Everybody here, if you guys want, there's access to our Department of Psychiatry virtual grand rounds. I coordinate a practical psychopharm grand rounds, which I love. We try to pick a really useful topic, and a clinical pharmacist gives the majority of the talk, just reviewing mechanisms of action, new approved medications, and then we have a psychiatrist or a panel of psychiatrists that then talk about clinically, what does this mean? How useful do they find things? They give tidbits, and so that's been a lot of fun. If there's ever a chance for people to do ad hoc collaborations, that can be really motivating and useful. And then, just some organization things. I try to give a general structure to how we do call schedules and stuff like that. One thing I've been really excited about is a program that I started in 2018 called the Nurse Practitioner and PA Clinical Enhancement Series. And the goal is just to have a safe space for our psychiatric NPs and PAs to come and review cases. We have an ongoing weekly case conference. A lot of times I host it, but I try to pull in other people to host it as well, and just make sure that the conversation's flowing and facilitate discussion. I also bring cases there and get input from our psych NPs as well. And so it's just a chance for us to share clinical challenges together and learn. So, and 3 days a year, usually they're half days, sometimes they're full days. I'll create a curriculum for didactic days, and I make sure that people get blocked if they want to join us for those. And so we just had one on Friday, and I've gotten really positive feedback. It's a chance for people to connect, see that they're not alone as a psych NP, and they just get to know each other. This is, I feel really proud of this program. we have a lot of really good nurse practitioner leaders. So Ali Wachansky is one of them, Paul Maniago is one of them, and Ali Wachansky, they both actually been spearheading a mentoring APP program, and that started in 2023. We're still trying to figure out how to get people engaged in that, and it's a great program, but I think it's been a little bit harder to get off the ground. I'm sure this will resonate with people that we get requests all the time for students who would like to rotate, and it's a challenge. And there used to not be kind of an organized way to manage this, but I've created a structure so that we have a streamlined process to review applications specifically for Psych NP students. I've pulled in 4 of our Psych NPs plus me as an education task force. And so we have kind of a structured way to try and be thoughtful about placing people at clinical sites. And we've been able to find clinical rotations for a lot of Psych NP students and PA students over the past few years. So you can see the numbers there. Our Department of Psychiatry website, I always try to remind people to refer back to it because it lists all under the events section, any of the grand rounds, and it's just an open link so people can join on anytime they like and see what topics are of interest. And so this is, let's see, as of January 31st, this was some of the talks. And one of our newest services, which is not run by me, is our perinatal tips line. And I think there might be people on the call who are aware of or involved in the kind of eastern portion of the state's version of their perinatal tips program, which is, I think that's run by Penn State Hershey. Somebody can correct me if I'm wrong. So it's been a coordinated effort across the state to provide that. Okay. So one thing that that I was asking myself with our telepsychiatrists is, do they really know the people that they're treating? And do they really understand when their patient says, like, I couldn't get here because there was snow and there's no way I was getting, through the roads here. So I just feel like it's been very helpful to have people travel to actually at least once, if not more, visit the site where they're seeing patients. And so this is Dr. Canton at the top. He lives in Florida. He's one of our very few telepsychiatrists who's all telepsych. And we've flown him out now to 2 different sites where he sees patients. And it also helps him get connected with the teams. And I try to make sure that he also meets with me regularly and has a chance to meet with anybody when he has clinical questions and meet with the team so that he stays connected. So it can't just be about him seeing patients and getting through his schedule for the day. So is he really connected with people on the ground? And then in the middle here, I don't know, you can see Winnie Wolf is our newest psychiatrist who's all telepsych from Denver. And she is working at Safe Harbor and she loves it so much. She's increasing her time to full-time there, all telepsych. And so she recently flew out to meet the incredible team at Safe Harbor. And so there's just, it's really valuable to invest in making sure that people know who their colleagues are and get a sense for them. People ask us often about recruitment. So this is Sheena Kellerman, our director of recruitment, and she cracks me up because she made this little, I don't know, it's like a little stand-up thing of herself. So she didn't mind me using that picture. So in general, there's so many different locations, and some of the hospitals will have their own like official recruiters. And so we just try to understand, how have you recruited in the past? What works best for you? We don't have the magic answer, but we can be here to help support you and add to what you're doing. And so that's part of really understanding that local culture. I don't get extra bonus points when I recruit for a site. If they have a recruiter, that's, I'm not trying to step on toes. And One thing that we try very quickly to do is once we have a physician or an MP who's interested in a site, making sure that they connect very quickly with the other psychiatrists on site there, and that they're, that sharing of information is really critical for recruitment. Just being organized, making sure people have a clear point person, and that you're focusing not on the position, but really where are they in their career? What is their passion? How can you continue to build a career that's meaningful for them? And how can they fill their cup up with like learning whenever they want to learn about things, and being connected? And the truth is sometimes it's just hard to recruit in certain areas, and it does not reflect the team or the care there. And so that is a challenge that I share too with a lot of people. And this is a slide that I show when I'm talking to people who are potentially interested in working with us, just reminding them that we're all not meant to do this alone. We don't want anybody to worry alone. And I think that holds true for us as a psychiatry community just across Pennsylvania too. So, okay, with that, I will stop sharing. I'm available for any questions. I appreciate your time.
Wonderful. Thank you so much, Gina. Appreciate it. So do we have any questions for Dr. Perez?
And please call me Gina.
I started off calling you Gina. I apologize.
Oh,
It's
God.
Dr. I just called you Gina, but I appreciate you. Yes, thank you.
Yeah, please do.
Yes, Dr. Klein.
Not a question, just a comment. Bravo. That is really impressive. That's really great what you're doing. Keep up the good work and lots of great ideas too. Thank you.
Oh, thanks.
Hi, Gina. My name is Eileen Diaz. I'm from Penn State Health. I'm director of Hispanic Clinic over there at Penn State through Pennsylvania Psychiatric Institute. So one of the things I've noticed is that there's this movement in like Pennsylvania itself to be mostly purple, a lot of UPMC sort of both spreading around. So I want to know how you collaborate with different systems as to like increasing the workforce and what you've seen so far.
How I collaborate with other systems with increasing the workforce. It's a good question. I feel like I could do better with that, to be honest. So I feel like that's really where there's room for improvement and growth. And I'll give anybody my cell phone, and I'm always looking for ways that I work more with other people, because you're right. Like, even I'm just trying to figure out what can I do to be helpful across our system, but I know that we're not alone, and it's better if we connect more. So I'm always open to ideas about that. Yeah. So I don't know if that's an answer or not. It's honest. So.
Kidding.
I would say one thing. I do have like one little thought, and that even small things I do think matter. So for our psychiatrists that we have who are beaming into like ACRP, for example, or to Laurel Behavioral Health, certainly during the pandemic when we were all like, what is this? What regulation am I supposed to follow? What am I supposed to do? I would have Sabrina George, who works closely with me, she's our telepsych project coordinator. We would reach out actively and be like, hey, just so you know, this is what we're sending out across our entire system for how we're, what we're doing to follow the regulations. This is what we're doing just to try to save people some time or to see if I missed anything. And so that is one way that we were trying to be really proactive, because there's never a shortage of need in the state. And so, I mean, I'm just happy when patients get great care. It does not need to be at one of our sites specifically. And so, that's one way. And I guess, now I did come up with an answer to your question. Aside from, I definitely could continue to improve. The other thing is with Heritage Valley. So it's an interesting relationship. We manage, like UPMC manages all psych services through Heritage, even though they are their own entity. And so I just sort of blend us, like we're all family, so I don't really care who's employed by whom. And all of our Heritage Valley, like those nurse practitioners that I showed you pictures of, Allie and Paul, they're not really hired by UPMC, but I know them so well, and I just feel like they're family because they're providing great care, and I adore them. So that's, yeah. So I think the more that we are connected, the better. And yeah, there's room to improve.
Hi, Gina. I'm Allison Swigert. I'm a psychiatrist in the Harrisburg area as well. I really appreciated your presentation and everything you outlined, particularly about having this protected time for check-ins, for mentoring, really focusing on early career psychiatrists, because I think it is often a steep learning curve when you're going from residency or even fellowship into being an attending. And I think, what you've outlined hooks into some of the themes that came up earlier today in terms of supporting existing workforce and making the work sustainable and enjoyable for those of us who are really trying to commit our careers to this. So the question for you is, I guess, how do you advocate with leadership or administration about the importance of having some of this time built into provider schedules? Because there is such an emphasis on every available minute being scheduled and accounted for and productive. So I'm curious what tips you might have for us on that.
One is looking at what has been the cost to fill a vacant position. I see head shaking. Yeah. And yeah, so I think that it's really hard to argue against that, because there's nothing more painful than having a psych NP or psychiatrist who's been missing from a clinic for 2 years, and everybody's been scrambling around to provide coverage, and it feels super stressful. And just, everybody who's trying to recruit psychiatrists or psych NPs or PAs for their system, how much money goes into that or can go into that. And so I think just trying to look at the bigger picture and balance that. And then when people are happier and they're more connected, they do better clinical work. And so and I feel this is where I feel really lucky that I was just like, for that nurse practitioner clinical enhancement series, it's just like secret days that people can take off. It's not included as part of their CME. So I said, don't tell anybody. Nobody has given me any pushback. And we've had people stay, and it's not, of course you need to make a reasonable salary, but in the end, it just isn't all about your exact salary. It's about, do you love your team? Do you feel like your team has your back? Have you guys gotten through a huge clinical challenge together? And that's just like, there's nothing like more empowering than that, just to feel like you can tackle so many challenges together. So that's how I approach it.
Hi,
Oh, and
Gina.
then, sorry. Hey, how's it going? Good.
Keep going.
Oh, I was going to say, I also always, I have the good fortune of working with Courtney Johnson, who's my administrative assistant. And I said, Courtney, send a reminder about the network meeting. But I send it to the clinic directors, not just the physicians and the NPs, because I need the clinic director to block it. And so I'll be sure to send it 3 months ahead of time so that they don't already have patients scheduled. So I just try to stay on top of that. Or like if we have our didactic day, did you remind people about the didactic day? Let's remind them again. She's like, I just reminded them. I know, but tell the clinic directors about it, because I don't want somebody to say, nobody blocked my schedule. Okay, I'm done. Hi, Marianne.
Hello. And I just want to say it's been you were very helpful a couple of years ago when we had one of our nurse practitioners at the FQHC who, how do we make some connections and help support their learning process and that lifelong learning commitment to the work. So I appreciated your ability to take her under your wing and help with some of that. I think as a purely selfish, how might we is there room or potential for interagency or interinstitution connectivity with what you're doing? So we don't have to necessarily reinvent the wheel, or how do we bring something to the table that may augment what you all have in your network already, but expand to greater reaches in Pennsylvania, and in particular rural reaches.
Yeah, no, I think that there definitely is room. And so I would just say, I think you have my cell phone, just text.
I do, I'm gonna talk.
Call me. Yeah.
Great.
It's 845-706-6961. Anybody can call me. But yeah, no, just when you have an idea, like, let me know and we can figure out how to make it work.
Thanks.
Hi, Janet. Ken Thompson. How are you?
I'm good.
It's good to see you. I sort of piggybacking on what Marianne just asked, and to talk a little bit about sort of a vague dream that I have. As you know, the PPLC was actually created with the idea that we would begin to build that kind of infrastructure that you're talking about and you've been doing. And we really, it's been a wonderful thing to see and to hear more about it today, what you've been doing with the UPMC docs across the system. One of the, our goal has been to create the capacity for public mental health services to be excellent across the state and to make it possible for psychiatrists and others who are involved in mental health to do the best work that they can do with the populations that they're caring for. So I think that very much fits with what you've been doing within the system that you've got. One of our challenges is that we know that there are a lot of docs out there in particular who are working in public service settings and who are not connected into a lot of resources. And I worry that we haven't figured out how to bring that kind of collegiality into the field and help folks feel some connection. I've been motivated for years, and I've talked to Allison actually about this a fair amount. She was doing some work trying to connect up with early career psychiatrists. I think it's actually just as important in some ways for even the older folks to be tied in to develop something similar to what they do in the UK and actually in Australia within the Royal College of psychiatrists. They create pods. If you're a member, you create a pod of somewhere between 4 and 6 psychiatrists who are charged with getting together 3 or 4 times a year and to share cases and to have some conversation and to some collegiality, and also to just kind of keep check on each other to make sure that folks aren't feeling too isolated, too disconnected, too stressed or whatever. And we've been trying to figure out how to create something similar to that as a way for people to feel some linkages with each other. And I'm just curious if you have any sense, one, if that seems like a potentially useful idea, and two, given your experience now with what you've been doing, how would we imagine taking this across the state, the kind of thing that you're doing across the state, so that psychiatrists are working in all kinds of community settings, especially the ones who are out in the field or working in isolated areas or working virtually in isolated areas, if that makes sense, how to connect them up with each other and the challenges that they have. So that was a long-winded question, like, help.
No, I think it's a really good point, because I feel like one of the biggest challenges is as soon as you get a little bit of distance, you start to think us and them, and you forget that we're all colleagues. And so, like, we have bed searching and placement kind of thing called Psych Care Plus that helps if there's a patient in an ER, like which location can they get to. And sometimes there will be pushback from one of our sites. And so then Eric Golden, who's the head of it, he's a psychiatrist, he'll say, I'm having a little bit of trouble getting this patient admitted to this unit. Like, what's going on? Can you? And I'm like, well, here's his number. I'm just going to connect you on a text. Can you guys just talk? And then they talk and they know each other more now. And then the next time they're referring patients back and forth, then, oh yeah, hey, how's it going, Ken? Listen, this, it feels different. And so I think it's just working through that. I think that you're right. If it needs to be a small enough group so that you feel like you personally know people. I feel like if you made the pods of people who could have a chance to refer to each other, that could be really meaningful to help with transitions of care, and being able to have it see if other systems would find value in protecting somebody's time, because I feel like once you have things that are 7:30 in the morning or after work, it's tough. You're not going to get that connectivity as easily. Yeah, so those are my initial thoughts. I think it is a really good idea, especially early career, and connecting them with somebody a little bit more seasoned. So maybe, and being thoughtful about what's the mix of what people are doing, consults, inpatient, all of the above, outpatient. When we went with Ali Canton to Laurel Behavioral Health, there was a nurse, or there was somebody there who had a question for me, and I'm like, oh, it's my cell phone. This is what I specialize in: adults with autism or developmental disabilities. Like, text me or call me anytime if you get a cool case. And like, I feel like there used to be like, oh no, legally, am I going to get in trouble? And maybe I'm at a different point in my career. I'm like, I do not care. I will happily give my 2 cents and be helpful if somebody has a stressful case. Yeah. Okay, I'll be quiet.
You had a chat question. Monique asked, can you tell the group how you get MDs interested in supporting rural communities?
Well, I don't know. That's Monique.
Well, you said not to ask you any hard questions. I thought that one was easy, and I thought it was a great intersect into the last panel discussion. So that's why I asked it, and I remember some of the strategies that you would use that I thought were that I thought were helpful and that the group would appreciate, because it's not as easy to get someone interested in working at like Northwest, right? And so I think that's why I asked that question. I thought it was relevant to the last discussion too.
Okay, so nice to see you.
Thank you.
We used to work together. You know what I think it is? I think reminding everybody to respect how hard the work is. It is, yeah, and being sure that they understand you are joining a system or a location that really respects how difficult the work is and what you're going to do and offer to the team. I think that's the biggest thing, and making sure, like, when I think about like education opportunities, it is never just one direction coming from our academic location. We know best about how to manage Northwest. Oh no, we do not, because it's just like a different ball game out there. You do not have the same resources. You have a different level of stress. It's so hard to get outpatient. And so then sometimes if you have somebody who's in Oakland, like, oh, just refer them to like one of the 20 IOPs available. That doesn't feel good. And so making sure that I just try to, in all settings, like, advocate for, this is tough. It's really hard, and we will respect the heck out of what you're doing, but we're also going to make sure that you continue to grow in your career, and that you feel like we all feel like we're getting smarter, and that we're learning from the tough, cool things that you're seeing. And cool is code for, oh my God, I'm going to wake up at 2 a.m. because this patient's stressing me out. And I say, I'm going to give 5 people you can call, maybe not at 2 a.m. You can call me at 2 a.m. But I don't know, just making sure that how do you get people motivated? I don't know. People are motivated for different reasons. Maybe they have family that's connected. Oh, that's one thing. When you're trying to recruit somebody, really paying attention to what's important in their personal life And are you getting them connected with the right people to answer those questions like daycare, or what is the Muslim community like at Somerset? I'm not going to be the right one to answer, either of those questions. So I got to get you connected with somebody who will give you the real answer. And and making sure that they get the real answer so they don't jump into something they weren't expecting. I think people feel a lot happier when you warn them about, there's going to be a challenge no matter where you go. Here's our challenges at this site. Did I forget anything, Monique?
Yeah, no, I think you answered it correctly and appropriately, and it highlighted that it's not all about financial compensation, right? It's the supports that people get and aligning with their interests and the benefits that they receive from taking on cases in rural communities as well.
Thanks.
Any other questions? Well, Gina, thank you so, so much for your presentation. It was just fantastic, and it was great to have you here talking with us today.
Oh, thank you. I appreciated learning from everybody. It was great.
So reach out to Gina, everybody. Text her.
Yes.
All right, we did it. Here we are. I'm going to turn that one off so I don't run into any problems. By the way, I'm Valerie Ferry, the Executive Director for PPLC. I think I forgot to introduce myself. Quickest microphone. So first of all, thank you for being here today. I know a lot of you traveled very far to join us, so thanks for joining us. Thank you to all of our fantastic presenters. I think we had a really interesting and informative day. Exactly. We cannot do these conferences or meetings without two special people in the room, and those people are Deb Shoemaker. Say hello, Deb. And Lucy Green. Thank you, Lucy. In case I didn't mention it before, I'll mention it again. If you need a CE or CME information for Category 2 or a certificate, Lucy is also going to be the person that you email. So L Green, like the color, at pmhcc.org. She can get you what you need. She's also going to be sending out some slides and the video of today's recording once she has a chance to go through and organize that. So please look out for that information as well. Ken, I don't know if you have any announcements, but I want to ask everybody, if you were intrigued by what we were talking about today, if you want to work on some things that interest you or other things, I've got a question for you. What are you doing on Thursday night? I see some of you at 6 o'clock on Thursday night, but we meet every week virtually on Zoom. You can also reach out to Lucy for that link as well, but we would love to see you all there. It's a great chance for us to talk about what's going on in our world, things that we might need, and to work on some problems. I think this conference has given us a lot of food for thought and things that we might want to think about. So join us. It would be really good to see you. Even if you can't make it every week, it would still be very nice to see you. Ken, you have to talk into the microphone or it doesn't count, Ken.
Thanks, Val. I don't mean to interrupt you.
No, please.
Just to say a quick word about the Thursday night meeting. They have been going on.
Got to turn it on, Ken.
On now?
There you go.
All right. Just say a quick word about the Thursday night meetings for those of you who have not participated. They've been going on now for 5 years. They actually started right after the COVID lockdown. And we started them as a place for people to come together and to be at least able to share and talk about some of the challenges that we were facing at that moment. And we continued on a weekly basis to meet for about 3 or 4 years. And then a year ago shifted to every other week. And then guess what? Starting in January, we went back to every week to be able to try to understand what was happening in the world around us. We are still meeting every week. And the reason I would like to encourage folks to join us is that, as you heard today, one, the situation in Washington continues to evolve, and its impact, we don't completely know how that's going to fold out yet, obviously. So it's been a useful place to share information and reactions to it. But I also want to stress that you heard that, the state is working on some notions about what it's going to do around behavioral health and health in general. And I think that what I'm hopeful our Thursday night meetings will do is to have us be in a position where we're prepared to address issues as they begin to materialize from the commission and the advisory committee. So it's a place where there is actual, we both support each other and share issues and concerns, but I think there'll be an opportunity to really make sure that we have our voices heard about what is happening at the state level. So I want to encourage people to come, and somehow they can find out the web address from Lucy. And is there any other, we'll send it around. How do we make sure people know how to get to us?
Don't give me the double microphone. That'll be trouble. Yes, just Lucy can get you on the list if you're not on the list already. If you're not receiving regular emails, you'll know because you'll hear from Lucy a lot if you are. But yes, please just let Lucy know and she can get you an invite to the Thursday night. We also meet Monday nights to talk about our racial justice initiative that we are still very much doing. So if you are interested in working with Marianne and Crystal and Sierra on that, please join us on Monday nights as well. So are there any other questions? All right, well, for the good of the order, I'm going to call this conference/meeting adjourned. Thank you, everyone. Safe travels.